الخميس. ماشي، كان عندنا ايه بقى عشان ابقى عارف الخميس؟ طيب خلاص تنميه والتكسيشن. ماشي يا بس يلا سلام. يبقى حطيتهم كده، يبقى انا بصيت عليهم. ماشي، بص عليهم سوا.
Good afternoon, everybody. It gives me great pleasure to start our 9th Aging Spine and Injectable Therapeutic meeting. We were lucky in the past 8 years to have it in the non-COVID era, but today this is our first experience in the COVID era. We have a very eminent international speakers from all over the world. We have around 70 attendees plugged in up to now. During the coming 2 days, which will be like 4 webinars, every session will deal with all aspects of the aging spine, starting from radiology, physical medicine, and surgery. We have the first session, and we are glad to have our first speaker, Professor Baha Karana from Azhar University, and Dr. Baha is going to give his talk on the aging effect on the spine. Thank you, Professor Baha.
Thank you for inviting me, Professor Dr. Yusra Hawari, one of the eminent spine surgeons in Egypt, and thank you for the conference committee. My talk today, it is about aging effect on the spine. This is my content of my talk about introduction of the spine and aging effect. And we are speaking about the spine as a whole, this including the cervical, dorsal, and the lumbar, and the sacral. The aging is a spine affecting 2 things, either morphologic changes in the spine or biomechanical changes. Morphological changes can be subdivided into a bony, which is including the vertebral body and the facet joint, and soft tissues, which including the intervertebral disc, endoplate, and muscle and ligament. The biomechanical change, and we'll speak about how this change affected the biomechanical of the body. The stages of spine degeneration, every human tissues aging of the structural component in the spine and maybe related to either to genetic cells or exposure to the tissues to heavy mechanical forces through the life. This is an example of the aging spine and how it is affecting the intervertebral disc and the body. So the vertebral body, which is composed of 2 things, either trabecular and cortical bone. For the cortical bone, there is a decrease in the cortical thickness, which is important as a protective layer with high resistance to the bending and the torsion. For the trabecular bone, there will be a loss of the bone mineral density, thinning of the trabecular and increasing for intertrabecular space, and the loss of the conductivity between the trabecular and increase for anisotropia and increasing for axial load, and this will lead to increasing the risk of the fracture due to off-axis impact. This is an example of the decrease for structural strength due to reduced for apparent bone density, and this is a more porous cancellous bone appearance is the result of reducing for horizontal cross-linked structure. And the intervertebral disc is will be decreased in the protoglycans, and this due to loss of the water and replaced by collagen. And this will lead to dehydration and the stiffness of the annulus. And this is an example of what is happening in the degenerative intervertebral disc. The disc normally the vertical load will lead in the nucleus getting compressed and radiating outward. The nucleus pushed on the annulus from within. The annulus fibers are as intentions. But in degenerative, there is a big cracking in the annulus and leading to disc dislodging gradually from the vertebral rim and decrease for interdiscal pressure and alternating load transmission, and disc collapses and the height will be decreased. This is an example of the aging of the disc for young age until old age. And this is an example of degenerative disc between the 17 years old and 55 years old. The intervertebral disc space will decrease and affecting on the foramen, and this will lead to progressive stenosis and also development of the lumbar stenosis. What about the endoplate? The endoplate, there is a loss of the mineral density and will be leading to thinning of the endoplate And with ossification of the end plate increases the risk of end plate fracture due to nutritional and hydration of the intervertebral disc. Also, the facet joints, there will be disc degeneration. There will be an increase in the load affecting on the facet, and this will lead to arthritis. And this arthritis will be leading to ulceration, lesion of the articular cartilage with inflammatory and hypertrophy of the synovial membrane. This will lead to formation of osteophyte and also sclerosing of the subchondral bone with degeneration, active remodeling process, and stabilization of the joint, but loss of the mobility of the facet joint. This is an example of the facet joint affection and encroaching on the femoral canal. And this is an example in the CT and then the MRI. What about the muscle and the ligament? The function of the muscle and the ligament, all we know about the function and the moving and the stabilization of the bony. There will be increase in elastin collagen, and this increasing the cross length of the collagen, which will lead to decrease the strength and the elasticity of the ligament. And this will decrease the intervertebral disc height. Also, there will be the decrease in the tension of the ligamentum flavum, increasing in the thickening due to remodeling and folding of the ligamentum flavum, and this will be leading to spinal stenosis. And this is an example of the narrowing of the disc space by bulging of the annulus and compressing in the neural element. And this will lead to the aging spine canal stenosis. There is a classification for the fit arthropathies, which is good from grade 1 to grade 5, according to the size of the space. If it's 2 millimeter, it is a grade 1. If diminished, this is a facet space cannot be found. This means that it's a grade 4. About the muscles, there is a fatty degeneration in the muscle, which leads also the tendon itself become degenerative as a ligament, and decrease field forcing generation and degeneration of the sensory and end organs. This is a classification. It go from grade 0 to grade 4, which go from muscle tissues is not until there is a fat more than the muscle tissues, which is a grade 4. This is an example of aging of the muscles. What about the biomechanical changes? This is 5 things. We will speak about creep characteristic of the intervertebral disc, kinematic and compression strength of the vertebral body, strength and interdiscal pressure and loading shear. What about the creep characters of the intervertebral disc? It means that in the non-degenerative, there will be load. There is creep slowly, the vasoelasticity property, and regain back normal space. But in degenerative, there will be a load, and there will be deforming force faster. There will be attenuated decrease for shock absorption and uneven stress distribution. This is a diagram shows that temperature changes displacement of an intervertebral disc under the constant load. It will be the final displacement increasing and the rate of deformation increasing significantly, in particularly immediately after the load is applied. What about kinematic of the function spinal unit? In the non-degenerative, there will be axial load, and the small area of the posterior aspect of the function spinal unit will be affected. But in degenerative, the range of motion increase in the initial intervertebral disc degeneration, decrease in advanced intervertebral disc degeneration. There is spontaneous fusion and the instant axial of rotation with the range of motion due to the ligament and facet and intervertebral changing, leading to hypermobility or hypomobility or immobility or paradoxical motions. This is in the normal spinal unit, the instant center of the rotation, which is the cora. It is always in the posterior aspect. In cases of degenerative disc, the cora may vary over a wide area, even outside the spinal function unit. This is the cora, which it changes. The compressive strengthening of the vertebral bodies, there will be decrease in the bone mineral density, which leading to decrease the maximum compressive strength as the central region, and there is thinning of the cortical bone, and which lead increases the risk of vertebral fractures. There is also there will be anterior wedging of the vertebra, and this will lead to changing in the center of the gravity of this patient, and this will lead to forward deflection postural, and this will hard to compensate it by the muscle and the ligament alone. This will lead to the patient walking in flexion attitude. What about the stress and interdiscal pressure across the intervertebral disc? The nucleus dehydration occur and increasing the pressure on the annulus lead, and the loss of the height will lead to decrease in interdiscal pressure and a decrease in tension on the annulus, and loading transfer and compression through the annulus. This is an example. The nucleus carries a compressive load and the annulus the tensile strength. But in degenerative, the tensile strength, the tensile stress on the collagen fiber of the intact annulus become compressive stress and leading to more degeneration. This is a comparison of the stress profile between the normal and the degenerative disc. With the normal, there will be a platform, but in the degenerative disc will be spiky of the irregularity of the pressure on the intervertebral disc. This is an example about vertical and horizontal, with going from normal to mild to moderate and severe, with decrease in interdiscal pressure. What about load sharing? Increase compressive loading on the neural arch and the bone loss and hypertrophy in the facet and the varus interarticular. This will lead to loading distribution altered and changes, and they will lead to increase the loading on the annulus and the facet joint. And this is an example of between the normal and degenerative. In the neural arch, there's only the compressive loading share is about 80%, but in degenerative it's going to 40%. And the anterior vertebral body taking about 45%, but in degenerative it's going to 19% decrease. What about the clinical relevant about the aging spine? Also, we have what we call the spinal stenosis. We have osteoporotic compression fracture. We have degenerative spondylolisthesis and degenerative other scoliosis and developmental degenerative disc degenerations. And for this patient, you have for physical, looking for the posture, looking for the gait, and looking for the musculoskeletal range of motions. All the other spine deformity, which is the main topic, is always scoliosis or kyphosis or sagittal or coronal imbalance. Always use all modalities to help for this patient to reach the proper diagnosis and the proper management. And this is what we call the step ladder for the interference, for the going from conservative treatment, percutaneous disc surgery, open disc surgery, arthroplasty, and then go for fusion. How can physiotherapy help? You cannot treat the condition, but can treat its symptoms and avoid complication, maintain the physical and prevent it from worsening. After surgery, preventive physiotherapy is very important in aging spine. This is my reference, and at the end, I thank you for your attention. Thank you.
Thank you so much, Professor Baha, for your nice illustrative presentation, and we'll keep the discussion till the end of this webinar. And the next speaker will be Professor Dr. Muhammad Saadani, Professor of Geriatric Medicine at Ain Shams University. Professor Saadani will highlight the importance of having a team dealing with the geriatric people. And his talk will be Geriatric Surgical Patients, Why We Need a Team. Professor Muhammad, please deliver your talk. Thank you very much for being part of this.
Thanks for the invitation. Is it my screen is okay, Dr. Muhammad?
Maximize.
Yes, please okay. Go ahead. We can see it. Thank you.
Thanks for inviting me to this valuable session. I will talk about geriatric surgical patients and why we need to have a team. We know that we are living in an aging world, so and the proportion of elderly population are increasing. Between 2015 and 2050, the population of the older adult will nearly double from 12% to reach 22%. and the number of the elderly population is expected to reach 1.6 billion at the year 2050. Surgery in older adults. We say that geriatrics is every surgeon's specialty, or in other words, every surgeon should be a geriatrician by default, as 40% of all surgical procedures are performed in individuals older than 65 years, and 50% of patients over 65 years will require surgery during their lifetime. Of course, the geriatric patients have, in general, higher risk of perioperative complications, but this doesn't mean that a person should expect the worst when dealing with elderly patient, as age by itself is no longer an acceptable exclusion criteria for surgery, and surgeons should be aware of the potential issues facing older surgical patients so they can be able to prevent or decrease these possible complications. Of course, the benefit of any surgical procedure must be weighted against the expected risk. If we are aware of this possible risk, it will be essential to be aware of this risk. It is essential for take appropriate patient selection and to offer realistic expectation and to help in decision making by the patient themselves or by their families. We should involve the patient and family members in an informed discussion, weighting the risk benefits and if there is alternative to the planned procedure. And of course, discussion with the primary medical care provider or the geriatrician, or what we call co-management, should be done. And this co-management in the pre-operative period will certainly improve the overall quality of and the prognosis and the outcome. Of course, we know that there are some common expected post-operative complications when dealing with surgical patients that include delirium, pain, constipation, pneumonia, UTI, pulmonary embolism, and DVT, wound infection, and iatrogenic complications. We know that with aging, there will be physiological changes or age-associated physiological changes that involve most of the systems in our body, including cardiac system, respiratory system, endocrine system, renal system, hepatic, and others. And this, of course, can increase the surgical risk when dealing with our patients. So when dealing with geriatric patients, we should consider these age-related changes, presence of multiple comorbidity, presence of polypharmacy. We will assess functional status, nutritional status. We should concern the communication issue and the comprehension difficulty issues with dealing with elderly patients, presence of frailty and some social needs, of course. There is some specific perioperative risk consideration when dealing with geriatric patients, like cardiac complications, which is much important as heart disease in general is more prevalent among elderly patients. And about 25% to 30% of the perioperative mortality could be due to cardiac cause. Also, pulmonary complications is an important issue when dealing with surgical elderly patients, as 40% pulmonary complications are expected to happen, or pulmonary complications expected to happen in about 14% of older surgical patients that include atelectasis, pneumonia, respiratory failure, and others. So we should take detailed pulmonary history, and if there is a history of swallowing difficulties for our patients, so this can we can prepare ourselves to take certain interventions when dealing with this patient to decrease the possible pulmonary complications. Also, renal complication regarding, we know that with aging there will be progressive decline in the renal function, and this will be accelerated by if there's comorbidity like hypertension and diabetes. Older adults are more susceptible to complications like perioperative dehydration, hypovolemia, hypervolemia, changes or abnormality in electrolytes, especially with sodium level. Also, acute tubular necrosis and risk of medications or contrast toxicity. Also, infectious complications, that is a very important concern. And of course, the modifiable risk factor for this issue is surgical site infection, extended use of catheter or any device, prolonged use of ventilation, and prolonged length of stay in hospital. So, to be able to do good assessment for these surgical elderly patients, this will be done through what we call comprehensive geriatric assessment, which is a multidimensional interdisciplinary diagnostic process that assess the medical, psychological, functional capability of our elderly person, develop a coordinated, integrated plan of care for these patients. This comprehensive assessment will include assessment, including the complaint, clinical history, any medication, if there is nutritional status, if there is malnutrition or other, and also the balance and the mobility level of our patients, and psychological assessment of mental status, if there is dementia or cognitive impairment, and if there is depression, and of course this will affect our plan and assessment for a living arrangement for our patients. Or social assessment is important, if there is caregiver available or not, if there is good social support for the patient or not, and if there is caregiver stress or not. All this issue will affect the outcome of our patient and should be assessed. This assessment will be done through it is not one-man show. It should be done through a multidisciplinary team. Of course, the geriatrician is the leader for this team. As we said, cognition assessment is important, as we can detect if there is cognitive impairment or dementia or not. So we will know if our patient can take a decision or he is committed. And of course, if he has dementia, so there will be a higher risk of post-operative delirium. For this patient who lacking capacity or what we call non-competent, so we will depend on advanced directives and to take decisions through decision maker. And of course, if we know our patient is at risk of delirium, so we can implement some intervention in the perioperative time to decrease this possible occurrence of delirium. Also, screening of depression, as we said. Functional assessment is important for our patient because functional impairment in general could be considered as an index of severity of our diseases, and it can predict operative risk to some degree. So in some patients who have functional assessment, we may consider post-operative transitional care or admission to this patient to some rehab center or rehab unit or subacute care, so they can help in good recovery and rehabilitation of this patient. Nutritional assessment is important for our patient, as malnutrition is much prevalent among elderly people in general. It can reach between 40 to 50%. And so perioperative nutritional support should be given to this patient with malnutrition. Assessment of social support, as we said, is important because in general, older patients who have little family or social support, they will have expected to have prolonged recovery period. So perioperative evaluation for this social issue is important, and we can, depending on this assessment, we can plan to admit this patient in the post-operative time into subacute nursing care facility to helping in the recovery and rehab program. Assessment of frailty to our patient is important also, because we should know that frailty is not universal for all older patients, and it is a condition present in about 10%, and the frailty varies in severity. So it is not the same level for all patients, and the frailty state for a person is not static. It means that it can be made better or worse. Managing the medications, we said that our patients usually have polypharmacy, taking a lot of medication. So dealing with this much medications is an important issue in the perioperative time. Medication including antiplatelet, analgesic, non-steroidal, anticholinergic, benzodiazepines, diuretics, CNS medication, cardiac medication, anti-diabetic medication, either oral or if he is taking insulin. And if our patient are on chronic steroid exposure, these are important issues, should be managed well in the perioperative time. Regarding the perioperative laboratory testing, it was estimated that 2/3 of the laboratory tests that were requested pre-operatively are unnecessary, especially for the low-risk procedure. And asking for much investigation without actual need can make some problem, like increase the risk of false positive result, contributing to surgical delay for our patients and increasing the healthcare cost, of course, and put our patient at a higher level of unneeded anxiety. Of course, emergency surgery are associated with higher mortality rates in general, and our elderly patients are or sometimes presented late due to the atypical presentation of their symptoms, and diagnosis will be made to effort to optimize comorbidity before going to surgery. So if the time needed for optimize the patient result in better outcome and recovery for our patients. So to take message, aging is not a disease. Aging is a developmental process, and the elderly are different, so their assessment should be different. In general, geriatric patients have a higher risk of perioperative complications, but age alone is no longer an acceptable exclusion criteria for surgery. So a proper preoperative assessment in collaboration with geriatric medicine team will certainly affect positively regarding surgical outcome. Thank you.
Thank you very much, Professor Saadani, for this comprehensive lecture on geriatric assessment. Again, we have the session. I would like to introduce Professor of Radiology and Cambridge University's talk on diagnostic of spine disease and imaging.
First of all, I would like to thank the organizer committee to the diagnostic to osteoporosis is the most common metabolic bone disease. Over 50% of women and 30 to 45% of men over age of 50 have osteoporosis. It can result in devastating physical, psychological, psychosocial, and economic consequences, is often overlooked and undertreated. Osteoporosis means systemic skeletal disease characterized by low bone mass. In this X-ray image lateral for the lumbosacral vertebrae, we can see the syndicate protease with decreased bone density and multiple fractures. Also in this AB and lateral radiograph of dorsal spine, the same findings are seen. On magnified views, the trabeculae are reduced in number and the tunneling of the bone, cortical bone, is seen. Also here in the lateral view of dorsal spine, multiple fractures are seen. Coming to MRI, it has higher cost than conventional radiography, CT, and DEXA. Is time consuming also, but it has the advantage of absence of ionizing radiation. In the T1 weighted sequence is the most common or most important sequence to detect osteoporosis, as shown by heterogeneous signal intensity of the vertebrae, as here in this example of lumbosacral vertebrae. MRI is mainly used in differentiating benign from malignant vertebral fractures. Here in benign fracture usually affects the body of the vertebra with the sparing of the posterior neural arch Also, there is a low signal intensity line in both T1 and T2 weighted images are seen with mild retropulsion of the fractured vertebrae in contrast to malignant or neoplastic fractures. We can use quantitative MRI techniques such as diffusion weighted images and ADC. In the upper row is the benign fracture, and lower row it is a malignant fracture. This is in the malignant fracture there is evidence of diffusion restriction of the fractured vertebrae. MRI spectroscopy or MRS is considered as the MRI gold standard for bone marrow fat quantification. It is a new technique. By using it, fat fraction and fatty acid composition parameters can be determined. Here, in this example, the amount of fat as compared to the other metabolites are increasing with age, denoting osteoporosis. DEXA is now the most widely used technique for bone densiometry in research studies and in clinical diagnosis. It is used to assess bone mineral density in the lumbar spine L1 to L4, proximal femur, and distal radius. Here, measuring the bone density, mineral density in the lumbar vertebra from L1 to L4. The T-score is a comparison of a person's body bone density, person's bone density with that of a healthy 30 years old of the same sex. While the Z-score is a comparison of a person's bone density with that of an average person of the same age and sex. T-score rating system is if the T-score of the study is above -1, it is considered healthy. Is if it is -1, low bone density, between -1 and -2.5. Sorry, it is called osteopenia. Osteoporosis if less than -2.5. If it is less than -3, it is severe osteoporosis. To compare between using T-score versus Z-score, the T-score WHO diagnostic classification in postmenopausal women and men aged 50 and older. WHO classification with T-score cannot be applied to healthy premenopausal women or men under the age of 50 years and children, while Z-score is used in reporting bone mineral density in healthy premenopausal women and the men under age of 50 and also in children. Z-score of -2 or less is defined as below the expected range of age for age. However, while if it is above -2, it is within the expected range for age. Advantage of DEXA: patients receive extremely low dose of radiation. Scanning is rapid and scanners are widely available. But it also has some limitations, as DEXA measures are size-dependent, causing problems in assessment of grown children. Also, high-density materials such as aortic calcification and metallic prosthesis in the path of the DEXA X-ray beam is assumed to be bone, adding to the bone mineral density, and laminectomy would lead to underestimation of bone mineral density. An interval of more than 2 years between DEXA procedures is required to detect statistically significant changes, and during the assessment of the efficacy of therapeutic interventions, significant change in bone mineral density measured by DEXA might take 18 to 24 months to be achieved. In children, DEXA can be used to measure bone mineral density at the lumbar spine L1 to L4 and in the whole body except the head. The diagnosis of osteoporosis in children should not be made on the basis of densiometric criteria alone, but must also take into account relevant clinical history and physical factors such as short stature. This is an example of estimating using DEXA and estimating the bone mineral density in children. Quantitative CT yields volumetric 3D measurements by utilizing low-dose scan protocols on a standard CT scanner or special scanners. Advantages include separate analysis for cortical and trabecular bone not affected by deformities or high-density material. Yet, its limitations are higher costs than conventional radiography and DEXA, higher radiation dose, and needs complex analysis. Is accomplished or achieved by using a phantom to compare with the density of the bone. Quantitative ultrasound, the transmission of ultrasound of frequency range between 200 and 1.5 MHz through bone tissue reflects its density and its structure. The two main parameters measured in quantitative ultrasound are broadband ultrasound attenuation in decibel per megahertz and the speed of sound in meters per second. The advantage of ultrasound as it is cheap, fast, and safe, yet it lacks comparable sensitivity. The ideal bones to be measured are the This is an example of the machine for measuring quantitative ultrasound. Different parameters are used by different machines. To summarize, osteoporosis is a common metabolic bone disease with serious medical, psychological, social, and economic consequences. Imaging plays an important role in screening, diagnosis, follow-up of osteoporosis, as well as differentiating osteoporotic fractures from malignant ones. Thank you.
Thank you. Now we will shift for next speaker. It's my pleasure to introduce Professor Ahmed Hussein, a professor of psychiatric Qasr Al-Aini, and he is going to deliver his talk about preoperative geriatric psychological problems. Welcome.
Is my voice clear? Is my voice clear?
Yeah.
Yes, Dr. Ahmed, we can hear your voice, but please share your screen.
Okay. Yeah, sorry. It's well known that psychological problems and psychiatric disorder is common in elderly patients. And actually,
please share your screen, Dr. Ahmed.
I'm sharing it. Is it not appear?
حضرتك open the presentation on your desktop, and when sharing the screen, press share screen, the green button, and select the presentation.
Okay. Okay.
Yes.
What happened? Okay. Thank you. It's well known that psychological problem and psychiatric disorder is common in elderly patients. Today we will discuss depression and cognitive impairment and its influence on
احمد بس احنا شايفين بس دكتور احمد حضرتك سامعني؟ احنا شايفين بس السكرين بروتوكول بس مش شايفين البرزنتيشن نفسها.
حضرتك انا صورتي بس اللي حبان.
يعني ما فيش برزنتيشن يا دكتور؟
ما فيش سلايد، لا سوري ما فيش سلايد.
مش شايفين البرزنتيشن.
اوكي
اوكي يعني حضرتك تشرح بس كده.
اوكي تمام. هنتكلم النهارده عن الديبريشن والكوجنيتيف امبيرمنت mainly، وهنتكلم كمان عن we will talk also about anxiety and delirium and chronic pain syndrome. Actually depression is common in elderly patients and has a great influence and has a great influence on outcome and prognosis of spinal surgery. The prevalence of depression in elderly patients ranges from 10% to 20% of people, and in some study it may reach up to 30% above age of 70. The most common symptoms of depression in elderly people is sadness, with lack of energy, with loss of interest, death wish. Most people of depressed in elderly age, they are didn't interest in management, and most of the time they are waiting for death. So they didn't give us reliable information about their somatic complaint or psychological complaint, and this is a great problem even for psychiatrists or special psychiatrists. And also, they had a lot of problem in appetite and in compliance of medication, whether pre-operative or post-operative. Helplessness and hopelessness in this patient makes their remission so slow and so difficult. Actually, they are neglecting personal care and the not compliance on medication. It's important to know that causes of depression in elderly patients is highly variant, and it ranges from biological depression and associated illnesses such as vascular disorder, stroke, heart disease, Parkinsonism, and diabetes mellitus. Also, a lot of medication that used to treat physical condition in geriatric people may cause depression, such as hypertension medication, beta blockers, with high cholesterol drugs, and even tranquilizers, with calcium channel blocker, with steroids, with ulcer medication. So they are highly vulnerable to have depressed mood and depressive symptoms. The influence of depression in elderly patients post-operatively mainly about compliance and the ambulance. They have reduced energy, great reduce in energy. So they have a great tendency to stay in bed. And this has caused a lot of complication in post-operative cases and in post-operative condition. And usually they are not compliant on medication. And we have to be highly aware about this. Second problem or second psychological disorder we will talk about is cognitive impairment. And cognitive impairment is common in elderly patients. Actually, it started about 50 years old, and it gets slightly progressive with age. And we have to know that cognitive impairment is different from dementia. Cognitive impairment has unrecognized symptoms. But people with cognitive impairment usually have memory loss and impaired judgment, so they are unable to make a right decision in right time. And also they have poor motor coordination and may show some confusion. These people cannot give us valid, reliable information about their condition. And mostly, they cannot make a proper decision in a proper time. Post-operatively, they are more susceptible to confusion. And so they are more susceptible to non-compliance of medication, and guidance of post-operative care. And we have to know that cognitive impairment is totally different from dementia. Cognitive impairment is common up to 20% in elderly people, and we can consider it as the first process of dementia. Dementia is more advanced condition of cognitive impairment, and demented people mostly have fragmented personality, while cognitive impairment still has intact personality, but they have a problem in memory and judgment and decision making. Causes of cognitive impairment mostly vascular and normal aging process, but it's highly important to make a screening for these people before operation, just to predict the presence of any cognitive impairment that could affect post-operative care. And people with cognitive impairment is most vulnerable to develop delirium, whether pre-operative or post-operative. And as we know, that delirium is a medical emergency condition that may occur after surgery. Actually, delirium has a wide variety of etiology. In our discussion, we have to focus on pain. Pain by itself in elderly people can cause delirium. And in cases of spinal surgery and in cases of spinal pathology, usually we have to use a lot of medication that by itself, it causes delirium easily in geriatric people. Muscle relaxant, painkiller, and patient with delirium is at high risk of post-operative complication because they are disoriented and have a great imbalance, and also are highly agitated people. Delirium may be due to wound infection in post-operative, can cause delirium. Dehydration can cause delirium, and also pain and sleep disturbance in post-operative time in elderly patients can cause delirium. Here I want also to discuss two important disorders. I know that a lot of surgeons may face it, pre-operative and post-operative, and they are common also in elderly people. One of them is chronic pain syndrome. Chronic pain syndrome, the pain all the time, complain from somatic pain without physical cause or without definite physical cause. In our practice, we consider it some variant of depression or anxiety. And I know that you have all of them, or most of our professors in surgery met a lot of people with repeated physical consultation, trying to find a cause of pain. Actually, this is variant of depression. In post-operative, pain could be persistent and without treatment because it must be treated as depression. The second disorder that we may meet is somatization. Somatization is physical complaint. Okay? It could be multiple, pre-operative or post-operative, and it's also considered as a variant of depression. The most important thing I wanted to mention here that it will affect both subjective information that we can get it from the patient pre-operative, and the compliance on medication and compliance of post-operative instruction, and it may cause a great influence on the health condition of the patient. So it's better to make pre-operative screening for cognitive impairment, depression, and anxiety, and to make follow-up and psychological care in detected cases post-operatively. Thank you, and it's nice to meet you.
Thank you very much, Professor Ahmed. Great talk, and really we face this a lot in everyday practice, the psychology of the elderly. And I'm sure there will be a lot of questions at the end of the session. Please allow me to introduce my great friend, Dr. Khalid Batarji, the founder of the Batarji Saudi German Hospital and the Batarji University. Dr. Khalid has been our guest speaker for the past 8 meetings, and would like to have him online. Dr. Khalid, are you in?
I am in. I'm trying to get in for the past 15 minutes. Just give me 1 second.
Okay.
So then I will show you my face.
Okay. Alice is going to give his talk on percutaneous vertebroplasty technique and complications. Alice, please go ahead.
Thank you very much, Jose, and the whole team. I'm really glad to present my talk about the percutaneous vertebroplasty. In general, this vertebroplasty is known to everybody, but I will concentrate the content of my talk to the indications and the contraindications, the procedure itself. I just want to elaborate more on the complications, whether it is a mild complication, moderate, major, and late complication, and prophylactic vertebroplasty, which is actually becoming more popular in our area. Next. Everybody knows the vertebroplasty is a procedure, it's a percutaneous procedure. It's used a specialized bone cement injected in the cancellous bone cavity of a painful fractured or weakened vertebral body in order to obtain pain relief. So the main issue of the vertebroplasty is a pain relief, but also strengthening and restoring the mechanical stability of the vertebra. Next, please. So we see the indication for the vertebroplasty is the osteoporotic fracture. This is the main indication for the vertebroplasty in our departments. And everybody knows that when an osteoporotic vertebral fracture occurred, most probably after a while, if it is not treated properly, after a while, a second level fracture can happen in the adjacent level. So it is better to treat these fractures seriously from the beginning. Otherwise, the patient will develop more kyphotic because of the imbalance of the spine. Next.
ازيك عامل ايه؟ كلكم كويسين؟
مين دخل علينا كده؟ Also the indication, this was the first indication for the vertebroplasty was the hemangioma. If the hemangioma considered to be painful, then it is a good indication for the vertebroplasty. Otherwise, it is not really indicated. Next. Now, spinal tumors, in particular metastasis, and I have lived many sessions with our friends, Dr. Majdi, I think in America. He is doing a lot of metastasis, painful metastasis, even if it is a palliative treatment, but it gives the patient really relief from the pain of the metastasis. Next. You can see here that also multiple myeloma is a good indication for the vertebroplasty because it gives also a pain relief and it avoids pathological fractures. Next. Now, when we talk about contraindication, I have seen the previous speaker, Dr. Mohammed Hussein. He was, I think, really elaborating about the conditions of the patients, geriatric patients that contraindicated for the vertebroplasty. Patients with depressions or patients with deliriums and patients with with fractures that been kept for a longer period, and patients with bleeding tendency. These are, or patients with neurological deficit. These are patients who are contraindicated for the vertebroplasty. In pregnant women, definitely, it is one of the contraindications. Next. Now, everybody knows the procedure is a very simple procedure. I just want to show you some pictures. Next. So everybody, it's very important to understand that the time between the fracture occurrence and the initial consultation should be not too long. It should be, the vertebroplasty should be done either in the acute stage or 1 week, 2 weeks, up to 3 weeks. It can be done. Otherwise, the healing process, or what you say, the vertebra plana will occur, and the treatment will be, or the indication for vertebroplasty will be then obsolete. Next. The patient is positioned. We do it. It has been many times mentioned that in the literature about local anesthesia. I really don't believe in local anesthesia in elderly patients. They are usually not comfortable with and their compliance also is not really, they are not compliant. So it is better for me to do it under general anesthesia in prone positions. This is the procedure that we are usually doing it in our institutions. Next. As you know, you have just to identify the pedicle under the image, and with the Jimji needle, you go through the pedicle eye. Next. And you come with the Jimji needle up to the 50% of the vertebra, and then you pull it up, and then you put the tube for the bone cement, and then you inject the bone cement, either bilaterally or unilaterally, as it requires. Next. It is important that you leave the bone cement until it becomes like a semi-solid, so the injection, or it does not go in the leakage. This is a very important issue, and I will discuss this in the complication sessions. Next. As I said, you can inject unilaterally or bilaterally, as indicated in the in the case that you are treating. Next. After it is finished, you can do it one level, multiple levels, and then you remove the cannula and just simple suturing or plaster over the wound. Next. Now, when we talk the complications, usually the complications are infrequent, but when it happens, it is very, very serious. We can modify or classify the medication in multiple levels. Next. if we can see that in mild complications, about temporary increase in the pain during the procedure or after the procedure. Also, the transient arterial hypotension is not very common, but it can happen. Next. Interdistal cement leak, this is something that should be really considered, that cement leak, when it comes to in the above or lower disc, it can lead to late complications, because it can lead to adjacent level fracture due to the high viscosity and the high intensity of the bone cement itself after it is hardened. Next. An incomplete relief of the pain. Most of these geriatric patients, they are at the beginning they feel better, but by time they feel the pain coming from the general or osteoporotic of the spine. Next, please. Then when it comes to the moderate complications, we have the infection. I have not seen myself an infection in the vertebroplasty, but it can happen because of the, let's say, how you sterilize the area for your procedure, but it can happen. Next. This is a foraminal cement leak. It happens with me. I said once, but I will never forget this patient. Post-operatively, the patient became not complete paraplegic, but there was weakness, and I have done a CT scan at once. This is very important that the CT scan should be done. You don't wait until next day. You do the CT scan, and then I have to go and do a laminectomy and remove the bone cement. It was through the pedicle. There was a leakage from the bone cement through the pedicle, and it came into the canal over the root, and the patient was weak. She had even bilateral weakness because the amount of bone cement was in the canal, and it was compressing the cord. So I had to remove it, and it was a sweating procedure. I have to admit this. Next. This is just, as I said, you have to do the CT scan. MRI will not help in this type of complication. So CT scan is to confirm the presence of the leakage where it goes. Then you have to approach it and remove it. This is the best management of something like this. Next. This is just a presentation of a patient that it became to. I have not seen this complication, the epidural cement leakage. It has been reported in the literature, and the patient definitely they become paraplegic, and this is a disastrous complications. Next. Next. We have also seen the misplaced needle in the tracts. This could be seen on this CT scan of thoracic spine patients, 79 years old woman. She went to vertebroplasty. The colleague who has done this procedure has tried multiple times through the pedicle, and it went up and have this, as you see, the misplace of the needle. Rib fractures can happen if you use force and you misplace the needle. It can happen that sometimes the head of the rib can fracture during the procedures. Next. The exothermic damage of the spinal cord due to but this is not anymore a complication that we see because the bone cement, the quality of the bone cement has been changed. The bone cement is now a low viscosity with a low temperature. So this is not, the radiation hazard to the patient and the staff is very common. Next. Bleeding, it can happen, it's a minor bleeding from either from venous plexus or sometimes A small arterial from the pedicle can bleed due to the multiple insertion of the needle or positioning of the needle. Next. As I said, this complication, a major complication, I have not seen this, but it's been reported, the intravenous cement leak or cement embolism. This is something I have not seen it, but it's reported. Next. Also the cement dislodgement. I have seen this case and I want to present it. This is a 70-year-old woman that had severe back pain for 2 months. Then the pain started after the fall during after that. Then the pain was bearable at the beginning, but then becoming worsened by time. On admission, she had a severe back pain, and we have seen there was fractured vertebra at L4, and then we have decided to go for vertebroplasty. Next. So we have done these procedures and performed in the L4, and the patient left the hospital. Here is saying 7 days, but it should be 1 day. The next day she left the hospital and she was doing fine up to 6 months. After the 6 months of the surgery, next, you could see that there was the bone cement, and the collapsing is more, and the bone cement is dislodged anteriorly. And on the lower images, you could see there was a peak from the bone cement compressing the aorta, which was very dangerous. And you could see that on the flexion extension view, it's still unstable fracture, and we have asked the patient to go for surgery and to stabilize the spine, but she refused. And she did not complain of these complications. Next. As I said, it can happen also the refracture after the vertebroplasty, and this is now the issue that I want really to open also for discussions. The adjacent level usually happen if you only inject one vertebra and you leave the vertebra above or below. It can happen that there is a fracture on the above vertebra due to the high the high viscosity of the bone cement that can lead to a fracture above the vertebra, the treated vertebra. And in my patients, I do usually one vertebra above and one vertebra below to avoid a refracture of the above vertebra. Next. So this is one of the major complications that happens. As I said, the fracture of adjacent level, and therefore I have seen an incidence, an increased incidence of such patients with fracture of the adjacent level. Next. Next one, please. Yeah, this is also the 96-year-old female with hypertensive and diabetes. She has a fracture at T11 and 12 and L1. Next. And you could see there was underwent the vertebroplasty from T11 to L1. Next. But 17 days after the surgery, the patient complained of low back pain, and the MRI shows a new vertebral body fracture in L2. And the patient did not agree for another session of vertebroplasty because she did not have major complaints, but she will definitely, we have explained to her that she will go in kyphosis, and most probably an adjacent level will fracture by time. Next. And this is where I say the prophylactic vertebroplasty is considered now a safe and efficient procedure for treating osteoporotic vertebral compression fracture. But in my experience, adjacent vertebral fracture remains one of the most common complication of vertebroplasty, and therefore I do recommend that prophylactic vertebroplasty to be done by such patients. I think I finished. Next. Yeah, next. This is just showing the same patients with the vertebroplasty. Next. An adjacent level. Okay, next, please. So in conclusion, I would say that the vertebroplasty has been accepted by physicians and spine surgeons and needed and welcome therapy for painful compression fracture of the spine. And it's been settled in the spine community. It is now becoming the standard of care for such patients with osteoporotic compression fractures. Vertebroplasty is a simple procedure. It can often be performed on the outpatient basis if the patient compliance. Pain relief has been high and also risk when performed by experienced physicians who exercise good setup. With the growing experience, we have seen that we were able to tackle and treat successfully more complex cases and expand the utility of this procedure. Sometimes in severe osteoporotic, you might need to do the prophylactic vertebroplasty into non-fractured adjacent vertebra to decrease the incidence of adjacent level complications. Thank you very much.
Thank you so much, Dr. Khaled, for your nice presentation, and you really highlighted some important issues which we can discuss with our panel. Professor Hawari, what about regarding injecting the nearby vertebrae at the index surgery? Do you practice the same as Dr. Khaled?
I think it's a good point because we always regret not doing it. So I think by doing it, just putting 2 millimeters, just 2 centimeters of cement in the level above and below, especially in high-risk patients with the osteoporosis high and the middle of kyphosis, because we know that eventually they will get fractured. So I think this is a good practice, and I accept it.
Dr. Bahat?
Here is a very important point about prophylactic vertebroplasty. And if we have a patient with impending fracture, I think we have to make a criteria. Like now we have a prophylactic fixation of the bone. So we have something in the future. I think we have to study this, and we can make as a prophylactic in the future. We can make a criteria for this patient and who is suitable for prophylactic fixation. I think this is a very important point in the future.
If I may say that I do the prophylactic vertebroplasty if the BMD score is less than the 3, because I am afraid of the leakage. So this is only my criteria, and I have mentioned this in my. So the criteria is the BMD.
In DEXA, a lot of fallacies, especially if you take an AB views or post anterior, because this patient has an atherosclerosis and sometimes missing. But we have to stress that this patient has to make the DEXA on the lateral aspect. So to exclude the calcification of the osteophyte and this, so we can rely on lateral DEXA, not on the AB DEXA. We're very important.
Good point. Good point. I have to consider this. Shukran, Dr. Shukran.
I have one comment. Professor Targi, I think we have to consider also the interosseous pressure during vertebroplasty, because this leakage is always going because we are injected both needle in the same time. So I think if we are going to do this, we do this practice, put another needle on the other one, and then distract the needle, So the intraosseous pressure will decrease and then injected the other needle by the bone cement. I think this will give you a lot of disparity of the cement in the vertebra and prevent any leakage from what we called any leakage or increase in intraosseous pressure, which lead to embolism or something like other complication.
It's a good point. It's a very good point, because most of the surgeon, what I have seen, even with myself, that we want to use the cement on time because it before it gets hard. So we inject both together, and this is could be the reason for the leakage.
I think Dr. Mohammed.
Me and Professor Gamal Baroud has invented like a technique in which we do a lavage from the other needle. So we do lavage from the other needle by saline. So we'll wash out the vertebrae, so it will get more cement, and the cement will go into the trabeculae. And also in cases of tumor, when you do this, you will prevent tumor from going into the circulation. And I think Professor Gamal is in the process of reporting this in the literature.
Mm-hmm. Good.
Thank you so much, Professor Batargi, for your nice talk. And may I highlight also the role of kyphoplasty to create voids that decrease the incidence of leak. And also it is important that to avoid such complication is properly choose your patient well and select the proper technique for application of the cement inside the vertebrae. Plus, don't forget to treat the osteoporosis to avoid the further fractures. Treat the osteoporosis after doing the vertebroplasty for the recent fracture. And the last speaker for this first webinar is our chairperson, Professor Dr. Yusr Al-Hawari, the chairman of the Egyptian Scoliosis Society, and he will deliver a talk regarding how to build a good practice in spine surgery. Professor Yusr.
Thank you. Hello, everybody. Since we are talking about the aging spine, and since I'm aging, so I think I have the criteria to tell you my experience into how to build a good spinal practice.
بلاش تقول الكلام ده يسر خلاص.
So what was my experience? I've started the spine surgery in 1981. So it's coming to 40 years. I've graduated from Cairo University. I've trained there, and then I went to the UK as a spinal fellow in Oswestry. I've started the first spinal center in the Middle East in the Nasser Institute. I am consulted in spine surgeon in Yemen, Saudi Arabia, United Arab Emirates, and Bahrain. And all of this, one side, the most important things which makes me deliver this lecture, that I'm the VIP taxpayer. I don't pay my taxes with my colleagues of doctors. I pay them separately with the most famous constructors and factory owners in Egypt. So this makes me, I think, by the country a VIP spine surgeon. So the first thing is to have an outstanding bedside manners. So you should be patient. From quarter of an hour to half an hour. So try to be patient during that. If you lose your patient, really you will regret it. So the first bedside manner is patience. You should keep eye contact with your patient the whole encounter. You should show empathy. Empathy is an active sympathy. You just not be sympathetic, but you should be empathetic. And you should be very professional. You should not cross borders. You should not do anything except what you are good at, your profession. You should honor the patient privacy. I remember there were two doctors talking in the lift in one of the New York hospitals, and one was telling the other that the famous soprano singer has been admitted. And somebody overheard the conversation and then went to the press and released this, and it was a scandal because this singer didn't want anybody to know that he's in hospital. So you should really honor the privacy. And you're a surgeon, you're a physician, and the patient is the patient. There's no cross lines. And again, you should be very confidential in what you know about your patient. And you should show respect to the patient age, the patient gender, religion. I remember I was doing a scoliosis case in a case of Jehovah's Witness in UK, and the parents didn't want their child to have blood transfusion. And I really was sarcastic about that, and I told them, how would you leave your child to die? But that's the religion, that's the relief, and you have to respect this. You have to respect the culture. You are an area of multi-cultures, and every tribe, every country has their culture. You have to respect that. You have to respect very much your colleagues. And again, you have to respect yourself and respect the terms of Allah. You should have a mentor. You should have a mentorship program. So you should find a mentor, as many as you can, not necessarily on site. You can have a mentor in the other side of the hemisphere, not necessarily at your workplace. You should be always grateful to your teachers, and then you will be a mentor for your other colleagues or junior staff. The mentoring program is a route to success. You should a mentor can give you direction, can coaching. There is no team without a coach. Can give you support, can set you a goal, can train you, can motivate you, and can advise you. And all this will lead to success. Workplace is very important, and you have to love your workspace. And because you cannot go to a place you don't like every day, and then you are expected to perform. And I was glad that I was trained in the Qasr Aini Hospital, one of the biggest training centers in the area. And one of my mentors was Professor Hussein Al-Fattah. He was a great mentor who taught me the orthopedic, how to approach patients and how to be really very kind to our patients. And then comes Professor Ahmed Abdelaziz, who has sent me, allowed me to go to UK to do my spine training there. John O'Brien was my first spine teacher. He was in Oswestry. He was called Jack the Back, and he was very famous of introducing the anterior spine surgery in Europe. And he was the inventor of the Oswestry Disability Index, the ODI. During our stay in UK, we had a lot of mentors coming over. The doctor in the middle is Dr. Cloward, the famous Dr. Cloward of cervical surgery and the PLIF. He was the inventor of the PLIF. He came over, stayed for 2 weeks, and trained us to do the anterior cervical decompression fusion and PLIF. So a great man. Professor Maher Halawa from UK, Dr. Kamal Ibrahim, past president of SRS, and Dr. Arthur Steffi, the father of modern spine surgery. All of these mentors really have changed my life, and I am very grateful to them. You should construct a team, win yourself more eyes and hands and ears, pick the best or make them to be the best, invest in your team, they will be the future experts. This was the first generation of spinal fellows work for me, and all of them are now the most famous spine surgeons, starting from the right, Professor Ehab Amran, Professor Ehab Hussein, Professor Yasser Mirigi, Chris Weatherly, Hussam Salah, Ashraf Ambar, and Walid Silmi. All are very famous spine surgeons at present. This is my fourth generation spine team, and I call them the A team. It's not only time management, it's also energy management. You have a limited 24 hours a day and you have a limited strength. So always manage your time and energy. In our area, tasks takes longer time to do. There's a lot of traffic which can make you late. You attend to the patient and also attend to the relatives. So there are tips which I use to help me to define my time and energy. Like we start early in the morning. I start my clinic 7:30 in the morning, so before the traffic, before the anything which can make me delayed. You should have a teamwork. You should have multiple examination rooms, because usually it takes a long time for the patient to leave the room. So you should leave it early before the patient does. That's why that's where you can save you more time. And you should have 2 operating rooms, because any long surgery which we do needs like an hour to close up. And by that time you can start another case. Then you should care to train, insist to train. You should do continuous training program for yourself, the medics and paramedics. And really, this is the lifetime investment you do. And you should market yourself. How do you market yourself? You market yourself by attending most meetings, present interesting cases, be courteous to your colleagues, create patient groups to exchange and share experience on the social media. And in the media, you should say and what you really believe, and you say, and you should be honest in what you say. And don't be like this doctor who is advertising himself like an expert in sitting with the patient till he dies. So you should be ahead of the doctor. So you should learn to recover from stress. There are 7 ways to build your resilience or to recover from stress. By sleeping, you should sleep 7 hours a day. If you cannot do that, you should, during the day, have like 15 to 20 minutes mini naps. And if you want to learn more about sleep, you should go to understandingsleep.org. You should exercise at least 3 times a week, 25 minutes per week, everybody. You can go to everybodywalk.org and learn more. Relaxation, you should choose to relax with fun, and there's many programs for that, like headspace.com. Nutrition, you should eat well, not too much, and mostly plants. And you should limit your hyper-connected state, and it's called digital detox. You should be less at your phone, be less at your computer, and try to give yourself away from electronics. You should be a positive physician, surgeon. You should show gratitude and random acts of kindness. And you should be surrounded by vitamin F, which is friends and family. You should be cost effective. There's nothing called all for all. Every patient, as we heard earlier from Dr. Mohammed Saaden, not all investigation to be done for the elderly. You choose what you need. You should, and there is, even if the patient is not paying for this investigation, somebody is paying for it. ما فيش حاجة ببلاش حتى رباط الشاش. For example, not all the pharmacists need MRI. You should budget the surgery. And in our area, patient would like one surgery. They don't like fractionated surgery. I know that magic rods is in fashion, but you know that a price of a magic rod can build this rural hospital. So you have to choose for yourself, for the country, for the community, whether this really, the patient really needs this fantastic, very expensive procedures or not. You should prevent surgical site infection. It's your duty and responsibility. You should do a patient screening and preparation before the surgery. Even a betadine or a happy scrub shower before the surgery. You should choose clean theaters to work in. You should enforce discipline. You should use pulse lavage in long surgeries. And before you finish, you should do a betadine lavage and vancomycin powder 1 gram. This reduces infection by 10 times. You should always avoid litigation. How do you do that? Communication is the key. You should discuss potential complications pre-operative. You should follow your complications. Don't just hide your head. I don't deserve it unless the patient is satisfied. This should be your rule. Provide the time and finance for complication, and the patient forgive you our mistakes, but they won't forgive you if you think you don't care. And in your clinic, you should develop the practice. You should have the A practice, which needs 3 A's. It should be available. You should be affable. Affable is nice and kind, and you should be able. And by the affability, and ability, you will have a good clinic. So the take-home pearls are: you should have a good bedside manners. You should show respect to everything. You should have a mentorship. You should construct a team. You should train yourself and train the others. Manage your time and energy, and you should learn how to recover from stress. And you should do a good marketing for yourself. You should be cost efficient for the patient and the community. You should prevent surgical site infection. You should avoid litigation, and you should have the 3 A's: availability, affability, and ability. And thank you for your time.
Thank you so much, Professor Hawari, for your nice talk. And I'd like to ask the attendees if anyone has questions, please write it and we'll answer it either live or write it.
في بقية للتوك
محمد
في بقية لسه
في بقية للتوك.
في كم سلايد عشان نبعض في البرزنتيشن الجديدة.
Maybe I ask Dr. Gamal Baroud to unmute himself. Dr. Gamal Baroud used for a long time, and he's used to be a co-chair as well this year. Dr. Gamal Baroud from Canada, due to the COVID-19 lockdown, he couldn't be physically with us. Dr. Gamal Baroud, would you like to comment and give us updated data regarding the vertebroplasty and the injectables? Dr. Gamal.
Yes, Dr. Mohammed, good afternoon to everybody. It's a great pleasure.
Good afternoon.
Good afternoon, Dr. Yusra, and good afternoon to everybody. I miss really being with you.
منور يا جمال.
تسلم يا حبيبي, تسلم. I have a question to the presentation of Dr. Khalid, and maybe it's a comment as well. Dr. Khalid, are you listening?
Yes, I'm with you.
Yes. Good. The issue of adjacent damage or adjacent fracture is not
لو تعلي صوتك شوية لأنه أنا قاعد هنا في منطقة شوية. تفضل.
The issue of adjacent damage is not, or adjacent fracture is not a new issue. So it has been already reported in 2002, 2003. And I already reported an article in the Radiology Journal in 2003, which referred to the amount of filling. We should not try to fill or to completely fill the vertebra. If you try to fill the vertebra with a lot of cement, you naturally make the vertebra itself, you treat very rigid. And by itself, it will increase, it will change the mechanics, and it will increase the risk of adjacent level fracture, which already, as Dr. Baha said, may have an onset, a light onset of a fracture. So I think we have to be careful how much cement we put in a vertebra. Not as much, not a complete filling, but as much as needed depending on the vertebra. So I think overall we have to be cautious how much cement we put in the vertebra itself.
Dr. Jamal, may I question?
Yes.
What is as much? And this is a relative word. When you say as much, do I have to inject half of the vertebra? I'm usually injecting as I see the pressure. If the pressure allows me through my hand grip, then the cement will go automatically in the vertebra. So I cannot judge intraoperative whether I am filling the whole vertebra or I'm filling half of the vertebra.
But
where should I stop? Where should I stop?
Exactly, you stop when you get satisfied with the filling. Not you see here. It's not the cement that decide how much you fill. I think the overall consensus is around 5 cc in the lumbar region. This is what is usually the consensus, and in other region less than that. If you continue to inject, the likelihood of leakage will increase as well. So you are dealing with two complications, intraoperatively and postoperatively as well. So I think 5 cc. This is what is being consensus at this point of time, but also targeted vertebroplasty in the region where you see the fracture as well. Where you see the fracture line, where you see the edema, this is the targeted area. So the idea is not to fill the vertebra completely, but rather go with a targeted vertebroplasty.
برضو حداخل معاك شوية معليش أغلس عليك. Your American patients is not our Asian patients. Usually the Americans, or let's say the European in general, their vertebra is very large. We have here small creatures, our mothers and grandmothers. They are very small. So a 5 cc might be too much for a vertebra in our region. So how can I judge? Is it 3 cc or 5 cc or 2 cc? It is a very delicate question. Whether we should stop by 2 or 3, I don't know.
Absolutely. But then the point we should, the basic idea, we try to avoid overfilling. We do as much, as we see distribute finely. And I think Dr. Baha and Dr. Yusri made a very good point. You see, when you have the collateral side open, it will take the intravertebral pressure away. So this way, you will be able to inject under low pressure in the vertebra, and as such, potentially decrease the risk of the leakage, but also the issue of displacing all of the soft tissue into the cardiovascular system and adjacent level. So if you inject, if you have the tendency to fill, I think it will be a very good idea to open up the collateral side.
If I may, so if I go out of this meeting today, I will go with this idea of opening both sides and inject and leave the other portal open, so the interosseous pressure is definitely less. So I thank Dr. Baha and Dr. Yusri for this idea.
And Gamal, I think to have a criteria for prophylactic injection, as Professor Baha mentioned, I think it's a good thing. Can we start on having defining some criteria? For example, like the DEXA, is it in the middle of the curve or not? And I think we can get a good criteria for a prophylactic injection. What do you think?
I think that the basic criteria is real osteoporosis. I like the idea. I like the idea of doing the prophylaxis. Hopefully, it can be done with advanced materials soon. Materials that resolve. But I think one of the criteria for prophylaxis is some of what Dr. Khalid reported. Dr. Khalid reported like leakage into the disc. Okay, and when you have leakage into the disc, that criteria is osteoporosis and second probably could be morphological, like more the gravity and the kyphosis. Number two could be also you see when you have cement leakage in the IV disc. This could potentially change the biomechanics. I think it's another reason why you would consider prophylactic as well.
May I suggest that Dr. Khattab communicate with me so we can put the criteria, me and him and my team, and then submit it to Yusri for his review and Dr. Jamal. What do you think?
I think it's a good idea.
Okay, look, this is a great idea.
There is a nice paper mentioned about the cortical bone, and they measure it in different levels in the vertebra itself, and they make a criteria for that, and we can take it as a baseline.
Good idea.
1 millimeter, 2 millimeter, 3 millimeter from up to down in one vertebra. And the cortical thickness, if it is go for less than, this is mean that the fracture is bending fracture can be okay.
Thank you, everybody. And to close this session, I would like to thank Novartis for sponsoring that webinar. And on their behalf, I'm going to present a trial they've done in Egypt. It's an open label trial on arthrophast. It's okay. Okay. So in treating any painful condition, acute painful condition, what's your target? Your target is to relieve the pain with an effective analgesic and anti-inflammatory. It should have a rapid onset with a short half-life, and it should give a 24-hour control, and it should be tolerable. And arthrophast has got this technology. It has got a layer like a topping of a cake, which is very fast, so it will act rapidly, and then the rest of the pill will have a slow release. And there was a study done by in Egypt on arthrophast efficacy and safety in acute painful attacks of chronic rheumatic disorders called the aerospace trial. It was published in the JAMA, and the objective was to assess the efficacy and safety of arthrophast 150 milligram orally daily. And the study design was a multi-center, open-label, non-controlled study. And it was done on 1,724 Egyptian patients. So it was found that the efficacy of ultrafast is 65% in reducing acute pain over 2 weeks, and a 66% reduction in the limitation of daily activities, and 76% in improvement of the joint tenderness. And after 2 weeks, 8 out of the 10 of the patient had relief of their initial swelling, and 9 out of 10 showed that they were better after 2 weeks. And it was safe. 87% of the patient had no adverse side effects. So it's taken once daily. It has a short term of action, and it can be used for 2 weeks in the acute painful conditions. Thank you very much.
Thank you so much, Professor Hawari, for this, and we would like to thank Novartis for sponsoring this webinar. And I think this is the end of the first webinar, and we'll have 10 minutes rest. Then we'll continue with the second webinar. It will be osteoporotic spine in collaboration with the Egyptian Spine Association. And we'll be happy to have Professor Hussein Abou Ghait, the Dean of Faculty of Medicine, Azhar University, with us. Dr. Sharif Al-Ghamri moderating the next session. And it will be as well by the help of some distinguished faculty from Alex's Spine Group. Thank you so much, and see you after 10 minutes.
السلام عليكم، تحياتي للجميع.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. I have a pleasure to share this session. I think this is the second webinar in our conference. I would like to thank the organizing committee for this very fruitful activity. And on behalf of the ESA board, I would like to thank a speaker in this session, because this session is the ESA session about the vertebral osteoporotic fracture. Let us to introduce my dear colleagues, Professor Yasser Alam, to start this session with case acute paraplegic after resuscitation. Professor Yasser.
Welcome, Dr. Yasser.
Thank you. أهلا دكتور شريف. أهلا يا باشا. Mr. Chairman, thank you very much. Do you hear me quite well, Mr. Chairman?
Please higher, louder.
Higher, louder. Okay, sir. Thank you, Mr. Chairman. Professor Elghait, it's an honor to be a speaker in this webinar. And actually, I should start on the spot. Okay. Mm-hmm. Do you see everything, Mr. Chairman?
Okay, that's okay.
Okay. Actually, it's a very nice information that I came across in the last 3 or 4 weeks, and I wanted actually that all the audience share with me this information. It's about an acute paraplegia occurring after cardiopulmonary resuscitation. It was actually not my case. It's a case report which was published in the year 2015 from a journal published by the Japan Neurosurgical Society. And at the beginning, I would actually thank all the organizing committee of the Aging Spine. It's a 9th Aging Spine, the 9th conference, 9 years along. They didn't stop even in this pandemic that we have, and that affected all the way we are living and all the way we are going to share the meetings together. It was actually an honor to have to see Professor Al-Hawari, to see Muhammad Khattab, Dr. Sharif, and you, sir, Professor Elghait. But a lot of changes has made by this pandemic. Thank you for the organizing committee for inviting me, and thank you, the organizing committee, for the continuation of these efforts. Let us start with the case. He was 78 years old male. He got a bicycle accident. With his age, he was doing bicycle, sporting with the bicycle, and he got a fractured pelvis. This fractured pelvis was actually aimed to be treated conservatively, but he got a DVT in the way of treating him for the fractured pelvis. They applied for him an inferior vena cava filter. And after application of the filter, the patient went into sepsis. And this sepsis was actually very successfully managed, and all the parameters of the infections, they improved, but he got aspirated while eating. And this led to airway obstruction and cardiac arrest. The patient was subjected to conventional cardiopulmonary resuscitation, and he was intubated. And actually, the patient recovered quite well from this cardiopulmonary resuscitation, and the heart started to work again in a good way. After he was extubated, the medical team noted that his consciousness is okay, but he was found to be paraplegic. This led to, and the medical team responsible for him, they started to do an MRI and CT scan of the spine, looking for why this patient is paraplegic after the cardiopulmonary resuscitation. And they were faced with this fact. As you see here, we have a fracture dislocation at the level of TH6 with severe cord compression, as we can see here in the CT scan and in the MRI scan, and the spinal cord is completely compressed at the level of the dislocation. Not only this, also the CT showed that the sternum here was broken. This means that they broke the sternum during the cardiopulmonary resuscitation, and after breaking the sternum, the patient was subjected to this fracture dislocation of his thoracolumbar spine. The neurological examination of the patient showed that he is completely paraplegic, and they started to, as the patient was still suffering from sepsis, and they started to continue treatment of his sepsis and to correct the general condition of the patient. And the spine surgery was done, and they started to think to treat this fracture dislocation 56 days after the cardiopulmonary resuscitation. After about 2 months. But they have demonstrated, and they have said that the patient, that they have to wait, that the blood culture negative, and that they have to improve the electrolytes. That was changed a lot after the cardiopulmonary resuscitation, and this was the cause of the delay. At the end, they have operated him, and they did for him here a laminectomy at the level of TH6 with long segment fixation above and below the laminectomy. And we can see here in the MRI that the cord is mainly decompressed at this area, and the fixation was fine. But the motor power after surgery didn't recover, and he is still, and they started to do rehabilitation program for him. Actually, this was the story of the patient, and we came to the conclusion, two important conclusions, that sometimes cardiopulmonary resuscitation is mandatory to save the life of the patient. And to do the cardiopulmonary resuscitation, you have to do an adequate chest compression in order to maintain the airway and the circulation. Sternal and thoracic spine fracture complications, they should be kept in mind, especially in the elderly patient who might have high propensity for these complications. These patients, they are so fragile. Think about chest, think about sternal and even spine fractures after such a very vital and necessary maneuver, which is the cardiopulmonary resuscitation. Thank you very much for your attention.
Thank you very much, Professor Alem. I think this gives us a lesson that we have the people in the ER must be treated, must be notified that this could happen. Nobody knows that this could happen anymore.
Yeah, yes, this was very strange for me, actually, very, very strange for me. But this directs us, Dr. Sharif, how fragile our patients are. They are so fragile that they may get catastrophes from this resuscitation.
I think, Professor, we should share this case with our colleagues in ICU units and intensive care, and I think so.
Yes.
It is very important.
Yes, we have
catastrophic case, but we should learn from a lesson from this.
Yes, actually, it was a nice occasion for me to spread this information so that every one of us is now aware about this complication, and he has to warn the ICU team about the possibility of such a thing.
Thank you very much, Professor Alam. Our next speaker will
Thank
be
you.
Muhammad Awad, lecturer orthopedics in Al-Azhar University. He will talk about the biomechanics of the OVF.
Yes, sir.
Welcome, Dr. Muhammad.
Yes, sir.
You can start.
Bismillah ar-Rahman ar-Rahim. My lecture about biomechanics of osteoporotic vertebral fracture. Osteoporosis is characterized by low bone mineral density in the setting of normal biochemical bone composition and microscopic structure. It's a metabolic imbalance favoring osteoclastic activity and bone resorption over osteoplastic bone deposition. This change results in pain, deformity, increased risk of fracture, and possible neural compression. The spine is the most common site of osteoporotic fracture. Osteoporosis is a progressive systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of the bone. There is primary osteoporosis as either postmenopausal or senile, or secondary osteoporosis due to metabolic bone disease, medical treatment, or lifestyle like diet and smoking. And this is the normal structure of the vertebrae, and this is the abnormal one of the osteoporosis. It's important to understand the biomechanics of the osteoporotic spine and to recognize that osteoporosis is a systemic disease. The osteoporotic spine is less able to withstand force, even the stress and strains that are entailed in the activities of daily living. First step for an adult spine surgical candidate is the diagnosis and quantification of the osteoporosis. Pathomorphology of the osteoporotic vertebrae. It's well established that the bone quality varies in different parts of the vertebrae, even in the vertebral body itself. The most affected part of the osteoporotic vertebrae, but the lamina, which is predominantly cortical, relatively spared, and potentially stronger anchor, the morphometry of the pedicle are variable. So this pattern of bone loss causes low the pedicle screw fixation to be less effective in osteoporotic bone. Bone mineral density or the varies in different regions of the spine. As we know, the T2 pedicle generally stronger than T3 to C6 pedicle, making T2 a good option for screw fixation or pedicle hooks as a strong upper anchor point. The vertebral body is composed of superior and inferior end plate with a thin cortical shell surrounding a network of trabecular bone. The end plate is in fact a bilayer of cartilage and bone. The cranial end plate thinner than the more caudal end plate on histological examination. This is in large part explain why the cranial end plate being shown to be fractured first in vertebral compression fracture. Also, the anterior vertebral body is preferentially affected by disease process in osteoporosis and is structurally weak than the central or posterior part of the vertebral body. And this distribution of the force in erect and flexed position of the vertebral column. Create deformity and fatigue failure. In many patients with vertebral compression fracture, this patient accidentally discovered for other medical condition without knowing about his fracture. This is defined as creep deformity, which is a slow progressive deformation of the vertebral bodies that occurs with repetitive physiologic cyclic loading. The idea of progressive creep can also explain the mechanism by which a biconcavity fracture type can progress to a crush type in the future. And this is different type of fractures, osteoporotic fracture, anterior wedge, biconcave, and the crush type. And this is a degree of mild, moderate, and severe type of osteoporotic fracture. And this is explained the anterior height, which is more affected by osteoporosis than the middle height, than the posterior height of the vertebrae. Mechanism of pain in vertebral compression fractures. The pain may be acute pain by the fracture itself and subsequent inflammation from the nociceptor in the periosteum and joint capsule. The fracture can cause pain via direct structural damage or compression from damaged tissue or by release of inflammatory mediators. Chronic and cyclic pain, multifactorial, more gradual biomechanical distribution than the initial insult of the fracture itself. Also, the final amount of kyphosis, which is the key here about the severity and disability which appears with osteoporotic fracture. With increased kyphosis, this will alter the articulation between the facet joints, which are rich in nociceptive nerve ending, This is in turn can lead to long-term facet arthrosis and neural irritation. Progressive kyphosis may result in paraspinous muscle fatigue as well as shift of the upper trunk. In severe kyphosis that's often associated with multi-level fracture, chronic pain may result from impingement of the rib cage of the pelvic frame. Non-surprisingly, the multi-level vertebral compression fracture are predictor for chronic pain, largely in part to the degree of increased kyphosis. As there is loss of anterior support structure and there is also failure of the posterior element, they may result in kyphotic deformity. And we see the pathological behavior pattern of the spine and pelvis, and there is a normal, and there is in relation to kyphosis, to see the horizontal gaze, the patient do hip extension, pelvic tilt, knee flexion to compensate the kyphosis. And this is part from the pain which is affected sagittal balance of the patient by kyphosis and vertebral compression fracture. Consideration for spine surgery in the setting of osteoporosis: 20 to 40% of the geriatric population has spinal hyperkyphosis. Kyphosis can affect health effects including impaired pulmonary function and physical function and pain. Pedicle screw pull-out strength and cut-out torque are directly proportional to bone mineral density which is affected. Osteoporosis contributes to instrumentation failure, pedicle and vertebral fracture, and proximal junction kyphosis. So methods to improve rigidity of fixation biomechanically include increasing the number of instrumented level above and below, in addition to cross-link rod, cement augmentation of the screws also increase the strength. Bone purchase can be improved by increasing screw diameter to enable great contact with the cortices of the pedicle. And there is a photo for different methods of augmentation of fixation in elderly patients with osteoporosis. As we see, cages, cement augmentation, cross connector. Compared with standard pedicle screw, there is another method of fixation which depends on a change of the direction of the screw to be cortical screw. As we see, the standard pedicle screw black arrow and the cortical screw is the red arrow, a more medial starting point in cortical screw, and the direction of the screw is caudal to be felt in the sagittal plane and medial to lateral in the axial plane to increase precise of the screw and improve fixation. Take-home message: in order to understand vertebral compression fracture, it's essential to have a baseline understanding of the relevant anatomy and physiological forces that act upon the non-pathologic vertebral bodies. The ability to conceptualize the morphologic classification in terms of this force is what allows clinician to better assess and treat patient. In classifying vertebral compression fracture biomechanically, it allows the clinic to ability to understand the deforming force and act upon the osteoporotic spine and predict further deformity. Similarly, knowledge of the mechanism by which vertebral compression fracture causes pain and deformity allow for the advancement of future therapeutic measures. Thank you.
Thank you very much, Dr. Muhammad. We'll move to the classification now of the osteovertebral fractures by Professor Alam. Of course, you answered the question which was asked in the Q&A, but can you just repeat it again, please, for the all audience? Because
what do you mean? Which question, Professor? The question, Dr. Sharif.
Is the fracture caused by the accident itself?
Yes.
Or it happened after?
Actually, it was also my question when I was reading the report or the case report, but they demonstrated very clearly in the paper, in the text, that after the patient was admitted to the hospital after this bicycle accident, he was examined completely, and he didn't suffer before this from any pain or any tenderness in the spine. No back pain and no tenderness in the spine. That's why they were sure that this fracture was sustained or was happened after the CRP and not before it.
The second question also to Yasser about the translation. Here is the fracture dislocation. And
yes, exactly.
How we can imagine this translation could be occur on the table, such as this translation, it is very strange in resuscitation.
Yeah, yes, exactly. I think, Professor Hussein, that the problem that they broke the sternum. And after breakage of the sternum, there is no protection for the spine cord anymore. All the movement that they have made to resuscitate and maintain the airway was transferred directly on the spine after the sternum was fractured. That's why it has been displaced posteriorly. They are very fragile, Professor Ulgate, very fragile patients. We have to find an explanation for this, how this fracture happened. I do not find an explanation better than the direct translational force on the spine after the sternum was fractured. The sternum was protecting the spine as long as it was broken, there was no protection and it was translated.
But if the spine itself is supported with sheet or table, I think no additional vector.
Exactly. They do all the time this on a board or in a hard object in order to be effective with the resuscitation. I do not know exactly, but I think there is no explanation except for this. Direct forces on the spine through the resuscitation.
There's a comment here. Did they use electrical shock?
They didn't mention anything about the electric shock, which may be a good explanation also if they electrolyzed him with the defibrillator, but they didn't do defibrillation of the heart.
Okay, thank you very much. You can proceed now, sir.
It seems that it was an interesting case, Dr. Sharif.
Very interesting. And carries a lot of questions.
A lot of questions. Very fine. Okay, sir. Then we shift to the second topic. Where it is now. Okay. Do you see the presentation now, Dr. Sharif?
Yes, sir.
Or not yet? You see it now. Thank you very much. Okay. Now I have to shift to the second, my second presentation, which is about the classification of the osteoporotic fractures. The commonly used trauma classifications, which are the AO spine classification, Dennis classification, and the thoracolumbar scoring system or thoracolumbar fracture classification were initially not developed for the osteoporotic fractures. On the other hand, classification of the osteoporotic insufficiency fractures, they are not common in trauma surgery. Until now, no classification of the osteoporotic vertebral fractures has gained international acceptance. Actually, I will take this as a chance to review the existing classifications, and they are not so important, but I will pass very rapidly through them. Gennant in 1993 was the first one to speak about the classification of osteoporotic fractures. It was based on vertebral shape, whether wedge, concave, or crushed. And number two, the decrease of the anterior, posterior, and all middle vertebral height. The fracture grading was grade 0, which means normal. There is no fracture. There is no loss of height. Grade 1, which is a minimal fracture with 20 to 25% loss of height. Grade 2, 25 to 40 loss of height. Grade 3, which is a severe fracture with more than 40% loss of height. Actually, it's a simple classification depending on the height loss. Kanshiko in 2003, this means that about 10 years later after Gennant, and he started to speak about his classification. He was the first to compare diagnostic success rates for osteoporotic fractures using MRI and plain radiographs according to the area of regional intensity changes seen on T1 weighted images The authors classified the fractures into 6 types, depending mainly on the T1 sequence, either total or anterior, posterior, superior, inferior, or central. 2 years later came Sugita, and he made his classification based on the initial lateral radiographs. The previous one was made on X-ray and MRI, and here Sugita is depending only on lateral X-rays. And we have here, he classified the spine into different types, like the swelled, this first type, the bow-shaped type, the projecting type, the concave type, dented type, and the first 3, they have poor prognosis, and the other 2, they have good prognosis. Now we come to the classification that I would actually, to spread also this information to all the audience and all the colleagues, which is the OF classification from 2018. It is the osteoporotic fractures classification, OF, osteoporotic fracture classification of 2018. Actually, in 2010, there is a working group. They call it the Working Group for the Osteoporotic Fractures. It is of the spine section of the German Society for Orthopedics and Trauma, was founded. Actually, we have here 23 affiliations, 23 hospitals in Germany, and they made this classification together. They have examined about 707 osteoporotic fractures in a prospective multi-center trial. They have made 14 consecutive group meetings, and the group decided to develop one classification for both traumatic and the non-traumatic, I mean the insufficiency fractures. And the classification was based on all available radiological examinations, X-ray, CTs, and MRI. And they came across this classification. We have 5 types of osteoporotic fractures, and they are classified 1, 2, 3, 4, and 5. The osteoporotic fracture 1, there is no vertebral deformation. There is a vertebral body edema and MRI steer only, in the fat subtraction technique, which is a steer technique. You will find that there is an edema in the vertebral body. X-rays and CT, they do not show any vertebral deformation, and sure, the treatment will be conservative treatment. Osteoporotic fracture 2, it has deformation, minimal deformation, with no or only minor involvement of the posterior wall, less than 1/5. One in the plate only is affected. It is like an impression fracture. It's a stable fracture, and the treatment consequently will be conservative. Now we come to the osteoporotic fracture 3. There is deformation with distinct involvement of the posterior wall, more than 1/5. It is considered as incomplete burst fracture, affecting one in the plate only. It's an unstable fracture, and consequently, the treatment mostly is surgical. The osteoporotic fracture 4, it may look like this, the first figure here. It is like complete burst fracture, or it may look like this, which is vertebral body collapse after failed conservative treatment, or it may look like this one, which is a split fracture or pincer type fracture. Any of these, you can call them osteoporotic fracture 4. All of them are unstable. All of them need surgical intervention. Osteoporotic fracture 5, it is a distraction or a rotation, and not only the anterior column affected, but also the posterior bony and the ligamentous complex, as in distraction injuries. It's an unstable fracture, and accordingly, it needs surgical intervention. This means that osteoporotic fracture 1 and 2, stable, and they need conservative treatment. Osteoporotic fracture 3, 4, and 5, they are unstable, and they need surgical treatment. Thank you very much for your attention.
Thank you, Professor Alam. Thank you very much for this nice presentation. From your point of view, Professor Yasser, what is the advantage of this classification? I think we need a template-like in our clinic to classify this or to use this classification.
I think, Professor Elgate, that this classification is easy to understand and to memorize, so that when we are speaking in a common language, when I'm saying osteoporotic fracture 4, then every one of us will get in his mind these three figures: the split fractures, the peristy fractures, or the failed conservative fractures. It's nice, it's easy, it's every one of us can memorize it. It's not like the AO classification in fractures, for example, which is very complicated and a lot of subdivisions. It has only 5 divisions. And when we get a common way of understanding, a common way of knowing, then we can also make the same treatment and which makes this action actually, I think it's a very nice classification.
We still have a question from a very active person with us today, Dr. Ahmed Saf.
Yes.
He said that these classifications speaking about the one vertebrae, so it is not enough. We need classification if there is a multiple level fracture. And we only speak about fracture and no neurological effects because the decision will be different.
Yes, you are right, sir. But yes, actually, when we have multiple fractures and we can classify each fracture alone. Example, I have in T1, in L1, I have osteoporotic fracture 1, I have only edema. In L3, for example, I have osteoporotic fracture 3. I can classify each one alone. This is a disadvantage of this classification, that they didn't include the neurological deficit in such cases. Actually, they didn't give us any idea about what about the neurological state. This is a mechanical classification depending on the imaging and has nothing to do with the clinical impact of the patient, which is, I consider it a disadvantage in this classification.
Okay, thank you, Professor Yasser. Thank you.
Sir. Thank you, sir.
I have a pleasure to introduce my dear friend, Professor Rafat Kamal from Alexandria University, to deliver his talk about glucocorticoid-induced osteoporosis in elderly. Welcome, Professor Rafat.
Thanks. Thank you very much. I'm missing you all. Actually, I'm missing this meeting very much. Actually, because this meeting has been a chance to meet Professor Yasser Hawali, Professor Sharif, Professor Hussein Abou Ghait, Mohamed Fawzi Khattab, all of you. I do thank the organizing committee for inviting me for this presentation. And I repeat what Yasser Alam has said. I appreciate very much their persistence in continuing the activities, even in the circumstances we are living. I also take the chance to invite all of you to our international meeting in Alexandria the last weekend in March. It will be hybrid, so there will be chance to, inshallah, to meet, inshallah. I will start presentation, if you allow me.
Share screen. Professor Rafat, share screen.
Yes, I did.
Okay.
Okay.
Not yet.
Are you on now?
No,
okay.
no.
Actually, okay.
Not yet, Professor Rafat.
Is the share box? The green one. Yes.
Yes. Now?
Yes, we started to share.
Okay. Actually, in the next few minutes, I choose to highlight one type of osteoporosis. It is very serious type of osteoporosis which can interfere with our spine surgery practice, the GIOP or the glucocorticoid-induced osteoporosis. To start with, an osteoporosis is systemic skeletal disease which is characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. And we know that it is a silent disease and people may not be aware until they have or develop the osteoporotic fractures. And you know very well that even with the WHO classification, according to the T-score, INDEXA, the BMD values, we need something like the FRAX, which will assess the fracture risk assessment. The fracture risk assessment, actually, we put one important factor in the risk factors, which is intake of the glucocorticoids. So let us revise some few points before stressing on the mechanisms by means of which glucocorticoids will induce osteoporosis. First, we remember that bone strength is nothing but bone quality and bone quantity. And bone quality we can't measure except by high resolution CT or bone biopsy. What we measure is actually the bone mineral density by the doctors. We actually assessing in our practice one part of the bone strength. Also, every 3 seconds there is an osteoporotic fracture, and even the incidence may go more and more. And we know that osteoporosis does interfere in our spine surgery practice and orthopedic surgery practice. Osteoporosis makes it difficult to obtain a secure fixation. Also, non-union and malunion and reoperation can occur with increase in the fracture risk. If we concentrate on these photos, on the left side, this is the normal bone. And on the right side, this is the osteoporotic bone. We should remember that our bones are composed of cortical and the trabecular bone, and that osteoporosis affects trabecular bone much more than the cortical bone. So that's why here we can see that the trabecular part of the proximal femur is affected much more than the cortical part. Why we are saying this? We are saying this to concentrate on the suffering of the spine surgeons from osteoporosis. Because if we revise all these numbers, we find, for example, in the trochanteric region, only half is formed of trabecular bone and half is formed of cortical bone. What about the vertebral bodies of the dorsal and the lumbar spine? The trabecular bone represents 75%, which is the highest percent of trabecular bone ever in any part of the world. And this means that the osteoporotic fractures of the spine should be, and they are, the most common osteoporotic fractures. But why we are not seeing this so common? Because actually in our practice, we are diagnosing 1/3 of the vertebral osteoporotic fractures. 2/3 of the vertebral osteoporotic fractures will pass unnoticed or underdiagnosed. So if we see this diagram, we can see that here, if we compare the anterior height of this vertebra compared to the anterior height of the vertebra above and vertebra below, we'll find that this vertebra is compressed. That is the morphometric fracture. This causes back pain, but it can pass unnoticed or underdiagnosed in X-ray. Here is the osteoclast doing its function in bone resorption. Before going into the mechanisms by which glucocorticoids will work on the bone, I will just say this, in this diagrammatic representation of how osteoporosis occurs. First, osteoblasts will secrete the rank ligand. As we know, the rank ligand will join the OPG, and then this will cause maturation and the proliferation of and activation of osteoclasts. The osteoclasts will go and will form its function in bone resorption, and then the osteoblast will come and do its function in bone formation. Bone resorption equals bone formation, that is normal bone balance, no osteoporosis. What happens in, for example, postmenopausal osteoporosis? There is excessive formation of rank ligand because there is loss of the inhibitory effect of estrogens. This means that there will be much more activation and proliferation of osteoclasts. The osteoclasts will do the bone resorption much more than the action of the osteoblast. So at the end of the day, we have still resorption cavities or imbalanced bone resorption and bone formation. That's why we are using drugs to counteract the rank ligand. And this is very important to know the mechanism of rank ligand, because this is one of the mechanisms by which glucocorticoids will cause osteoporosis. So what is the impact of glucocorticoids on bone health? Glucocorticoids actually represents one of the most common, the most severe, and the most resistant type of secondary osteoporosis ever. And if we know that the BMD declines by at least around up to 3% during the first 6 to 12 months of glucocorticoid therapy, and we know as much as little as 3 months only of glucocorticoid therapy to cause osteoporosis, and that the fracture risk increases by 20% if we use a dose of 5 milligrams. If we increase the dose to 20 milligrams per day, the fracture risk jumps to 60%. And osteoporosis can occur with doses as little as 2.5 to 5 milligrams. But how the glucocorticoids will cause the osteoporosis? Actually, glucocorticoids will have direct mechanism and indirect mechanisms. In the direct mechanism, as we can see, they will affect the cells, all the bone cells, osteocytes, osteoblasts, and osteoclasts. What is apoptosis? Apoptosis is the programmed cell death, which means that if we increase the apoptosis, we actually decrease the lifespan. So the osteocyte will die quickly. This will occur to the osteocytes and osteoblasts, and so at the end of the day, there will be decreased bone formation. The opposite occurs by glucocorticoids to osteoclasts. They will increase the rank ligand as we saw. So if they increase the rank ligand, there will be more maturation and more proliferation of osteoclasts, more bone resorption. So at the end of the day, glucocorticoids will cause decrease in the bone formation and increase in the bone resorption, and hence the bone mass will decrease and the bone strength will decrease with increased risk of fracture risk. Not only that, glucocorticoids also will cause will increase the fracture risk by indirect effect. We know that the glucocorticoid use for a long time cause a sort of myopathy. We call it steroid-induced myopathy. This causes muscle weakness, and through muscle weakness, there will be increase in the risk of falls. Also, it has a negative effect of the calcium metabolism. It decreases intestinal absorption of calcium and increases the renal excretion of calcium. So there is negative calcium balance. Through both direct and indirect mechanisms, glucocorticoids will induce osteoporosis. There will be increase up to 2 to 3 folds in the hip fracture risk, and up to 5 folds in the vertebral fracture. Why? Because osteoporosis affects the trabecular bone more, as we know, and the trabecular bone percentage in the vertebral bodies is more. However, if we increase the dose, the risk will increase from 7 up to 7 folds in the hip fractures and 17 folds in the vertebral fracture. So this is very important. So to conclude, osteoporosis represents a compromised bone strength with increased incidence of fragility fractures. Proper assessment of the osteoporotic patient should be done individually, and osteoporotic fracture represents failure of bone under trivial trauma. Osteoporotic fracture represents an economic as well as health problem with increased incidence of mortality and morbidity. And the glucocorticoid-induced osteoporosis represents a serious form of secondary osteoporosis with increased incidence of fragility fractures, and therefore continuous monitoring of patients on glucocorticoid therapy, especially those having long-term courses more than 3 months. Prophylaxis against osteoporotic fractures of these patients using calcium, vitamin D, and anti-resorptives. And of course, we can use combination of both anabolic agents and anti-resorptives, which can be resorted to in patients with low BMD having long-term corticosteroid therapy. Thank you.
Thank you very much, Professor Rafat. We really miss you here. Maybe next year, inshallah, تبقى موجود معنا physically.
بإذن الله إن شاء الله.
Our next speaker will be Dr. Tahir Al-Fei from Alexandria. He will talk about how to reduce the cement leak in the vertebral fractures.
Assalamu alaikum. Can you hear me?
Yes, Dr. Tahir.
Good afternoon, all. I'm very happy. I'm very proud to be among very, very distinguished teachers, colleagues, and friends. And I will start my topic. I think it's important. It's about cement leak or extravasation in osteoporotic vertebral fracture. So osteoporotic vertebral fracture is one of the most common complications of osteoporosis, and we know that all of the shortcomings of the conservative treatment. Nowadays, vertebral augmentation techniques proved their effectiveness and safety. Two main issues should be raised when we are injecting the osteoporotic vertebra is the cardiovascular changes, which is probably due to fat embolism, as well as the cement leak. I have to admit that early reports about vertebroplasty, about cement leak in vertebroplasty should be taken cautiously, and the problem of extravasation or leakage should never be underestimated. And we imagine that we have an incidence of about 80% leak with vertebra you are injected. Just look carefully at the X-ray, not even the CT, you will find extravasation. The extravasation is much, much, much more common than we believe. Fortunately, we don't have clinical implications in most of our cases. And we have to know also that most of the meta-analysis comparing vertebroplasty with kyphoplasty or even vesicoplasty, the more advanced techniques, have equal incidence of extravasation or leaks. Sometimes the leakage or extravasation would be very serious. Fortunately, it is not common. What the literature tell us about the risk factors, first of all, is the amount, which is quite important. Nowadays, I do not inject more than 3 to 4 millimeter in most of my cases for the osteoporotic vertebral fractures. Because more than that, the leakage will be very high. Also, the type of fracture, the amount of vertebral damage can share also. There are many reports about the use of the high viscosity cement, the type of the cement itself, low viscosity, moderate, or high viscosity. Definitely the high viscosity cements had low incidence of leakage. I have to make a comment for this. If you use, and I don't have much experience, if you use high viscosity cement, you have to inject the cement at high force. which on the other hand can increase also the leakage. Also, the presence of cleft on the MRI, it's important for those patients to do MRI if the MRI has no edema, so don't inject, it's too late. Delayed surgery also because of the hesitation from the doctor or from the patients. If you exceed 2 to 3 weeks, again, don't inject. So how to limit the cement leak? There are several attempts which we can take very cautiously in the literature. This is an idea of creating a small hole. I don't know how to do that, but already the fracture had a cleft or had a hole. Also, a technique for serial injection to not inject all of the amount at the same time, but I think it can add to the stress during injection because the cement may harden. This is the technique I like it, which is the technique of vertebral wash or the vertebral lavage. It's a very simple technique and was published about 5 years ago. The hypothesis was that if you make a wash using simple saline, you can inject at low force, and at the same time you will remove much of the debris in the form of the fat contents. Therefore, you will lessen the likelihood or the incidence of both fat embolism and cement extravasation. I think all of the credit should be given to this man, this Professor Michael Loreen Penneker is my friend. He's working now as a chief in Enschede Hospital, Bern, University of Bern. He's the chief of the spine unit in Bern University. This is the idea of him. Actually, this technique was tried in a cadaveric and as well as in animal model, which proved its both efficacy and safety. The technique is very simple. What you need is 2 MCD needle. I think 1 MCD needle costs maybe 1,000 pounds in our country, but it deserves. And also two 20 millimeter syringe, one empty and one filled with saline. We don't inject saline most of the time, but we use the vacuum pressure. Just apply vacuum pressure, and on the other syringe, the blood will come out. And you can repeat this 3 to 4 times until the fluid becomes clear. And this technique clinically proved its efficacy and safety also. So this is the technique illustrated again, and we need the 2 MCD needle. The lavage ended by formation of a clear fluid on both sides, and I think in most of the cases this technique can works using this maneuver. It's important to stop immediately after leakage. Nowadays, I'm not very interested about the feeling and the good shape of the vertebra. I'm thinking that once you have an extravasation, you have to stop immediately, especially when you are confronted with cases 2 to 3 weeks or more. But I don't advise to inject at this period because you are not gaining to restore the height of the vertebra anymore. Also, we have to remember that in our country, most of us, or in most of the time, we use only one C-arm. So you don't appreciate TB and lateral at the same time. So you have to turn the C-arm and take another view, etc. Last, I will illustrate some of the cases which have some extravasation for this lady, 79 years old. As you can see, this is the what's called S-type leakage or leakage in the segmental vein. So if you see this, you have to stop immediately whatever you inject, even 2.5 and 3 centimeter. This is what's called, this is the D type of leakage or discal leakage, and I think in the incidence of this is about 100%. The clinical implication of this is the discal type of leakage can increase the likelihood, of course, as you know, or the chance for getting one more vertebral fracture. I think this is not good. I don't like to see this, because if you see any cement in the pedicle, most probably you are in the canal. So it's better to leave the posterior half of the body of the vertebra out of or without any cement. I inject this case, these patients 3 weeks. So despite of the fact that the patients dissatisfied and got relief of pain, but the vertebral height did not restore. The biomechanical restoration did not happen. This was only just a painkiller operation, and the cement started to be in the posterior half, so I have to to stop cementation after only 3 cc. I also injected this patient maybe after 3 weeks, because she's very hesitant to do vertebroplasty, and after 3.5 centimeter, I noticed extravasation in the segmental vein or isthmus, so I stopped injection immediately, and none of those patients had any postoperative clinical implication. This patient came for me for consultation with this very strange X-ray. In fact, I cannot categorize this extravasation, which type of the cement leakage described in the literature. I don't know, so you may help me to discuss just what was happened for the surgeon. He was a consultant spine surgeon when he tried to inject this, and fortunately, of course, this huge amount was not in the canal, and fortunately, this patient also came to me walking without any clinical implication. I like to see that every time. Since we expect straight extravasation with infiltration, so we must expect cement extravasation with every case. My advice is always expect extravasation, inject small amount when possible, do the procedure very early. Lavage technique is visible and simple, and lastly, stop immediately if you can see any leakage. Thank you very much.
Thank you very much. Very nice cases, very much leakage everywhere. I think the last case, the leakage was in the kidney. It's renal extravasation. So, our next speaker will be Dr. Hussein Abulgate, the Dean of the Medical University at Azhar. We'll talk about the sacral insufficiency fracture.
Bismillah ar-Rahman ar-Rahim. Firstly, I would like to thank the organizing committee, Professor Yusri Al-Hawari, Professor Khattab, Professor Sharif, Professor Gamal Baroud from Canada. My talk today about the sacral insufficiency fracture. I have nothing to disclose. my ELOs now for this talk, sacral insufficiency fracture, to highlight incidence and the magnitude of the problem, to discuss the fracture pattern and the pathomechanics, to clarify diagnosis and misdiagnosis, and at the end the treatment. I pay attention for sacral insufficiency fracture actually after I facing a lot of cases with misdiagnosis or lately diagnosed, up to some patient advocated or advised to take a biopsy. This is the first case, male patient, 70 years old, well-known rheumatoid. History came with sacrooccipital disabling pain. The pain typically increased with sitting, or what's called sitting intolerance. No radicular pain, no nocturnal variation. With examination, just local tenderness at sacral region. No swelling, negative ACLR, no neurological deficit, and lab was only high SR and attributed for the rheumatoid. This is the X-ray for the patient. For a patient more than 70 years old, I think it's nothing more spondylitic changes, which is expected, but nothing in the sacral region strange or to comment. Just spondylitic changes, narrowing on disc space, instabilities, but nothing in the sacral region in the X-ray. This is the MRI with the low signal intensity region confined to the sacral region, very clear, and this is nothing more in the other region of the lumbar spine. And this, I think, correlate with the pain region or the area of the tenderness. And this is the T2 with high signal intensity region. And inside this high intensity region, the area of low signal intensity or line of low signal intensity region within this high signal intensity region. The MRI report for this patient was bone marrow infiltration, maybe metastasis, for further investigation. Fortunately, the bone scan was very clear with this very specific finding, what's called Honda sign, with high with grace uptake in a specific pattern, like H shape or Honda sign, with the two upper limbs longer than the both lower limbs of the H sign. It's very typical Honda sign, and very clear specific sign denoting the what's called sacral insufficiency fracture or sacral stress fracture. This is the second patient, 74 years old, long history of low back pain with claudication, well-known spondylolisthesis. The patient was diagnosed as spondylolisthesis for a long time, but the patient has a new pattern of pain. On patient words, I have a new patient. I have a new type of pain. I know the instability. I know the claudication, but now I have a new pattern. I can't sit. He has now recently developed acute severe low back pain in form of sitting intolerance. Again, the MRI after this new developed back pain or sacral pain, again there is a low signal intensity in T1 and high signal intensity in T2 with the low signal intensity within this region of low signal intensity. Again, the MRI report speak about altered marrow signal of S2 and S3 segment appearing low in T1 and T2, no sizable extra osseous soft tissue, and the patient advocated to do also biopsy for discover or to diagnose this pathology. The patient recommended to do the bone scan, and again the classic Honda sign, very specific sign. The bone scan is very sensitive and also very specific in this issue. Regarding the sacral insufficiency fractures, common cause of debilitating back pain in the elderly, since they were first described by Lurie in 1982. The sacral insufficiency fracture usually or commonly misdiagnosed or lately diagnosed require an adequate level of suspicion to diagnose or to pick up the diagnosis. We should think about it in elderly, in back pain, in sacral region. We should think about it. Careful diagnostic imaging workup is necessary to detect them. As we know, there are two types of stretch fracture. Either insufficiency fracture occurs in the setting of physiological load upon upon weakened bone, suboptimal bone mass quality or composition, and second type is fatigue fracture due to abnormal force and load applied to optimum bone quality and structure. This type of fracture is insufficiency fracture. The osteoporotic bone faced normal load, maybe trauma or no trivial trauma, or maybe no trauma at all. The incidence, the precise incidence of sacral insufficiency fracture is unknown. However, the potential prevalence of sacral insufficiency fracture is considered to be higher than the widely appreciated. Some authors speak about or reported about almost 2% of women who present to ER with low back pain may be suffering from sacral insufficiency fracture. Again, sacral insufficiency fracture recognition and treatment. This review for the patient came or treated for vertebral compression fracture. There is about 10 out of 79. More than 10% of patients with vertebral compression fracture may be associated with sacral insufficiency fracture. Usually overlooked, sacral insufficiency fracture are usually overlooked in the elderly, and as we see before, we need some sort of suspicion, like the infection. We need some sort of suspicion to detect it. Regarding the pathomechanics, the fracture pattern may be related to the axial load and weight bearing transmitted through the spine, resulting in sacral alar strain. Osteoporosis cause symmetric loss of bony trabeculae in the sacral ala compared with vertebral body, placing the lateral aspect of the sacrum increase the risk of sufficiency. Fracture pattern reported by Linstorm. There are three fracture patterns. The typical symmetrical is the one in the extreme left, and if we look for this pattern of fracture, may explain why H shape or Honda sign usually came by the or resulted in the bone scan. Regarding the clinical findings, sudden onset of pain in the lower back may be relating to hip or groin with or no trauma, maybe trivial trauma. Pain may be significant and disabling. Sitting intolerance is very important. Regarding the radiology, maybe sclerosis or cortical disruption, but the X-ray, it is not the tools for diagnosis because difficult to see with overlying bowel gas and because the underlying bone is osteoporotic. CT scan may demonstrate sclerosis or interruption or fracture line with or without callus formation. CT scan fracture line are usually sagittally oriented and are radially apparent on the CT scan image. Again, the MRI is very useful, very sensitive, highly sensitive for stress fracture or sacral insufficiency fracture. T1, low signal intensity corresponding to edema, and T2, appearing dark line within the relatively bright signal edema background. Very similar to our case I have presented before. Bone scan, very sensitive and very specific. If we look for the Honda sign, or if reveal the Honda sign, increase radio tracer uptake in the pattern that has been called the Honda sign. Explanation of the Honda sign, the characteristic appearance is that of the fracture line running vertically through both the left and right sacral ila, medial to sacroiliac joint, and transverse fracture just below the level of the sacroiliac joint. Again, the Honda sign, our variation with evidence of fracture elsewhere or no evidence of other metastatic disease should be strong evidence for sacral insufficiency fracture. The likelihood of having a solitary metastasis to the sacrum is very small. Regarding the treatment, either conservative or operative, conservative treatment in bed rest, pain medication, reduced weight bearing, prognosis is good, but complete healing maybe take many months, 4 to 9 months. We should protect the patient from possible sacral decubitide. Regarding the operative treatment, either standard with iliac to iliac plate, very extensive approach, and usually there is a prominence of plate, so we can go to the sacroplasty. Has recently emerged as a minimally invasive alternative to conservative treatment for sacral insufficiency fracture. Not so easy, but also maybe accompanied with complication of lake, and the lake maybe affect the neural element or neural foramina. The last, I think the fixation with iliac screw, it is an minor access approach, safe and effective, technically not demanding at all. Just two screws in the iliac sides, length about 110 to 140, diameter 7 to 8 millimeter. The presence of perforation of perforated screws may be advantageous in the osteoporotic bone. The entry point posterior superior iliac spine, and the owl is used to penetrate between the two cortices in the ventral caudal direction towards the anterior inferior iliac spine. Preferred diameter 7 to 8 millimeter. Very important to have these three views during surgery: the true lateral, the obturator outlet view, and we should keep the screws above the iliac, above the greater sciatic luge, with as at least 2 millimeter. My take-home message: sacral insufficiency fracture, an important cause of sacral pain, especially in elderly, which usually overlooked. High index of suspicion is required for detection. Bone scan with Honda sign is the most specific diagnostic sign. Treatment either conservative, minimal invasive sacroplasty, or iliac screw fixation. Thank you.
Thank you very much, Professor Abourid. We have some questions, but the first question will be for Dr. Tariq. Can you unmute yourself, please? You're still muted, Dr. Tariq.
Yes, sir.
We have a question from Dr. Gamal Baroud. He asked about your experience in terms of reducing the risk of leakage, and does he has any statistics, it seems, of in terms of reduction of the leakage risk, or in terms of type of leakage?
Okay, thank you, sir. Actually, I didn't publish any paper other than the paper I presented using the technique of lavage or vertebroplasty. The others were just personal experience without any published data.
Okay, we have another question for you, sir. How to be sure of 3 weeks interval of osteoporotic fractures before vertebroplasty, and how long edema persists in imaging?
Is for me also? It's for me?
Yes, you can answer this.
Okay, okay. I think it's routine. It's our routine to do MRI. We should not underestimate that. I think the edema may last for 1 month, but according my personal experience, don't inject at this period even, and the literature maybe take 4 to 6 weeks at the cutting edge for using vertebral augmentation. But I think more than 2 to 3 weeks, the procedure will become a painkiller procedure, and you will not be able to restore the height anymore. Of course, if you don't have edema, don't inject. Yes.
Thank you, Dr. Tar. We have a question for Dr. Hussein. The rule of bilateral iliosacral screws. Will it does compression?
Yeah, we can get a compression with compression instrument or so between the two screws along the rod between it. Okay.
And will you do it percutaneously?
I did it open, but I know some professors did it percutaneously.
Okay. That's all. And I encourage all the attendees to put their questions in the question and answer. Yes, Dr. Yasser, yes, please.
Dr. Sharif, I have actually a comment to Professor El-Gate. Yani, it's time that the radiologists, they have to be more specified and to be more accurate during writing their reports. It is unbelievable what they are doing with us, making us in a total chaos. Metastasis, secondaries, and the condition is very simple. It's a fracture. You are now in a state of responsibility, Professor El-Gate. You are a dean of the faculty. I think that you can start in Al-Azhar to put rigid rules that the radiologists, they should be more categorized in groups: musculoskeletal group, spine group, knee group. And if you have 2 colleagues only specified in a special region, they will be the best. And all of us will run after them, and we want to take their opinion in such cases. But everyone is everyone is reading the images, everyone is writing a report, and at the end, the patient is losing time, and we are in a total chaos. We do not know what to do. We have to do then another investigation and to be sure that we are on the right track. Would you agree with me about this, Professor Al-Hawari and Professor El-Gate?
Yes, sir. You raised a very important subject, and everything is specialized now. So why not radiology? And so I add my voice to you, and yes, this should be done, and Professor Reit would do it.
I totally agree, Yasser, but I think the problem not only in the radiology. The radiology, we can pick up it. All of us, we can read the MRI very well, but in such case like pathology, it is another issue. Still, the no subspecialty in the pathology and or histopathology. And this, I think, this is a catastrophe rather than the radiology. The mistakes in the radiology, I think, could be picked by all spine surgeon now. The second issue, I think, in the university or the well-established faculty and the university, I think no problem in this issue. But this is actually private. The private centers for radiology usually they send the MRI through the Zoom or through internet or email without any physical contact between the reporter and the patient. I think so.
Yes, this is a big problem. Yes.
We have a question for you, Dr. Tari, again. How to deal with the leakage after it happens?
I don't know, but I pray to Allah to to not to have any clinical implication. Fortunately, I don't have in my life so far.
Okay, thank you very much. We'll move to the next topic. Could be Professor Yusuf Hawari in a case-based discussion.
Hello, everybody. And we have now 145 attendants, and today we have had 700 registered. So attendance will come and go. So we're never going to have this amount of attendees if it was physical meeting. So thanks to COVID, at last we've seen one benefit from COVID. So ankylosing spondylitis case with chin to chest deformity. The objective of my presentation is to be able to apply a new technique for correction of chin to chest deformity in ankylosing spondylitis. This was a 53-year-old male, had long history of ankylosing spondylitis. 6 months ago, he had a fall. Symptoms became worse. He had loss of frontal gaze and difficulty in swallowing. And this is the patient. I'm not sure the video will work. This is his CT scan. There's no compression on the canal. But if we have a reconstruction of his reconstruction, we can demonstrate that this patient has no deformity in the cervical spine. The deformity is between the cervical and the thoracic spine. So what are the treatment options? You can leave him alone. Can you? Can you? You cannot, because the patient cannot see in front of him. And I'll ask everybody to try to put his chin on his chest and swallow. You cannot, because you block the esophagus. So imagine yourself eating with your chin on your chest. You cannot. Would you do a lumbar osteotomy? No, because the deformity is at the cervical thoracic junction. So any lumbar deformity, any lumbar correction with the deformity, it will not work. And would you do a C7 osteotomy or a T1 osteotomy or a T2 osteotomy or any other osteotomy? So because he did a lot of work on ankylosing spondylitis, whether here or in Germany, what would he choose?
Please, Professor Hawari, to see the X-ray or the CT scan again. I think here there is no apex still up to 2, 3, 4, 5, 6, up to C7, T1. Still no apex. Have you another sagittal CT scan or X-ray, whole body X-ray? No, just C7.
Yes, you can do a C7 osteotomy. What's the problem of C7 osteotomy? You might lose the hand function because you can injure the C7 or you can injure the T1, okay? And also there's a problem of differential fixation. In the thoracic spine, you put large screws, and the cervical spine, you put small screws. Also the rod, one is 4 millimeter and the other is 5 millimeter. And this is the problem of the differential fixation. Also, we have other difficulties with this patient, anesthesia. Imagine the patient chin to chest, and you're putting a tube in. And positioning, after you put the tube in, how are you going to position this patient? How are you going to put with the flex head? How are you going to put the head on the table? And as I mentioned, the C7 T1 palsy, the patient has got osteoporosis, ankylosing spondylitis with osteoporosis, and the fixation in the cervical spine is usually not that good. And the problems with differential fixation from small rod to a larger rod. So what we've done, we did an endoscopic intubation. It was difficult. It took more than the operation itself. It took like an hour and a half trying to put the tube in. We had an ENT surgeon ready. If we failed, we would have done tracheostomy. But again, tracheostomy is very near to the incision at the back, and you can get infection. So we were thankful that we didn't need a tracheostomy. Positioning using the Mayfield frame is very good because there is no pressure on the either the forehead or the eyes, and you can use this Mayfield frame to correct the deformity. And of course, we had neuromonitoring, and we did a PSO of T2. This is a new technique in which you do the osteotomy, the pedicle subtraction of T2. Why it's good? Because you have still T1 and you can put a 5 millimeter screw in T1, and this will be a very good grip. So we put a 5 millimeter screws from T1 to T6. We use a 5 millimeter rod, and then we used a 4 millimeter lateral screw mass from C4 to C6. We didn't put any screws in the C7 because you need put the connector between the small rod and the large rod. And then we closed the osteotomy using the Mayfield. We were able to pull the Mayfield because this patient had two deformities. One, the chin to chest, and the other, the rotation. So we were able to correct both deformities. And we kept the patient intubated overnight. And this is the next day. Patient, for the first time, and he said in like 5 or 6 years, he was able to see in front. And this is his front view. Patient can sit without having this deformity of the head. And this is the fixation. We down to T6 and C4. Can you start the video your side, يا محمد? شغل الفيديو عندك. This is the Okay. This is the next day. He's walking after the tube is out. And he's a different person than yesterday. So why T2? At least you won't get any hand palsy. You have a good grip in T1. You have a better fusion because you're fusing a thoracic vertebrae, not a cervical vertebrae or a cervical osteotomy. It's a thoracic osteotomy. There's no need for any post-op external fixator or a halo. And I think this is a good, a safe, a new method. It's been reported, I think, like 2 years ago. And I would do this again and again. And I'm open for any questions. First, I will ask Dr. Abul Ghait, what do you think?
Thank you, Professor Hawari. Very excellent presentation and excellent results. I think the social life of patient has been changed. He has no social contact. Now he has social contact, eye contact. Excellent results. Thank you very much.
I remember when the patient came to me a month later, he said, okay, doctor, I'm very happy. I can see other people now. I could eat. But what about the fixation of my neck? Why it's not moving? And I wanted to move again. So,
any question from the panel?
Can I ask? I have
any questions? Yes, please, doctor. Yes, please. Go ahead.
Okay.
Go ahead.
Thank you very much, Professor Hawari. The very interesting cases. All of us learned so much from this presentation. It needs a big hero like you, of course. Did you perform a neuromonitoring during the surgery?
Yes, sure, but it's much easier than the cervical. Yeah, and when you remove C7 lamina and then you're working the cervical spine, it's more difficult than the thoracic spine because you're accustomed to do osteotomy in the thoracic or lumbar. So it's like lumbar PSO.
Can you tell us what happened during the neuromonitoring and if any signal changes happened during your work or during closure of the DSO?
No, nothing happened. But using the Mayfield, you have a very good grip and you can close it anytime because it's one key to close the Mayfield. So whenever anything happens, you can just stop and close that key and the head is stable. So I like the Mayfield, and there is no pressure sores in the head or the eye or nose.
Yes, we have a question from George Al-Khouri. How do you explain the discrepancy between the imaging and the clinical deformity?
As Professor Abul Ghait said, the deformity is lower in at the T2. And that's why it's not present in the CT reconstruction image.
Okay, thank you.
Professor Yasser?
Yasser?
A nice case, Professor Hawari, very courageous. But my comments are above the osteotomy, we have C4, C5, C6 lateral mass screws, and T1 pedicular screws. Is it sufficient, sir? I didn't see any external neck support or any. Is it? Are you happy with this? Very sure about this? Or we better put him for a couple of weeks in, for example, Philadelphia neck support to limit the stresses from the above arm, above the osteotomy. What do you think, sir?
From the grip of T1, I would have just quitted at T1, no need for cervical, because it was very good grip. And when we closed by moving the head and closure and then doing like compression between T1 and T3, the screws were holding well. But I did go more proximate because there was like between C4 and C5, there was like an old flexure which has healed.
Yes.
That's why I went to C4. But it's when you try the T1, it's a good, very good screw.
fine, sir. No need for a Philadelphia neck collar or something like this for a couple of weeks?
No, because if you go back to the literature, you find most of the infected cases come from the external support. When you start putting the patient in external support, then all the sweating and the thing will lead to the infection. So no need, and it's an added complication.
Okay, sir. Thank you very much.
Still have a question from Anita. Why do you consider only multi-level posterior stabilization? Was a ventral combined approach an option?
There is no role for anterior surgery in kyphosis because it's a deep wound and a deep site to do your osteotomy, but that's why there is no. Yeah, you might go anterior if you are open a space and then you want to put a bone graft, but in enclosing it wants to heal, so you don't go.
Dr. Yasser, what do you think? You are muted.
Yes, sir. As Professor El-Hawari said, in kyphosis, I think there is no place for anterior surgery, especially at this level at T2. In order to reach T2, we will need a sternotomy, and it's a big surgical hazard. We are not in need of this. Actually, posterior surgery, as you have seen in the result, the patient is looking in front of him. Everything is fine. He is happy. Professor El-Hawari is happy. We are also happy. And this is all what we need.
I think that's right.
Thank you very much for the attendance, and we'll break and we'll return back at 6 o'clock for the third session. Thank you, everybody.
Thank you very much for all the speakers from Alex and from Cairo. Thank you very much. And for young colleague Muhammad Mawad, thank you very much. Okay, Dr. Yasser.
Thank you very much. Thank you very much. Thank you. Thank you.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Beatrice believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Beatrice, we know the way to empower people worldwide to live healthier at every stage of life. In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Beatrice is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Beatrice believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Beatrice, we know the way to empower people worldwide to live healthier at every stage of life.
She's not the only one.
أنا عارف زي ده.
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life. In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life. In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear friends and colleagues, thanks for being with us. Till now, we are continuing the program of the first day of our Egyptian Scoliosis Society annual Aging Spine meeting, and this webinar will be in collaboration with the Saudi Spine Society, and I am happy to have Dr. Faisal Konbaz from Saudi Spine Society moderating this session with me. And this session will cover some degenerative scoliosis talk from Professor Muhammad Wafa. Professor Wafa is president of the Arab Spine Society, and he's the past head of the spine unit at Ain Shams University, and he's one of the pioneer in spine surgery. Dr. Wafa.
Yes. Good evening, everybody.
Yes, good evening, Dr. Wafa. Can you start this session, Dr. Wafa, sharing your screen, giving us the experience about degenerative scoliosis?
Sure, very happy to do so. And thank you for your actually very fruitful meeting. I've been sitting there for some long time, and that's why I got some back pain, maybe degenerative scoliosis also. Right, I'll try to be quick just to keep with the time. So degenerative scoliosis is that's the scoliosis which doesn't move. Adult scoliosis defined as coronal deformity more than 10 degrees in a skeletally mature person. But when this degenerative scoliosis actually has similar gender distribution between males and females, typically starts at 50, and presentation usually is around 70 years of age. Max Abe classified this into type 1 primary degenerative or de novo, deformity in a patient who had previously a straight spine, usually this with minimal structural changes, but with advanced degenerative changes. And predominantly it is lumbar curve. Type 2 is on top of idiopathic deformity. Somebody who had an idiopathic deformity which is progressing after skeletal maturity. This can be anywhere in the spine with superimposed secondary degenerative changes. Type 3 is that type which we see in the context of other pathologies like pelvic obliquity or hip pathology or lumbosacral transitional anomaly. It's mainly lumbar or lumbosacral. Schwab and SRS classification is very useful. They define the curves into 3 types, actually, either thoracic with lumbar curve less than 30, or thoracolumbar lumbar only with thoracic curve less than 30, or double curve where both thoracic and thoracolumbar lumbar curves are more than 40. If the coronal curves are less than 30 degrees, they are not considered to be no major deformity then. But you have to look at the pelvic incidence and the lumbar lordosis. If pelvic incidence minus lumbar lordosis is 0, then, or is giving 0, if it is within 10 degrees. Moderate deformity or moderate mismatch, if it's the mismatch between 10 and 20, or if it's over 20 degrees, then it's a marked mismatch and takes double plus. And you have to look to the sagittal vertical axis. Usually it's about 4 centimeters from the posterolateral superior corner of the S1. If it's less than 4 centimeters, it's fine. If it's between 4 and 9.5, it's +1. If it is more than 9.5 centimeters, then it takes 2+. And also look at the pelvic tilt, less than 20 or between 20 and 30 or more than 30. This gives you a good idea about the spine you are dealing with. But look, these measures are not the same all the time. With increasing age, there is increase in these values. If you are under 35, the pelvic tilt is within around 10.9 degrees. But over 75, it's allowed to be 28. And the mismatch between pelvic incidence and lumbar lordosis also increases. And this sagittal vertical axis, or the plumb line, accepted in people above 75 to reach about 8 centimeters. So it may be natural for elderly patients to have some degrees of positive sagittal vertical axis and compensatory pelvic retroversion. There are some risk factors for this, adult spine deformity, like genetic, smoking, obesity, and prevalence of osteoporosis. And there are risk factors for progression of the curve. If starting with Cobb angle more than 30, or there is asymmetric disc above and below the apical vertebra, later lateral subluxation of the apical vertebra more than 6 millimeters, you have to look at the X-rays for these things. Then you know that this curve is gonna progress rapidly. Or if L5 is located above the intercrestal line, this is a very important point also. And those people with demanding occupations in their middle or early 50s, still doing physically demanding occupation, then there is more possibility for progression of the curves. There are special difficulties with these patients, starting with the age and the medical comorbidities, long operative time and blood loss, disturbed anatomy. Sometimes it's not very easy to put the pedicle screws. And in cases with severe and prolonged stenosis, the dura becomes too thin. So it's easy to injure the dura. Osteoporosis with higher incidence of adjacent fracture, as you see in this case, or loosening of the screws, as you see in this X-ray. The long segment fixation and extension to the pelvis, this is a problem in itself. It takes time, it takes blood. The failure rate of non-union rate is higher than if you do 1 or 2 levels. And there's increased incidence of pseudoarthrosis for this, and adjacent disc problems also. The treatment, usually we start with non-operative treatment if the patient is not fit for surgery and in absence of neurological deficit. You have to try the non-operative treatment. If you have a curve less than 30 or with less than 2 millimeter rotary subluxation. How? By supervised exercise program, core strengthening and postural training, injections, bracing, and medications. This you can usually buy time by these 5 items or 4 items. Then you can give your patient some time before you go to surgery. Treatment surgically is indicated if there is failure of conservative. The patient cannot continue like this without interference, or if there is neural compromise, like distal weakness, or the most annoying symptom for patient is the neurological claudication and limited walking distance. This is the main symptom that drags patients to surgery. Other suggested indications include curves more than 30 to 40 degrees or subluxation, lateral subluxation more than 6 millimeters. Do we have options? Do you have only one surgery? No, we have many options actually. You can always go for minimal decompression in some cases, or you can add limited fusion to the decompressed segments, 2 segments, 3 segments. And you can do decompression with whole lumbar curve instrumentation, or you can extend this to the thoracic spine also if the thoracic deformity also is severe. And you can always include osteotomies if you need to do a correction of the sagittal imbalance. I will not go through all these just for the sake of time. And how to select the fusion levels. If you decide to go for long fusion, then you have to be very careful. Don't stop at the apex of the curve and don't stop at an area of kyphosis. Include all levels of lateral subluxation and rotation. Include all levels of spondylolisthesis and retrolisthesis. If you leave one of these, then there will be very soon adjacent segment degeneration and progression. The upper instrumented vertebra fixed long fusions is strongly recommended. Always remember this figure: pelvic incidence and lumbar lordosis, sagittal, sacral slope, and pelvic tilt. Put these all in mind and measure these before you start. And always remember the sagittal balance, and you have to regain it during surgery. How? Either by doing interbody cages or by doing osteotomies. If the mismatch between lumbar lordosis and pelvic incidence is about 50%, then, or if the deformity is rigid, then you need osteotomy. What type of osteotomy? It depends on your experience. It depends on the case and how much sagittal imbalance you want to regain. We had this study done in NSHAMS, but I don't think it's published yet. I just asked my colleague, Mohammed Zayan, and he said we did not publish it yet. It's 72 cases done between 2005 and 2011. The steps in surgery is decompression, multiple bilateral fenestrations, facetectomies, Smith-Peterson's, fixation, pedicle screws with rigid rod, fusion, facetal fusion, posterolateral fusion with selective interbody fusion, as you can see here, some cages, plus big amount of autogenous iliac graft or local graft. Let me look at the results. The Cobb angle improved from 20-something to 7. Lumbar lordosis improved from 22 to 37. And the mean postoperative osmometry, the ODI score, improved to 21 instead of 50-something. This is good, but the complications were too much also. When you do these cases, always think of the next surgery. It's nearly 24% in this group that they needed surgery within the first 5 years. So your patient should know, and you should know, that you are exposing your patient for another surgery. It's not appendectomy. You do the appendectomy and you go home and everybody's happy. No, you have to keep an eye on these patients because they are always exposed to next surgeries. This one with the very early cases we did. She's a female, 69, back pain, claudication distance very short, multi-level stenosis, mild scoliosis, but she was really miserable. This was done, I think, 13, 14 years ago, and she's still around. She's 80-something years old with this X-ray. Look at the correction of scoliosis and the lumbar lordosis also. Again, this was a young lad, actually relatively young, 59, had 4 levels fusion before presentation, but he presented with a screw pull out and rod injury, rod breakage, plus multi-level stenosis. So we did a wide plus this also is very important, the sagittal imbalance. You can see how much it is. So we did this multi-level decompression cages, interbody grafts. You can see here, this corrected the lordosis, fairly accepted level. Again, 72, claudication pain, and he had a fixation, but you can see that the correction of the lumbar lordosis is not very good. Within few months, he presented with this loosening, and you can see there is destruction of the disc between D12 and L1. Screws at L5 also were loose, and you can see this discitis at D12, L1, and we had to do this surgery, discectomy at D12, L1, cage in this level, correction of the lordosis, and extension of the fixation to the pelvis, plus bigger screws at L1 and L5. Again, similar case, but this actually, after being corrected, she fell at home and presented with a broken L5. So we had to extend our fixation to the ilium through S2 alar iliac screws. Again, similar case. Look at this. If you have this sacralization of L5, sometimes you can stop by doing L5 and S1 screws. You don't need to go to the sacrum. I think this is my own recommendation, actually. I had about 10 cases of this type, scoliosis with long fixation and sacralized L5. I tried to do this without extending the fusion to the ilium, and they did very well, actually, over the past years. Again, so sometimes you can get away without extension of the fixation to the ilium. If you have a tricortical fixation like this one and divergent screws as this, then you have strong distal fixation, or you can, if you have a sacralization, then you can use the screws in L5 and S1. In conclusion, treatment should be tailored individually according to each patient, age, the medical conditions, the disability, social and psychological factors. The goal is to reduce pain and discomfort and improvement of the quality of life. We do decompression. We restore the spinal balance with arthrodesis. Include all levels of lateral lithesis, spondylolisthesis, sagittal or coronal decompensation. You have to consider this is more important than the Cobb angle. Most cases of screw loosening we found that were in patients above 65 with low bone quality. Adjacent segment fracture mostly in females with low bone quality also. And adjacent disc rupture occurs mostly in younger patients with fixation stopping below a healthy disc. There are some suggestions of using the dynamic stabilization systems to decrease the number of revisions, and this is still under investigations. Thank you very much.
Thank you so much, Professor Wafa, for this very nice talk. One question, Professor Wafa, is body mass index and the morbid obesity play a role in your decision?
Yes, sure. If you get this very heavy weight or relatively weight patients, morbid obesity is not in our indications. I mean, no, don't do them. But I mean, even those, if you get a lady with over 90 kilograms, then ask her first to get some weight loss. If you have any neurological problem, then go on and do the surgery. but with the promise and preparations to get her to lose weight. They will come back with loose screws, with non-union, and you'll never get a satisfied patient.
Thank you so much, Professor Wafa, for your talk. The next speaker will be Dr. Muhammad Ramadan, Associate Professor of Orthopedics and Spine Surgery in Tanta University, the dilemma of aging lumbar canal stenosis, an overview for this hot topic. Dr. Muhammad.
Assalamu alaikum. First, let me thank you for having me and giving me the chance to give this talk among esteemed professors. And thank you for having me for the 9th Aging Spine Conference. So my talk for today is about the dilemma of aging lumbar spinal canal stenosis. I have no disclosures. So my objectives for this talk is to appreciate the cause and symptoms of low back pain and spinal canal stenosis in the elderly population. I will try to address the dilemma in diagnosis and treatment and also discuss a few complications about it. So first, lumbar spinal canal stenosis is a common condition in the elderly population, and it's actually considered one of the most common reasons to perform spinal surgery at that critical age. The spine being a part of the human body, it's no different than the knees and hips and other parts of the body. It's progressively affected by the unrelenting aging changes. However, degeneration of the spine is somewhat different, as there is a relation of the spine and the spinal canal with the neural elements. Actually, degenerative disease is by far the most common cause for lumbar spinal stenosis. So we have bulging degenerated intervertebral disc anteriorly with hypertrophied ligamentum flavum. Also, we have a hypertrophy of the facet joints. All these factors, they account for narrowing of the canal. As we all know, the site of compression, it might be central, lateral, or a combination of both. So actually, the degenerative process, it usually begins at the level of the disc with disc degeneration, which leads to biochemical changes. The biochemical changes usually leads to tears and fissuring in the disc, which is ultimate disc herniation, which is responsible actually for the patient's leg pain and radiculopathy and claudications. Also, it's associated with nociceptive nerve fibers, which account for the patient's back pain. Also, as we all know, the facet joints, they undergo degeneration of the cartilage together with laxity and hypertrophy. Also, there is hypertrophy of ligamentum flavum. All these factors, they cause the narrowing of the spinal canal. And they actually lead to some form of instability, which may be in the form of spondylolisthesis or rotary instability, which may lead to some sort of degenerative scoliosis. Going back to a dilemma in defining the condition. So is all narrow canals, are they considered stenotic canals? And actually this was this was demonstrated that lumbar spinal canal stenosis is a pathological condition causing compression of both the neural and vascular contents of the spinal canal. If no compression occurs, then the canal is narrow but not stenotic. What about symptoms? So most of these patients, they present with neurogenic claudication. The patient typically complains of pain in his buttocks or shooting pain down his thigh, which usually happens after walking for a period of time. The pain is usually relieved by sitting down or by lumbar flexion and increased by lumbar extension. The pathophysiology of this phenomena is not entirely understood. However, Porter et al. They propose that claudication may be caused by venous pooling, induced by stenotic impairment of venous drainage at the level of the root, which occurs only if stenosis happens at two or more adjacent levels. Patients with lumbar spinal canal stenosis with spondylolisthesis often have low back pain and other leg numbness or imbalance and sometimes weakness. Our second dilemma is how to diagnose these conditions. So there is no gold standard diagnostic criteria. Diagnosis is usually a combination of history, physical examination, and radiographic images. So there may be the shopping cart sign that we all know. or the fact that pain is usually increased by standing and relieved by sitting. So among this critical group of patients, we have to differentiate the pain that happens in them due to neurogenic claudication from vascular claudication and peripheral neuropathy and other conditions like hip osteoarthritis or trochanteric bursitis. Physical examination is usually very important in these cases. We have to do all our workup from motor, sensory, reflex examination. Also, we have to do assessment of the gait. Also, there is the test, the modified Romberg's maneuver, which is very helpful in lumbar spinal canal stenosis patients, which has specificity of about 91% and sensitivity about 40%. Also, disappearance of pain with flexion, which has specificity of more than 44% and sensitivity less than 80%. Investigations. So usually in these cases, we do plain X-rays. Plain X-rays. Also, they should be. We should do some sort of dynamic X-rays, like flexion extension views. Also, doing a full spine views. CT and MRI. Actually, MRI has a superiority in diagnosis of lumbar spinal canal stenosis when compared to CT. However, we can resort to CT in some cases where MRI is contraindicated. Myelography. So myelography, it's very helpful in diagnosis of spinal canal stenosis. However, its usefulness is restricted by its invasiveness. Electromyography may have a role. However, it's not routinely used in cases of spinal canal stenosis. However, we may use it in some cases where there is peripheral neuropathy, which is usually common among these delicate group of patients. So coming back to the MRI, so specific to spinal degeneration is the fact that although MRI studies showed that almost 80% of individuals more than 70 years will have abnormal stenotic images, while most of them have no symptoms. Also, up to 21% of non-symptomatic subjects more than 60 years will demonstrate stenotic images on MRI. Hence, there is poor correlation between imaging studies and clinical symptoms. Also, autopsy studies shows that degeneration is present in 90 to 100% of subjects above 64 years. So this means that in many cases, spinal degeneration cannot be really considered as a disease, and that the relationship between the patient's complaint and imaging is still to be studied. Coming to a dilemma in treatment. So does non-operative treatment have a role? I think that it has a role. So I don't think that any of us will move to surgery before having non-operative treatment, even for a long period of time in these delicate patients. So many non-operative treatment like lifestyle modification, drugs, physical therapy, rehab, epidural injections, and some form of pain relief medication may be tried in these patients. And actually, a lot of studies have showed that there is comparable satisfaction between non-operative treatment and operative treatment in these patients. What about surgery? So surgical intervention is recommended if symptoms are persistent and they are interfering with the patient's activity. So there is several different kinds of operative treatment. We have decompression alone, which may be in the form of laminectomy or bilateral laminotomies. And we have instrumented decompression. We also have the interspinous spaces. Interspinous spaces, they rely on the fact that the spinal canal is the diameter and we have the spinal fusions. So a lot of studies also, they compared between the uninstrumented and instrumented decompression, and the debate between the value of each of them is a matter of ongoing debate. So let me go to my first case. This is a male patient. He's 67 years old, controlled diabetic. He has a back pain 6 out of 10, leg pain 8 out of 10, failed conservative treatment for many years, has gait disturbance. So we do, we actually, for most of these patients, we do full spine view to detect if there is sagittal imbalance. So there is some form of sagittal imbalance in that patient. Going to the MRI images, we'll have that it shows degeneration and some form of disc herniation, especially at the L3, L4, and L4, L5 levels. Also, we have higher levels at the level of L1, L2. Also, going to the axial cuts, we'll have I think there is obviously obliteration of his canal, also hypertrophied ligamentum flavum and facet hypertrophy. So we decided to do decompression with some form of interbody cages. And as we can see, there is improvement of his sagittal alignment. This is a female, 50 years old, HCV positive. She had back pain and leg pain with failure of conservative treatment for a very long period, for 3 years. So MRI images showing also disc herniations and degeneration at the levels of L3, 4, 4, 5, 5S1. So we did, as I said, we do a full spine views for these cases, and actually she has, I think she has good sagittal alignment. So we did only the stenotic levels with some form of interbody cages. Going back to another case, he's male, 62 years old, diabetic. He had back surgery for spinal canal stenosis in the form of decompression and post-lateral fusion 6 months ago. He presented to us with that image with failure of his instrumentation and penetration of the L2 screws into L1, L2 disc space. So we did extension of his fusion up to the level of T10. So what I'm trying to convey from these cases is that we try to select what is better to these cases. So the debate is not only in what to use, whether to do decompression alone or decompression with fixations. The debate is where to stop and what to use. The bone quality also plays a very important role in these cases, in these delicate patients, due to the fact that osteoporosis is very common among them. Is it risk-free? Actually, in our population, I think that there is a lot of complications might happen in these cases. However, in a recent multi-center prospective study conducted in 7 spinal centers, 270 patients, more than 80 years old, with the aim of investigating perioperative complications of spine surgery in elderly patients above 80. They found that there is no major systemic complications observed in them, that they concluded that it's safe to perform spine surgery at that age. My take-home message is that the lumbar spinal canal stenosis has high prevalence in aged population, and it is the most common reason for them to perform or undergo spine surgery. There is no gold standard diagnostic criteria for them. Diagnosis needs to be comprehensive, relying on patient history, physical examination, and radiographic images. It must be stressed that the so-called stenotic images we all see on the MRI might sometimes happen in symptom-free individuals. Thus, the relationship between degenerative lesions and the importance of abnormal images is still, and patients' complaint is still unclear. Non-operative treatment still have a role, and we still have to try it. Patients only offer surgery if there is persistent symptoms. What to use, whether decompression or to add fusion to that, is an old and persistent controversy. Again, finally, I have to say that a good surgeon does not just concentrate on technical ability, but also on the appropriateness of what you're doing. Thank you.
Thank you so much, Dr. Muhammad, for your nice talk. And due to the time factor, we'll continue the program. And the next speaker will be Dr. Said next, giving us update diagnostic and therapeutic guidelines for intervertebral degenerative disease. Dr. Said.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. I'd like to express my greatest gratitude to Professor Khattab for giving me this chance to be among my eminent professors. and I'll talk today about updated diagnostic and therapeutic guidelines for intervertebral disc disease. Low back pain is the commonest and most important musculoskeletal disorder affecting quality of life in the last years. We have seen in the last presentations, up to 84% of the population complain from low back pain at some time in their life. The most common causes of low back pain are intervertebral disc disease and their associated pathologies. The prevalence of disc degeneration in a study done by Bowden et al. Was at least one lumbar level in 35 and about 35 of subjects between 20 and 40 years, and nearly in all subjects between 60 and 80 years. Degenerative disc disease and prolapsed intervertebral disc are the two commonest forms of intervertebral disc disease. My talk today aims at the broad overview of various diagnostic issues and proposed treatment strategies. The disc degeneration is abnormal structural failure, as we have seen in the last lectures, due to multifactorial contributions as micro or macro trauma or accelerated age-related changes leading to excess catabolic over anabolic responses. A degenerative disc disease is a painful degenerated disc. Prolapsed disc material can be part of the nucleus, annulus, end plates, or combination of the above, leading to significant inflammatory response with nerve root irritation and physical narrowing of the spinal canal. What clinical examination findings consistent with diagnosis of lumbar disc herniation with reticulopathy, with level of recommendation grade A, manual muscle strength testing as compared with the other side, sensory testing, supine straight leg raising test, Glasgow sign and cross Glasgow sign are recommended in diagnosis of lumbar disc herniation. Supine straight leg raising is better than seated straight leg raising with grade of recommendation type B. There was insufficient evidence for use or against of cuff impulse test, hyperextension test, femoral nerve stretch test, lumbar range of movement, or absence of reflexes in diagnosis of lumbar disc herniation. Regarding to the diagnostic imaging, first of all is the plain X-ray. It gives us a good overview of what's happening in the disc. In the first, disc space narrowing, foraminal height narrowing. When advanced, there is anterior posterior osteophyte formation, facet joint arthropathy, and also in the dynamic films gives us about if there is instability or spondylolisthesis. And last one to the right is a vacuum phenomenon, which gives us impulse about severe degeneration of the disc. Regarding MRI, it's diagnostic imaging of study. We have used two main classification systems, giving us about the grading of the severity. Modic changes in the sagittal profile, T1 and T2. In modic change type 1, it's hypoindense end plates in T1 and hyperindense T2. In modic changes type 2, hyperindense T1 and isoindense or hyperindense T2. And in modic changes type 3 are both hypoindense T1 and T2. Ferman classification also gives us about the severity in grade 1 to 3, it's mild to moderate, and 4 to 5, it's advanced degeneration. The most appropriate diagnostic imaging, as I've said, history and physical examination they are suggestive for disc degeneration. We do an MRI, it's the most important and appropriate non-invasive test. If MRI is not conclusive or contraindicated, CT or CT myelography will be the next most appropriate test. Regarding electrodiagnostics, as Professor Ramadan said before, it's not very much important, but we can make the conclusion after MRI is not conclusive, especially somatosensory evoked potential. EMG and F-wave have limited use in lumbar disc herniation. This is a decision flow chart for early degenerative changes from Ferman grade 1 to 3, whether symptomatic or asymptomatic. If symptomatic, we give a trial of conservative treatment. If conservative treatment is successful, it's okay, not a candidate for discography. If failed, it's a candidate for discography. Either discography is positive or negative. If it's negative, as here to the right of the slide, we make also a trial of conservative treatment. And if it's negative, also we can exclude other causes of back pain from other parts of the spinal cord, like cervical spine or thoracic spine, or it's referred from other sources, just like the gynecological or sacroiliac joint pathology. If it's a positive discography, we start with from the right to the left, conservative treatment. If it's not okay, it's going to next step with local injection, local pain generation injection, and it's not working. It's percutaneous intervertebral disc techniques that like endoscopic discectomy, or restorative treatment, just like lower molecular treatment, cell therapy, or growth factor therapy, or gene therapy. If are not every step is not working, we go definitely to the surgery. In the late degenerative disc disease, Ferman grade from 4 to 5, we start first. If it's only back pain, we give a trial of conservative treatment. If it's successful, it's okay. If it's not, we ask for whether the motion preservation is good. We can make disc replacement. If it's not, we go to fusion. If there is no back pain or associated with back pain related neurological compression, we check for predominant disc collapse. If it's yes, we also can go with disc replacement. If it's no, we go to fusion. If it's no with associated discogenic back pain, we go for decompression. Decompression only without instability. In the last step, we check for gross instability. If it's gross instability, we go directly for fusion, decompression, and fusion. So if back pain and a successful trial of conservative treatment, it's okay. It's not a candidate for discography. But if it's tried and failed, we go for discography. Either the discography is negative, as we have said in the last slide, we go for other causes of low back pain and check it. If it's positive, we try also from the right to left with local injection, percutaneous intervertebral disc treatment with radiofrequency ablation or so, or minimally invasive endoscopic discectomy, or finally for fusion. The current treatment strategies are also, I'll go in brief, oral medication, physiotherapy, but there was insufficient evidence for using physiotherapy and spine manipulation as standalone treatment for lumbar disc herniation with radiculopathy. Epidural and periradicular corticosteroid injection can lead to immediate short duration pain relief and functional improvement, but there was no evidence regarding the frequency of injection. Corticosteroid injection is particularly efficient in radicular pain, but it's not efficient for spinal canal stenosis or non-radicular or facet joint arthropathy. So, regarding the role of intervertebral spine procedures, intradiscal electrothermal annuloplasty or percutaneous discectomy, there was insufficient evidence regarding use or against use of intradiscal ozone. Also, regarding endoscopic percutaneous discectomy and endoscopic percutaneous discectomies can be tried as compared with open discectomy. It will lead to early postoperative reduce early postoperative disability and reduce opioid use. Regarding automated percutaneous discectomy, just like we approach with the C-arm or fluoroscope, the disc space, and we indirectly visualize the disc material when we remove with a nucleotome. There was poor evidence regarding its use. And also insufficient evidence for use of percutaneous electrothermal disc compression with radiofrequency ablation or use of ultrasound or low power laser. What are the prognostic factors influencing functional outcome of medical or interventional treatment of lumbar disc herniation? Regarding the patient age, when younger than 40 and shorter duration of symptoms less than 3 months, has a better outcome. When have preoperative signs of psychological distress, such as like somatization or depression, we also have worse outcomes as expected with surgery. When the patient have positive preoperative straight leg raising, it correlates with better outcomes from surgery. When surgical intervention is done before 6 months, in patient with severe symptomatic lumbar disc herniation, it has a faster recovery and improved long-term outcomes. there was insufficient evidence regarding use or against urgent surgery for motor deficits in lumbar disc herniation with radiculopathy. So, what are the predictives of conservative treatment failure in the X-rays or radiology? In MRI, anteroposterior prolapsed disc fragment diameter regarding to the thecal sac. When they are equal, it's likely the patient needs surgery. When CSF flow is plugged or the disc is closer to the foramen away from the midline, mostly the patient will need surgery. When the foramen issue of the normal is relatively to the other herniated disc are too narrow, it's predictive also for necessity for surgery. So the surgical options for intervertebral disc and start with disc herniation. After failure of conservative treatment as usual or significant neurological deficits are these surgical indications. Surgery aimed at decompression of neurological element with removal of herniated disc fragment. Fusion is indicated in selected cases in recurrent disc herniation, spinal canal stenosis, instability or spinal deformity with adjacent segment disease from previous surgery. Well, approaches are so many, and it goes according to surgeon preference and the learning curve of the surgeon. Either open, minimally invasive, microscopic, or endoscopic. Regarding degenerative disc disease with spinal canal stenosis, surgical options are decompression, disc replacement, and fusion. Indication of decompression is spinal canal stenosis after failure of conservative treatment without spinal instability. Total disc replacement is usually done with anterior approach, indicated in degenerative disc disease with stenosis after failed conservative treatment with preserved motility. Spinal fusion, just like the decompression with additional instability. We can use also interbody cages. It will aid wide surface area, decrease the load on the pedicular screws, and also directly restoration of the foraminal height with indirect decompression of the nerve root. And here are the pictures. To the left as interbody fusion with fixation, and to the right is a microscopic discectomy, and to the bottom is disc replacement. Endoscopy is the coming and expected to have less invasiveness with better visualization of disc material. Safely, we can decompress neurological elements with radio frequency to decrease the pain generating nerve as sinovertebral and basivertebral nerves. The surgical options are widely and controversial with mid to low quality of evidence supporting each of the techniques over the other, confounded by the surgical experience, technical expertise of the surgeon, as well as the comorbidity of the patient. Surgical procedure have the risk and complication, hence we delay to be the last after failure of all conservative treatment. The aim of all types of surgery is to provide definitive treatment and maintain long-term pain relief, reduce the complications without further reoperations. And here is the conclusions of my presentation, which aging population intervertebral disc disease is becoming more prevalent and troublesome. Precise diagnosis involves concordant clinical and theoretical findings. Conservative treatment is preferred to surgical treatment in the initial phase of treatment. Local corticosteroid injection is a good diagnostic and short-term therapeutic pain relief option. Surgery last call with choice of decompression, fusion, or disc replacement according to the patient morbidities, surgeon expertise, and hospital equipment. Recent development of endoscopic spine surgery provides new insights in the spinal surgery of the disc and pain management strategies. Here is my reference, and thank you very much.
Thank you so much, Dr. Said, for your nice talk. And now I'd like to invite my dear friend, Dr. Faisal Konbaz, orthopedic spine surgeon practicing in Riyadh, Saudi Arabia, to introduce our dear colleagues and present the Saudi Spine Society team. Dr. Faisal.
Thank you so much, Prof. Khattab. It's our pleasure to be part of this excellent meeting. And we're very happy with the usual collaboration with our colleagues in Egypt, particularly in the Egyptian Scoliosis Society. Next presentation will be by Dr. Anwar Burghali. He's a spine surgeon practicing in Kingdom Hospital in Riyadh. And the title is what is the normal sagittal spine alignment in the elderly? Thank you, Anwar.
Thank you, Dr. Faisal. Thank you, Dr. Khattab, also for the invitation. Actually, my presentation is pre-recorded, so I may ask the team to put it now. Thank you.
Ladies and gentlemen, good evening. I would like to thank the organizing committee for the invitation for this 9th Aging Spine Virtual Conference, and I'm happy to present the following topic. So what is the normal sagittal alignment in the elderly? Sagittal alignment concept enables understanding and treating spinal pathologies, and it depends on the interaction between spinal parameters such as the lumbar lordosis and thoracic kyphosis, and also pelvic parameters such as pelvic incidence, pelvic tilt, and sacral slope. Sagittal alignment also depends on the aging process. In fact, spine degeneration modifies the organization of the curvatures and is responsible for compensation mechanisms. As you can see here on the left side, the X-ray of a normal and healthy young person with nice and harmonic curves, whereas on the right side, we can clearly see how the different curves changed and the spine is globally in a kyphosis shape. Degenerative disease of the spine induces local or global kyphosis, and as Dr. David Pauly said, life is a kyphosing event because progressively with time, because of the degeneration of the bones, the spinal shape becomes more and more kyphotic, and sometimes the person may need an assistance in order to walk properly. So when we start to go through the literature, we may find different papers that are describing this topic. For example, in this paper, normative parameters ranges were described in 160 volunteers, and the results of the elderly were compared to younger adults. They used the EOS imaging system with the 3D reconstruction using the StereOS system. And so thoracic kyphosis, T1 pelvic angle, and SVA were found increasing with age, whereas lumbar lordosis was decreasing. And also asymptomatic scoliosis was found in 27%. So this kind of data may be an important resource for spine surgeons in planning surgical correction of spinal deformities. In this other study, 3D musculoskeletal motion analysis was used to analyze the calculated values of pelvic tilt SVA, pelvic incidence, lumbar lordosis, T1 pelvic angle, and hip flexion angle. So this is actually a dynamic study that takes into account the walking activity. Sagittal parameters significantly changed between the static standing and the dynamic walking. In fact, while walking, the spinal pelvic sagittal alignment deteriorated, where SVA and TPA increased and pelvic tilt decreased. In this study, actually, what was studied was the difference between standing and sitting positions in two populations of young and older people. And so again, they found larger SVA, TPA, thoracic kyphosis, pelvic tilt, and also cervical lordosis was higher. And the difference between the two positions were smaller in the older population, which may show a kind of less flexibility, higher stiffness, less range of motions in the older population. Also in the older population, what was studied was the impact of osteoporotic vertebral column fractures. And in this study, the alignment showed a worse global sagittal alignment with higher TPA and higher GSA, which is the global spinal angle. And also it impacted the quality of life. In fact, the number and severity of vertebral column fractures had a negative influence on the global sagittal alignment directly. This is a very original paper where the impact of soft tissues was studied on the sagittal alignment and compensatory mechanisms. In fact, MRI with 3D reconstruction of 17 muscles around the hips and knee and spine were studied, where muscle volume and percentage of fat infiltration were calculated. There was a direct correlation between the muscles degeneration and the sagittal alignment, as well as compensatory mechanisms recruitment. So this stresses the fact that in addition to the bone degeneration that may create progressive kyphosis and forward positive sagittal alignment, also the muscles degeneration should be taken into account in the elderly population. We cannot actually talk about the sagittal alignment in the older population without mentioning this paper from Rusuli that was published in 2018, where in fact he classified the degeneration process according to the different shapes of the lumbar spine. And so according to the type of spinopelvic setting, we can suggest the tendency for degenerative evolution and pathological alignment. So 11 types of spinal degenerative shapes are described, with 4 main types that were called classical types, antiverted types, retroverted types, and kyphotic types. And so all that was linked to his previous classification that was published in 2005 with 4 types. It was updated in 2017 with a 5th type that was the type 3 antiverted. And so there is globally an increase of types 1 and 2 shapes with age, as type 1 could be a degenerative evolution of low pelvic incidence types, and type 2 could be a degenerative evolution of high pelvic incidence type. So, for example, you can see here that a type 1 lumbar lordosis may evolve to either an accentuated type 1 where there is a higher thoracolumbar kyphosis, or to a global kyphosis of the global spine. Here, the type 2 may evolve to retroverted type 2 with thoracic kyphosis. It may evolve to a type 1 where there is a thoracolumbar kyphosis, or to lumbar kyphosis, as it is shown on the left side X-ray, or also to a global kyphosis. Type 3 and type 4 are the high pelvic incidence patients. And so in this case, what was found in the study is that they may evolve to false retroverted type 2, false type 2 with thoracic kyphosis, or also to a global kyphosis. So the classification may help the surgeon to predict what is the best correction magnitude and what would be the required rod bendings, because in fact, when we have a global kyphosis, it would be restored to a type 1 with a short lordosis when there is a low pelvic incidence. And if it is a type 3 or a type 4, the lumbar lordosis should be longer. And so this will directly impact the intraoperative bending of the rods, for example. This is just one slide for the cervical alignment. In fact, older patients in the different published studies showed a significantly higher C2, C7 cob angle, and also a T1 slope. In fact, the head and neck tend to shift anteriorly with age and become more lordotic in order to maintain forward gaze. And this is, of course, a direct response to the increase of the thoracic kyphosis in order to have a good eyesight in the horizontal plane. Also, we should not forget the hip-spine interaction. And in fact, when there is a higher pelvic tilt, in order to compensate, the hips are forced in extension, and this may impair a hip arthritis or a total hip prosthesis function. And it should be taken into account in case of surgeries. So in conclusion, besides the lumbar lordosis, sagittal alignment parameters are globally increasing with age at the level of the thoracic and cervical spine. This is related to degenerative changes at the level of bones and also of the muscles. Surgery should take into account such changes in order to avoid hypercorrections that may lead to mechanical complications. And it is always difficult to recognize in the current position of the patient what is related to the original anatomy, to the pathological evolution with time, and also sometimes the functional adaptation because of the pain. The only signature of the initial situation is the pelvic incidence. So, of course, we should always calculate the pelvic incidence, but there is also an interest of the degenerative classification published by Rusuli in order to establish a treatment algorithm with age-specific alignment targets. Thank you for your attention.
Thank you so much, Dr. Anwar. Very informative presentation. And we kindly ask the attendees, if you have any questions, you could type it in the Q&A, and Dr. Anwar and the other panelists will be able to answer your questions. Next presentation is Dr. Yahya Al-Gahtani. He's a spine surgeon practicing in Riyadh, and he's a SSS board member, and his presentation is about osteoporosis and vertebral fractures. Thank you, Dr. Yahya.
You are muted. Kindly unmute yourself and do it.
شكرا دكتور فيصل. شكرا دكتور خطاب for inviting me to this conference. My talk will be about osteoporosis and compression fractures. The International Foundation of Osteoporosis had defined the osteoporosis as a silent disease. Why? Because there is over 2 million people worldwide suffering from osteoporosis, more than 8.9 million osteoporotic fracture annually, which means fracture every 3 seconds. 1 in 3 women and 1 in 5 men over age of 50 will experience osteoporotic fracture during their lives, either in the back or hips or the arm. This is the definition of WHO with the rapid aging of the population and the change on the lifestyle, we can see more osteoporotic patients and fractures. So the definition could be summarized to be compromised bone strength that increases the risk of fracture. The epidemiology of osteoporosis is too big, and still we cannot have all the numbers as correct as we can. We will see later why. So these are the epidemiology in 3 continents, Europe, Canada, USA. In Europe in 2010, there was 22 million women and 5.5 million men aged between 50 and 84. Canada, in the USA, there is 10.2 million adults with osteoporosis and 43.4 million with low bone mass. If we gather them together, they will form 50% of the population who are aged more than 50, which means people aged more than 50, half of them either have osteoporosis or low bone density. The epidemiology of fracture is a little bit difficult to measure. Why? Because first we start with the definition of the fracture. What's the fracture? Is it the fracture that lead the patient to come to the clinic and do the X-ray and confirm that there is a fracture, or is it the fracture that was not clinically apparent? So there was any other form of X-rays that discovered the decrease or reduction in the height of the vertebra. And also the diagnostic methods are very different. For example, if we take the morphometric method in this study, which is a big study, the EVIS study, they had the same population, but they used 2 different methods. And we can see here that the incidence is much different between these 2, the Estel and the McCloskey methods. It dropped from 20 to 12. So it's not coherent between all the studies that we can find in the literature. The bone mass, we used to have the idea that it will start to decrease after menopause or after the age of 50. But actually, if we see this study done by Minner, and it starts even earlier, but it starts to decrease at the age of 50 or after the menopause, it starts to decrease more. And we can see here also, it's with age, the vertebral strength is decreasing in a proportion with the age. The incidence, we can see here that the vertebral fracture incidence among the osteoporotic fracture, the spine is leading in men and women until the age of about 75 to 80, and then the hip fracture will take over from there. This is a study, the EPOS study. It's a study done in Europe. There was 14,000 men and women aged 50 years and over recruited from 29 European centers. They repeated X-ray for them for 4 years. And what they concluded that there is 20% or more reduction in the vertebral height at the last X-ray, which means that as more as we aged, we lose more bone mass and be susceptible of vertebral fracture. This is another study also from Europe. It has been, they had 15,000 patients from 19 centers, and they did lateral radiograph for all the 15,000, and then divided them to groups and found that the prevalence is increasing with aging. The problem with the vertebral fracture, as we can see here, in difference with the other fracture caused by osteoporosis, is there is only 30% of vertebral fracture are apparent, which means that we are missing 70% of osteoporotic fracture because it's not causing pain, but it will cause other morbidities to the patient like kyphosis and other problems that we will come later to. And this study also, they have shown that when you have a first fracture, you are at risk of having another fracture. In women aged more than 50, they have 5-fold more risk of getting a fracture, a second fracture after the first one. And as more as fractures you have, as more as the risk increase. This was 4 large RCTs from Canada, from USA, Australia, and New Zealand. This is the definition that we all know of osteoporosis and low bone mass. What we can see in this graph, and what's important is that is the low bone mass. We are more concentrating in the osteoporosis, but we have to recognize the low bone mass also to catch up with easier treatment. We can see here that almost at the age of like 69 to 74, we have almost 80% of the population with low bone mass density. Osteoporosis is not the only fracture, not the only risk factor to have fracture. The highest osteoporotic fracture are in oldest population, in women with or men with the previous fracture, high in those with low bone density, high in very thin people, high in those with comorbidities, and high in patients on steroids, or high on patients who are smoking or using excessive alcohol. The morbidity and the effect that this can cause to the patient life: back pain, loss of height, deformity, reduced pulmonary function, and damaged quality of life, which is very important in the old age patient. They will have loss of self-esteem, distorted body image, dependence on sleeping tablets, sleep disorder, depression, loss of independence. And this study was done and have shown that all vertebral fractures are clinically important, even if they are not presented to the clinic as a fracture. We can see here that no incident fracture and radiological fracture and clinical fracture, they all increase the amount and the severity of pain, the amount of limited activity per day, and the amount of bed rest. The mortality is very high and mostly in spine, also in the vertebral fracture, regardless of the other osteoporotic fracture. And the survival rate in the first year was found to be 75%. And collectively, all limb fractures was higher in patients who had, mortality was higher in patients who have a fracture than general population. It's a global problem, and the cost of osteoporosis is increasing with time because increasing age and diagnosing more cases. In USA, for example, in 1997, there was 13 billion. 2015, there was 19, and in 2050, they are expected to be 25 billion. And what is most interesting is that the second vertebral fracture, this study was done by Taguchi in Japan. The second vertebral fracture treatment costs more than twice when compared to the first fracture treatment cost. In Europe also, fracture-related costs will increase to, this is done by the Broken Bone Society. The fracture-related cost will increase to 37.5 billion euros in 2017 to 47 billion in 2030. This is another issue with osteoporosis. Osteoporosis is more common than most of the disease that can catch the public attention. We can see here that it's more than, in women aged more than 45 years of age, osteoporosis accounts for more days in hospital than many other diseases, including diabetes, myocardial infarction, and breast cancer. This is how much osteoporosis is affecting the population with less attention from our side. The management also, we are losing some patients. This is a paper was published in The Lancet 2019. The prescription of bone protective medication has decreased over the past decade. For example, in USA, from 2001 to 2011, prescription fell from 40% to 21%. Why? There is reasons that the author suggested: fear of adverse effects, issue related to reimbursement, poor coordination of health system, and poor patient adherence to therapy. Osteoporosis is often only diagnosed after the first clinical fracture has occurred, as we say that we have only 30% that we can discover. Early assessment of risk of osteoporosis is very important to prevent the first fracture from the beginning. The measurement of BMD and DIXA is a valid method to diagnose osteoporosis and to predict the risk factor, but a new tool is coming and we should be more oriented to this tool because the studies have shown that using the FRAX system approved by the WHO had reduced the incidence of osteoporotic fracture by 28%. The objective of the treatment is to reduce the likelihood of fragility fracture, strengthening the skeleton, decreasing frequency, or both. By modification in the lifestyle measures, by using pharmacological intervention, and finally by getting the patient more attention by investing in the fracture liaison services. The patient education, this study from Morfield in 2017 showed that educational program for osteoporosis require further investigation to help with RCTs to know exactly where we stand now and what we should do. Intake of enough calcium, vitamin D, and eat a well-balanced diet. This study in 2011 showed that higher protein intake was associated with reduced fall frequency. The goal of the treatment is not only to treat osteoporosis, but treat the patient as a whole. To engage in regular exercise, the exercise has the potential to be a safe and effective way to avert bone loss in postmenopausal women, avoid smoking and alcohol. I will not go through this type of pharmacological treatment, but they have proved that they reduce the vertebral fracture risk by 30 to 70%. The fracture liaison services, it was founded by the International Osteoporosis Foundation. And what it means collectively that we don't lose the patient. The patient comes to the clinic with osteoporotic fracture, and we'll give him the option to have either conservative management or vertebroplasty, kyphoplasty, and then we will see him after a few months and ask only about how is pain and how is he doing. This system was found to get the patient to engage in a circle. So the patient, the physician, the family physician are engaged in a protocol that helps the patient not to lose their follow-ups in their osteoporosis. So the fracture liaison services provide comprehensive assessment and management. It's cost-effective and improve treatment rates and adherence. It's lower refracture rate and mortality with wider coverage is an important priority for the future. In this study, they have shown that programs that improved osteoporosis-related fracture with significant increases in bone mineral density testing, treatment initiation and adherence to treatment, and reduction in refracture incidence and mortality. Thank you very much.
Thank you so much, Dr. Yahya. Very nice presentation. And again, we kindly ask our attendees to write your questions in the Q&A. The next presentation is by Dr. Fahad Abdel-Jabbar. He is a spine surgeon practicing in King Abdulaziz University in Jeddah, and his presentation is about thoracic OPLL. Thank you, Fahad.
Good evening, everyone. I would like to thank Dr. Khattab and the Egyptian Spinal Association for the invitation. I would like to share my screen now. There you go. So is it clear? My presentation is clear to everyone?
Yes, it is clear.
طيب, Bismillah. So I got nothing to disclose. So talking about thoracic OPLL, as we all know that it's a rare entity compared to the cervical OPLL with an estimate prevalence of less than 1%. It's very common in the Eastern Asia that goes up to 4% in China and about 6% in Japan. So the pathogenesis is really poorly understood. Some of the authors suggested that it's a variant of DISH, which is just an idiopathic hyperostosis of the vertebral bodies causing this ossification. It affects more female than the males with a ratio of 2:1 and commonly presents in the 5th or the 6th decade, which makes it more in the elderly age group. And as I mentioned earlier, so OPLL of the cervical spine is more common than the thoracic OPLL. It's multifactorial in etiology. Some of the authors suggested that there is association with genetic and environmental factors. This is one of the cases that I encountered. So a 45-year-old male patient with who presented to the emergency actually with a tandem gait and significant paresthesias in both lower extremities. As you can see, he has myelopathy of the cervical spine, but interestingly, when we did his thoracic MRI, you can see that the significant lesion causing his symptomatology was the big type at between T2 to T4 levels. So you can see in the CT scan in the next slide that it's continuous type with significant compromise of the canal. There is a variant of this disease called the ossification of the ligamentum flavum. It's usually less severe or less symptomatic in patients, but you have to keep that in mind when encountering thoracic OPLL, because some patients, they present with both. What about the classification? So it was proposed by the Japanese Ministry of Health and Welfare. This is the committee who actually proposed the classification based on a lateral radiograph. It's classified into continuous type, like this image over here. There is the segmental type, which actually lies just posterior to the vertebral body. So you can see in this image, there is some calcification of the OPLL or of the PLL actually here. So it's the segmental type. There can be mixed type between both the continuous and the segmental. And there are other types like ossification behind the disc space. So the worst types are usually the continuous types and the mixed types, and usually they progress to significant myelopathy. There is subdivision or subclassification to this based on the morphology of the ossification. So this is the flat type. You see there is no significant protrusion versus this one, the one I just showed earlier. This is the beak type, which is causing significant stenosis, and usually the beak type is associated with worse neurological outcomes. What about the surgical options when you deal with those patients? Unfortunately, when you deal with thoracic OPLL, the non-operative option is less likely successful because of the location of the thoracic spine and the significant narrow canal, as well as the tenuous blood supply in that area. So laminoplasty is one of the options when you just increase the spinal cord or the spinal canal space. You can do a laminectomy with or without fusion. You can do an anterior decompression through a posterior approach, such as transpedicular or costal transversectomy, and just go around the spinal cord trying to decompress it directly. There is also circumferential option by doing staged anterior and posterior approaches. This is one of those examples when you can do the floating piece technique. When you go through the pedicle, you go around the vertebral body and try to detach that ossified segment from the vertebral body, and then using a dissector or a pin field, you can detach it from the anterior aspect of the spinal cord. This is one of the interesting concepts to help you decide whether you have to go from the front or the back. This is called the ossification angle. So it's an angle drawn between the posterior aspect of the vertebral body above the compressed level and the below level. And they call it the alpha angle. So if it's more than 23 degrees, it means you have to go through the anterior decompression, because it means that this segment is really kyphotic, and an indirect decompression will never give the cord any space to swing back, even if you do a laminectomy. So I will take this opportunity to show you our work, which is not published yet. It is in the review process. We did a systematic review looking at the surgical outcomes and complications of anterior and posterior approaches for the treatment of thoracic OPLL, and OLIF, which is the ossification of ligamentum flavum. So the objectives were two questions. So what's the clinical effectiveness and safety of decompression alone compared with decompression and fusion? And the second question, what are the risk factors associated with poor outcomes in those patients' population? So we did a review of the databases until February 2020. This is our PICO table. I'm not going to go through that, but we came out with 15 studies. So key question one, we had 5 studies and 15 studies for the second question. So as you can see, all of the evidence of those papers are class 3 evidence. So to start with, the evidence grade is not amazing. And our results showed that there is no difference between posterior decompression and posterior fusion in the JOA recovery ratio in the long-term patients with thoracic OPLL and OLIF. This is the pooled. And looking at this table, at the possible risk factors to determine worst outcome, there might be, so 2 papers said that diabetes and the middle thoracic spine ossification are risk factors for poor outcome. Decompression alone as well is one of the prognostic indicator of a worst outcome, and estimated blood loss as well. So if you look at this, the JOA recovery in the area postoperative period, there was no difference between posterior fusion or posterior decompression. But if you look at the follow-up neurological deficit recovery,
we cannot hear you.
Hello? Can you hear me?
Go ahead, Fahd, we can hear you.
Yeah, so for the long-term follow-up of neurological deficit, our data suggested that posterior fusion along with decompression has better outcome. What about CSF leak? It's more evident, like you have more CSF leak with posterior spinal fusion group. When the infection is obviously more with the instrumentation group, and operative time is less in the decompression group. And the overall complication rate favors doing a posterior fusion compared to the decompression. So the evidence summary, I know it's a lot of information. There was no difference between posterior decompression and posterior fusion in the postoperative period. But however, in 2 studies, the long-term neurological deficit was more evident in the decompression group only. And I think this concept is very evident even in the cervical OPLL, because adding an instrumentation will limit the progression of the disease. No risk factor associated with a low recovery ratio and a longer duration of symptom was one of them, was found to be associated with lower GOI recovery. So there are limitations. So this systematic review suffers from the lack of studies comparing decompression to decompression with fusion in OPLL and OLF patients like separately. And the study designs only, like we included 5 studies, so there is not much in the literature. And all prognostic studies were phase 1 explanatory studies with small sample sizes. And I just wanted to compare our findings to the cervical OPLL findings in the literature. So this is a systematic or a meta-analysis done for the cervical OPLL. They actually concluded the same conclusion. So the decompression and fusion has higher recovery rate and lower incidence of OPLL progression, as well as less deterioration compared to decompression alone. So this is one of the algorithms we came up with after doing this systematic review. So if you have a thoracic myelopathy, if it's an OLF patient, you just do a simple decompression. If the patient has changes on the MEP, then you can do a posterior spinal fusion. If the patient has OPLL without OLF, then you do a posterior decompression, and then you have 2 options. If you have a change in the MEP, we have to do a posterior spinal fusion. And if we have inadequate decompression on ultrasound, so this is one of the nicest techniques to know whether you had a nice indirect, a nice direct decompression or no. Then if you did not have significant or enough decompression on the ultrasound, it means you have to go through either a transpedicular approach or through a second stage doing an anterior direct decompression. So this is an ultrasound image. So in the upper image here, so this is the axial and this is the sagittal. You see the OPLL compressing here over the spinal cord, and there is no echo free space anterior to the spinal cord. And here, after the decompression, you can see there is an echo free space just anterior to the cord. And this is the axial image compared to this. So the spinal cord actually is this part over here. And it was compressed in the axial cut compared to the other one. So my take-home message to the attendees: so there is lack of evidence to determine which approach is more effective, but I would recommend to consider that fusion is better option for those patients as it's clearly can stop the progression of the disease. This is my last slide. I would like to thank again the organizing committee for this event and for having us, and I'll be happy to receive any questions. Thank you.
Thank you so much, Fahad. Very nice presentation and very challenging topic. Next, we'll be changing now the topics to cervical spine. It's my pleasure to present Dr. Mohammed Khashab. He's assistant professor at King Salman Abdulaziz University of Health Sciences in Jeddah, Saudi Arabia. And his talk is about minimally invasive surgical treatment options for cervical radiculopathy in elderly.
Thank you, Faisal, for the introduction. And I would like to take this opportunity and thank the organizing committee for this kind invitation. And I will shift the whole talks from major topics to a minor one. So minimal invasive is totally different shift from all those major and wild big procedure to a minimal invasive one. So simply, any one of us will be probably faced with something similar to this. An elderly who comes to you with the classical symptoms and sign of cervical radiculopathy, previous multiple neck procedures. You can see the clips all over the place there, and comorbidities, you name it, hypertension, diabetes, ischemic heart disease, and on Plavix, and a lot of issues that really want to hold our hands away from intervention. And you do your best in trying to manage this patient non-surgically, but things is not going well. You look at the images and you can see typical findings that is really going with the reticulopathy that failed conservative care. DF has been a good run for such a procedure. It's been there for a long time and reliable and effective and up to the point. But sometimes we might think of doing another procedure, which is a motion preservative. It was one of the attractive procedures to keep the motion segment, but we learn over time that this procedure is not for everybody. We have a specific indications to think of that, but not anyone who can go for that. Both of them can be done, but it needs to have a good surgical dissection to be visualizing the site where you want to operate on. And that's never without the possible complication, which is related to the approach itself, with all the vital structures in the way, especially with the previous surgical procedures and the scarring, as well as sometimes the implant itself, if it's dislodged or causing some issues, that might be a problem. Long term of it with the PGK is always a concern to worry about. So can we think of any other options that will get away with just hit and run for the target procedure with the least intervention to the body? That's where the minimal invasive procedures came in. So what you need to do is what we call a target surgery. So you do the same target goal like an open procedure with the least iatrogenic with what we call anterior cervical foraminotomy. This procedure has been there for some time and has been described with two approaches, which is microscopic or endoscopic. You could drop the axis through a tube. This is typically a case where you have a foraminal disc that is there and it's a soft. You could approach it from the front by dropping the tube, have a direct visualization with the use of microscope or endoscope. And then in order to reach to that level, you need to drill on the uncinate process at the oncovertebral in order to reach to the fragment and then extract the fragment and then have the approach done similar to this view on the CT. So such a procedure, it's good when you have just a unilateral foraminal disc, but it's impossible to reach to the other side if you have another fragment there. It's technically demanding. And the approach itself, has some pressure effect. So on the adjacent nerves, so the commonest is recurrent laryngeal nerve, which is at risk for problem, as well as being on the coli, and you try to dissect it more and you'll be fiddling with the coli. So Horner syndrome might develop. So flipping the direction through the back, so you could do the open or minimal invasive foraminotomy. Laminoforaminotomy has been there for a long time, done with the traditional open approach or the minimal invasive approach. A similar concept, you get to the side with the blunt tubular retractors, and then the visualization can be done with either the endoscope or the microscope, and done with the direct visualization of the side, and then accomplished with a good decompression of the nerve of interest. Such a procedure, when it's done as a minimal invasive, it's a bit technically demanding as well. It needs some learning curve. And those patients who has neck pain, which is a predominant, is not probably a good candidate for such a procedure, because with that drilling, that might take some part of the facet, which is less than a 50%, has to be to that limit, can sometimes increase the pain post-operatively, and some sort of instability might develop as well in a few patients. The nerve root palsy of C5 or even C6 is always there a risk whenever we operate around that level, whether it's from the front, from the back, open, minimal invasive, whatever. So nerve palsy is a common complication. Another technique was called cervical facet distraction, is known for us. We sent those patients to rehab, and the physiotherapists, they do that technique. They apply some sort of traction on the neck. Patients come back to us and they say, the pain is completely improved with those techniques. And there are some device called spinal cord decompression device, or whatever they call it. The physiotherapists keep on changing the names on that decompression device. It's helpful in applying the same traction with the good practitioners. So from that technique, it drives the interest of the surgeons to think of distracting the facet. Probably that's going to help. So Goel in 2011 came up with his study that he looked at a 36 patient with radiculopathy and even myelopathy, and applied those kind of spaces in the facet. And what happens is he got a very impressive results, and about 70% of his patient got an excellent outcome, and no poor outcome at all among his group. And those spaces placed in the facet actually gain a volume of improvement in the foramen as well as in the cross-sectional level around the spinal cord. And another device that came about 10 years ago is called G-Trax. So that device is a shim that is placed along the inclination of the facet, and then a screw is driven through that shim, make it open, and then hooked inside the facet. Bruce McCormick came up with a study in 2013. Results were about 60 patients included in that study. I'm followed up for 1 year. And the procedure was targeted a patient with a cervical radiculopathy of a single level. And the primary outcome was a clinical and radiographic outcome. And the secondary objectives were the safety of such a procedure with the selection criteria. And then the procedure was done, but over the 2 years' time, and then the procedure did not have a control arm in that pilot study. The selection criteria was mainly a cervical radiculopathy for a single level, and they've excluded the myelopathy and any deformity of kyphosis, scoliosis, osteoporosis, instability, and inflammatory joint disease, that kind, or the worker compensation as well, in addition to infection. So the results of the Neck Disability Index and SF36, as well as the BAS, all were supportive for a good results. So that technique is actually utilizing a few tools to help you reach to the side. You would need a good control of the visualization with double C-arm in order to see what you want to do. So you can reach percutaneously with a single skin incision on both sides of about 1 centimeter skin snip. And then you do everything under the help of the C-arm, dropping that shim in with the screw driven in that will hook in the facet after you prepare that facet with the decortication internally and externally. And you would need to add some injectable bone graft or even aspirate the crest to have autogenous bone grafting. So such a procedure was done in this specific case, applying the screws at this two symptomatic level based on the clinical condition and radiological. And those two shims gave an improvement of the volume, which you can appreciate this on looking at the plain x-rays, look at the anchovertebral joints on this preoperatively, and look at them post-operatively after placement of those shims. It does really improve the volume of that level. And clinically, the patient usually get better immediately with the arm pain, which is a sign of the radiculopathy. So in conclusion, we know that degenerative cervical spine is a common consequence of the aging process, and patients with disabling neck pain, arm pain with radiculopathy might be a good candidate for surgical intervention. The main goal of MIS is to do a target efficient surgery with less trauma. Surgical invasiveness has to be minimized mainly, but that shouldn't be on the main target and goal of the target surgery. So the goal has to be kept exactly like an open procedure, but with the least trauma as much as possible. With this, I will end up my presentation. Thank you all for listening.
Thank you so much, Dr. Khashab. Thank you for sticking to the time as well. And we could have a few questions or comments from the panelists or the audience to any of the previous presentations that were done.
Good evening. So my question was actually for Dr. Mohammed Khashab. Thank you so much for the very nice and interesting presentation. So my question was, have you ever had any problems with dislodgement of these devices?
Yeah, thank you very much for the question. Actually, we had a fracture in one of the facets with the placement, and this was a case that has some osteoporosis, and that by sticking to the main indication, you could probably just not involve in that as an indication, but it was done only in one side. So we end up just putting her on a neck collar for a couple of weeks, and fracture is going to heal, as you know, the cervical facet, and that's end up with healing around that implant without any problem. So it went well without any further consequences. But that is something to be considered. So selection of the patient might be, if you stick to the main criteria, which is specific cervical radiculopathy without osteoporosis, and sticking to a single level, or we've expanded our indications to a double level. And to my limits of experience in this kind of cases, limited experience so far, it seems to be impressive as a start.
There is a question or comment regarding Dr. Fahd Abdul Jabbar presentation. There is some literature that advocates that even plasty or laminectomy for ossification of the posterior longitudinal ligament in the cervical spine, we need to fix, because there are many cases that may progress even of the pathology. So may we practice the same in the thoracic OPLL?
Yeah, so I agree with your comment, and this was the core message from my presentation. Despite the conflicting evidence, so there were 5 studies that looked at the outcome. Only 2 of those recommended the fusion, but when we pulled the data for the systematic review, it came out significant, because the 2 studies which recommended the fusion had more cases. So I believe that fusion makes more sense, because it actually reverses the hyper mobility or instability that might cause more bone formation at that level, or progression of the OPLL, I think.
So we have no more questions. So thank you so much.
I have a question for Dr. Khashab, actually.
Yes, please.
So, Dr. Khashab, I have no experience whatsoever with those facet spacers, but I was just thinking about them and the cervical alignment. Do you think those spacers might affect the cervical lordosis or push the patient more into kyphosis?
Yeah, thank you very much for your question. It does. Each segment you apply this, you're going to lose some sort of lordosis. So as a selection criteria, you need to think that you get your patient with a normal lordosis or at least a straight spine, but not kyphosis. Because what you've noted, what you're going to see immediately post-operatively, you're going to see some segmental kyphotic angle, which is looking at the whole global spine, global cervical spine, you would see a good compensation. But at the end of the year on follow-up, what you see is like a subsidence, I've noticed, at that level. So the angle that you use in the beginning, you get the changes over time with the fusion in that facet, with the continuation of the same improvement in the cervical radiculopathy. But this is something to be kept in mind as an indication. I think that has to be always outweigh risk and benefit of selecting this procedure with the standard procedure, which is the ACDF. The angle itself, you could always go back and correct from the front if you think that caused a problem. And putting the patient through a revision with these kind of procedures is never without any issues. So I think as a minimal invasive procedure, it still has its own target.
Great. Thank you, Dr. Khashab.
Thank you so much.
I have a question, Dr. Khattab.
Yeah, Dr. Waf.
It's a question to Dr. Borgli Anwar. Can you just tell us in short how much would you bend your rod when you are fixing all patients with to the pelvis? I mean, if you do long fixation, I mean, practically, what would you do in theater?
Actually, regarding the rod bending, actually, it's a very good question because we always want to give the maximum lordosis possible. But honestly, in old people, usually I don't try to overcorrect to avoid putting overload on the screws, especially the proximal screws. I try actually to do my decompression, my eventually SPOs, ponte osteotomies. And after that, I try as much as possible just to put the rod as it is, put it down without forcing, eventually just at the proximal screws to have the best curve possible. But I avoid actually using the reduction towers to force the rod inside the screw heads. So as much as possible to put it smoothly inside the back, especially if the patient is over 60. So in this case, I try to avoid overbending.
Okay, thank you.
Prof. Khattab, can I please place one question to Prof. Wafa?
Yes, please.
I would like to congratulate Prof. Wafa for the cases that you presented. It's marvelous and excellent outcome. My only question is, how would you select your patient and when to say sorry for the patient who cannot go for a surgical procedure? Would you do any preoperative assessment to select your patients, especially majority of them, as you know, elderly with comorbidities, and then bone density is not the best. So how would you come up with a decision, which I find it myself is really hard to make?
Yes, you're right. It's first you have to postpone this surgery as much as you can. So use your conservative measures for as long as possible. So long as the patient is coping with the pain with some medications and doing his activities, whatever he's doing, because sometimes this, when you say activities, sometimes you get these patients in mid-50s and they are still working. They still have to go in to work every day, and maybe they are. I have this in one of the nurses. She's doing really demanding, physically demanding occupation, and so this is the first. Second, you have to know that this is not end of story. It's a progressive disease. It's going on and on. The degeneration will never stop. Probably it will become even faster than without your fixation. Then you have to discuss this with your patient and discuss, and you know that this he might be coming for another surgery. As I said, in the first 5 years, 24% presented for another surgery. And the third point is improve the bone quality. If you can postpone for a few months and you add something like Forteo or teriparatide, this is very helpful. Also, the teriparatide postoperatively is very helpful. It helps in forming new bones and in the healing of the bone grafts and the posterior fusion. How we choose, the most important point is the ability of the patient to cope with his symptoms. If not, then we put him to surgery. And the most important and the most annoying symptom is the claudication. The claudication pain and the repeated falls is probably what you cannot say no to them, but always say postpone it, take some more time before surgery.
Thank you very much.
Thank you so much, Professor Wafa, for your comments. And last but not least, we are happy to invite Professor Al-Hawari to tell us more details about the neuropathic back pain. Is it a real disease?
Good evening, everybody. Neuropathic low back pain. I'm sure some of you don't think it really exists. What is this neuropathic low back pain? I would say more than 5 years ago, I wouldn't diagnose this. So I was losing like 20% of my patients by not diagnosing that disease. We'll start with this case. She was a 45-year-old female. She's a teacher. She had low back pain for 6 months, no sciatica, occasional left foot burning, sleepless night, overreactive to examination. She had a normal range of motion. Straight leg raising was negative. No neurology. I'll tell you, 10 years ago, I would diagnose this as a psychic patient. She's a female. She's a teacher. She's overweight. She has left foot numbness. She doesn't sleep the night, but she has normal straight leg raising, no neurology, normal range of motion. She's overreactive to examination. When you touch her, she flips. So I would say she's psychic. Let's see if I'm right or wrong. So what would you diagnose this case based on the symptoms on the X-ray? Would you say it's a lumbar disc prolapse at the L4-5, L5S1? Or you would say it's degenerative disc disease, L4S1? Or because of L3-4 is grayish, so maybe it's DDD L3S1? Or is it neuropathic pain? Does this exist? And what would you treat if you don't know that it's the neuropathic pain? Would you give a non-pharmacological treatment? We all do. Would you offer surgery? Would you do compress? Why do compress? It doesn't have any like symptoms. She has got numbness. Or you fuse because she has got a black disc. Would you give her non-steroidals? Would non-steroidals work with her? Or you give her muscle relaxant?
and she doesn't have any spasticity in the muscles, she has got normal range of motion, would you still give her muscle relaxant? Would you give her paracetamol? Does paracetamol work in such a case? Opioids. Are you ashamed to give her opioids? Is that a line of treatment accepted? Would you give her pregabalin? Does she have sciatica? Why would you give her pregabalin? Or duloxetine or whatever of these neuropathic pain relievers? So, or would you give her antidepressants? She doesn't sleep at night, or maybe she's psychic. So there's a lot of dilemma about such a case, although this is what we see every day in our clinic. So the learning objectives of this talk is to differentiate between the types of pain, to identify neuropathic pain as a component in low back pain, and to know the treatment guidelines for neuropathic pain. So what is the sequence of pain? You have acute pain and chronic pain. Acute pain, you have a stimulus, you get pain, and this usually stays less than a month. And usually this is the time needed for the tissues to repair or to subside. And usually it doesn't take more than a month. And the purpose of pain is good for the patient to allow him to rest, not to use his part. So it's good for the patient. And usually it heals and then the patient gets better. But what's chronic pain? The pain stays more than 3 months. It doesn't have a purpose. Why is still painful? There is no healing. Healing has already occurred. Why does it? There's nothing which can take 3 months or 6 months to heal. And it doesn't have any protective function, but it degrades health and function. So neuropathic pain is a pain caused either by the peripheral or the central. And it has got signs and symptoms, spontaneous symptoms, and stimulus only when a stimulus evoked. Spontaneous symptoms, we hear it every day, like persistent burning, intermittent shock-like lacenating pain, or dysthesias like unpleasant sensation, shooting sensation, or parathesias like tingling, prickling, buzzing sensation, which sometimes called pins and needles. Or you have symptoms only when the patient is stimulated or evoked, like allodynia. Allodynia is pain due to a stimulus that does not normally provoke pain. When you pinch the patient, small pinch, this doesn't normally pain. Then the patient shouts and it's so painful, this allodynia. Hyperalgesia is a pain from a stimulus that normally provokes pain. When you do a prick of a needle, then the patient says it's really hurting. Hyperpathia is abnormal painful reaction to stimulus, especially of repetitive stimulus. When you put do a needle prick and do it several times, the patient gets more and more pain. This is hyperpathia. So neuropathic pain is not just pain, it's pain. It has got sleep disturbance in 60% of patients, and it has got mood. This will lead to mood disturbance. More than 25% of patients has reported moderate to very severe discomfort from anxiety or depression or mixed anxiety and depression. So it's like a vicious circle or a triangle, and it's you have to stop it at one of the sides of the triangle. What's the burden of neuropathic pain? You know that 60% of patients can experience difficulty in sleeping, 58% can have lack of energy, 40% can have drowsiness, 36% can have difficulty in concentrating, 35% have depression, 28% can have anxiety, and 18% can have lack of appetite. So it's a big burden. Chronic low back pain is more or less neuropathic pain. I'll give you an example. You go every day every month to have your money from where you're working, and then if you just wait 2 or 3 months and you go, your money is not there because it has shifted to another place. It's shifted. You cannot cash it from the cashier. It's not there. So this is chronic pain. It's no longer in the back. It's now in the brain. So what you want to treat? You want to treat the brain, not the back. The prevalence is high. It's 16% in men, 22% in women. And the lifetime prevalence is 24 in men and 30 in women. So it's really a real problem. And the components of chronic low back pain could be nociceptive, or could be local neuropathic pain, or could be neuropathic root pain. That's why this patient had foot numbness, although she doesn't have any negative straight leg raising. So how do you get nociceptive pain and chronic back pain? You get arthritis of the facet joints. This activates the this activates the C fibers. This gives nociceptive pain. Or if you have a damaged disc, the C fibers sprouting the damaged disc are stimulated. You have chronic activation of these C fibers, and you have nociceptive pain. It's not neuropathic pain. That's why in low back pain, you get back pain without neuropathic symptoms. Or you can get local neuropathic pain. Sometimes you get an X-ray or an MRI in a patient with leg pain or neuropathic pain, and it's normal. So why is this patient has an irritated nerve root? Because of the facet joint damage, then there is a local release of inflammatory mediators. This will stimulate the chemical C fibers and produce local neuropathic pain. Or again, the damaged disc will has got a C fiber sprouting in this damaged disc, and it presses on the damage on the fibers, and they get mechanical C fiber damage with local neuropathic pain. But most of the time you get neuropathic root pain. You get root pain without any MRI of a disc pressing on a nerve. Why you get that? You have a lumbar disc herniation. You get release of the inflammatory mediators from the degenerative disc. You get inflammatory nerve root damage, and you get inflammatory neuropathic root pain. Like this case we've seen, there's the disc. There is no disc pressing on the nerve, but the patient has got foot numbness, and this from neuropathic root pain. So how do you diagnose a neuropathic pain in low back pain? Examination, history. This is the most crucial thing. We hear from the patient saying, "I have pins and needles in the foot. I have burning sensation," and we take it for granted, and we don't pay attention. Although this is the clue for the patient's symptoms as a neuropathic pain. We must know since when you have the pain. Less than a month is acute, more than 3 months is chronic. What's the frequency? And then is there tingling, electric shock, numbness, burning? All these symptoms is for neuropathic pain. And we can now quantify pain. Before we cannot, but now we can quantify it. We can quantify it by using the visual analog scale. We can quantify it by using the scores. We have Oswald Disability Index. We have other scores. So now we can quantify back pain or leg pain. These are the common verbal descriptions of neuropathic pain: burning, tingling, shooting, electric shock-like, numbness. So pay attention to these symptoms, because this will be the clue for neuropathic pain diagnosis. And then you have to do very simple things. It's not costly. It's present in every clinic. You can have a piece of gauze. You can have a pinprick. You have a pinch, thermal, hot or cold object. And so you can use this, and you can confirm the neuropathic pain. So you don't have to buy any instruments. All of these instruments, you have it in your office. So what's the management of neuropathic component of back pain? You have to recognize it and manage the cause of the pain. You have to reduce the symptoms, and you have to use appropriate pharmacological therapy. Non-steroids does not affect neuropathic pain. And we all use non-steroids as a routine in each prescription. But in neuropathic pain, it doesn't work. Muscle relaxants doesn't work unless you have muscle spasm. Otherwise, they won't work. And you have to address the psychological stresses. You remember to the triangle, two components of this triangle was depression and sleepless nights. So you have to address these stresses. There are non-pharmacological treatments like physiotherapy, pain management programs, acupuncture, TENS, transcutaneous electric stimulation. All this can work. And there are pharmacology. And again, we have guidelines. We have the European Federation of Neurological Societies. We have the International Association of the Study of Pain. We have the Canadian Pain Society. And they have put guidelines for treatment of neuropathic pain. They have put a first line recommendation and a second line. First line, most of them agree to pregabalin, gabapentin, duloxetine. And in the second line, they agree for tramadol, opioids, capsaicin. So more or less, they are all agreed as a pregabalin, duloxetine to be used for neuropathic pain. What's the drawbacks of the current treatment we have? They are delayed in action. It takes long time for it to work. It doesn't work in the same day the patient will take it. The number to be treated is high. There's no direct effect on the mood. Sometimes they can produce poor quality of life. They can produce drowsiness. They can produce sometimes they can affect the sleep. So you have to, there are many drugs and you have to choose and wait for them to work. You cannot get the patient after 2 weeks and they will tell you it's not working. You have to wait more. And you have the privilege of increasing the dose. Most of these drugs, you can increase the dose until you get the maximum effect of the treatment. So if you go back to this case, 45-year female has low back pain for 6 months. So it's chronic pain. She has no sciatica, so there is no need to do surgery, no need to do decompression. She has occasional left foot burning. So if you omit this out and you don't hear the patient complain, you lost the case. And sleepless night, she's not psychic. Yes, sleepless night because this is neuropathic pain. She's overreactive to examination. This is a part of the anxiety, and she's not psychic again. She has got normal range of motion, so doesn't need muscle relaxant. She doesn't have a positive straight leg raising, so she doesn't need a decompression, and she has no neurology. So what's the diagnosis? Yes, she has got degenerative disc disease, but with a neuropathic component. And what we gave her pregabalin, tramadol for 2 weeks, and antidepressants. And after the months, she was better. So what's the take-home message? 10% of adults suffer from chronic low back pain, and a neuropathic component may be present in 20 to 35% of these patients. So if you don't address the neuropathic component, you will lose 20 to 35 of your patients. A simple, stepwise approach to diagnosis may help to differentiate between neuropathic pain and nociceptive pain. Patients with back pain should be screened for a neuropathic component. And I'm sure this case, most of you would have given her non-steroids, and non-steroids will not work. Evidence-based treatment guidelines propose pregabalins and duloxetine for neuropathic components of back pain. Thank you very much.
Thank you so much, Professor Hawari, for this informative talk. There is a question from one of the attendees asking about what is the commonest cause of low back pain in general?
In general, it's muscular or non-specific. This is what we all get. And the rare lesions like disc prolapse or tumors, they are rare. But most of the low back pain comes from just you strained your back. You have what we call lumbago. Actually, lumbago is lumbar pain. It doesn't tell you anything. But most of I would say 90% of these cases of low back pain are non-specific, and they will just give it like 2 to 3 weeks and it will go away.
Thank you, Professor Hawari, for this game-changing presentation. Most of us get these patients in our clinics, and they start, as you said, by non-steroidal anti-inflammatories. So the patient comes to me after 3 or 4 months on medical treatment. He has received the pregabalins or gabapentins, which are available right now. Some of them might have been on duloxetine. Now the patient has been on medication for 4 or 5 months, and he's still complaining. So what's our next step? What can we offer him?
I would go for psychological assessment and try to target this psychological problem by other medications like amitriptyline or triptizone.
So we go back to considering that there is a psychological element to it.
Yeah, it's one side of the triangle.
Yeah. So do you recommend antidepressants to start medication with antidepressants as well as gabapentins and duloxetines?
Some of the neuropathic pain relievers, they have a higher concentration of antidepressants, and like venlafaxine. Pregabalin has a low effect on mood. So I would go either to combine the pregabalin with antidepressant or go to one of the new venlafaxine drugs.
Thank you so much.
The last question, Dr. Yusri, regarding for how long you prescribe the pregabalins and antidepressants for neuropathic low back pain?
As long as it gets. Sometimes I think the minimum will be like 6 weeks, and as long as the patient needs it, because there is no side effects of prolonged use. And the good thing, our pregabalins, you start with 75 twice. There is nothing called 75 once. The minimum dose is 75 milligram twice, and then you can go up to 300 milligram twice. So the maximum dose is 600. So you can go from 150 to 600. So you have a good range to increase your dosage.
Thank you so much, Professor Hawari. And I'd like to thank the faculty for this webinar and the Saudi Spine Society for their active participation. And this is the end of this webinar, and we'll give 5 minutes to stretch our legs and drink something and come back for the endoscopic spine approach webinar. We'll have great friends from all over the world to give updated endoscopic approaches, technique, indications, and techniques. Thank you so much.
السلام عليكم دكتور حاتم بيه. أنا مش سامعك. أيوه
يا باشا سامعني.
أيوه
سامعني يا باشا، ازيك؟
أيوه السلام عليكم ورحمة الله. شو الأخبار؟ تمام
كده يا باشا.
10/10.
اديني يا مريم.
مش عارف دكتور محمد السوس مش معانا.
تمام. بص خلينا نعمل تيست بس كده الحاجه. تمام في حاجه شغاله.
سامعني ها؟
ده اعلانات.
دكتور صالح،
السلام عليكم.
دكتور سوس،
باشا.
السلام عليكم.
منورين.
ازيك يا خطاب عامل ايه؟
معلش بس هناخد 5 minutes.
لا 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 ولا يهمك ولا يهمك مفيش مشاكل.
عايز اقول لك ان انا نعست.
اجل يا باشا اجل يا باشا.
شربت واحد قهوه عشان افوق.
قول لي بس اول شيء مساكم بالخير، اخيرا شفنا
ايوه السلام عليكم. السلام عليكم ورحمه الله
باشا
وبركاته.
باشا تحياتي. حمدي ازيك؟
الله يخليك يا
ازيك دكتور محمد؟
الله يخليك. ايش البلان للسيشن؟ انا ما عنديش البروجرام للاسف يعني.
احنا كلنا جايين وراك.
الدكتور حسن هيقول توك كده عن الادجيسنت سيجمنت، وبعدين الفونسو مسجل توك على الفورامينوبلاستي، وبعدين حضرتك نص ساعه.
دان
فهي تقريبا
هم 10 دقائق ربع ساعه. انا هي كيس برزنتيشن، حاله من ضمن الحالات اللي اشتغلناها كانت adjacent segment degeneration ديسك prolapse، ست كبيره في السن وريفيوزنج الفيوجن وما عندهاش instability symptoms وجاست راديكولوباثي، والكومباريزون ما بين ان انت تخش تعمل ديكومبريشن الون مايكروسكوبيك ولا مايكرو سيرجيكال، مع ان انت تشيل الفلافم والفاسيد جوينت واللامينا وكل دوت، ولا ان انت تخش اندوسكوبيك وتشيل هي القصه كلها ان احنا بنبعت مسج انه بنحاول نقول يا اخوانا الفيوجن is not always the solution يعني and we have a good option for treatment of such cases.
عظيم. I think this is a significant message للاندوسكوب الحقيقه and diffusion.
انا والله جاي اسمع الانجليزي بتاعك يا دكتور.
حبيبي انا عايز اسمع الالماني بتاعك.
لا يا عم لا ما ينفعش.
فالفيوجن فانت يو ديفير الفيوجن. يعني انا عندي كيس L1 L2 هاي كومبرومايز في الكنال، في ست معمولها من L2 ل S1 وشي هاز ويكنس بالليجز، ما عندهاش محل باك بين. So I did the transforaminal L1 L2 and she's excellent. فمش كل الناس اللي بيصير عندهم adjacent level disease which is very common بالضروري تعمل extension للفيوجن، يعني بتدخل بها
محمد
الدوامه.
احنا نذكر بالفضل ربنا يبارك له الدكتور حاتم بيه حمدي، ده اخويا وصديقي من سنين، ان هو فتح امامي السكه ديت وحببني فيها، وبعد كده والله ربنا يجازيك انت كل خير ان احنا حضرنا كذا ويبينار معاك، لانه انتوا الاثنين ربنا يبارك لكم ما حدش بيخبي اسرار. انت عارف كويس الواحد بيروح يحضر كورس يدفع فلوس وزي ما طلع زي ما دخل ما استفادش حاجه، لكن انا من مجرد الويبينار ان الواحد يبقى انترستد ويحاول ويبتدي، وهذا هو الدليل اهو.
يا سلام استنى اعمل لك ماجنيفيكيشن. وريني ايدي يا سلام. الله عظيم
بيهم حياتي حبي الاول والاخير. شوف يا استاذ محمد بهزر، لكن ده يعني جيم تشينجينج برنسبل، انه احنا بندخل ازاي من الفورامينا without injuring the ligamentous apparatus ولا الفاسيد جوينت ولا الليجامنت ولا الفلافم ولا endangering the stability. طيب يعني وحتى لو انا عوزت ان انا اعمل ريفيجن ولا اي شيء، الفيلد بتاعي بيكون فيرجن. وبصراحه لغايه دلوقتي ما فيش حد بيجي سواء دي كومبريشن او ديسك محتاج ديسك سيرجري الا بنخش اندوسكوبيك وريزلتس هايله. يعني ما فيش غير حالتين بس، واللي ربنا يبارك لكم انتوا الاثنين. ايوه الانتري بوينت.
I had the conversation between you both. It was nice.
السلام عليكم.
Yusri, you always look younger when I see you. I'm not sure what's your secret, man, but I don't know.
How are you?
Habibi, I'm good.
Dr. Sharif.
Start now our
we can recognize you despite using the mask.
Okay. I forgot actually. Well, Dr. Hassan, my dear friend, now you can start your session. We'll talk about the transforaminal endoscopic lumbar disc surgery. to avoid fusion of adjacent segments. Is it really possible?
That's what we are going to discuss today. I'd like to thank you for this nice invitation, Professor Yusr Al-Hawari, my dear friend Muhammad Khattab, my dear friend Dr. Sharif Al-Ghamri. And I'd like to give a lot of thanks for both my colleagues and friends, Dr. Hatem Hamdi and Dr. Muhammad Assous, for encouraging me to enter the field of endoscopic spine surgery. I believe I can say that I have about 12 years of very good experience in microscopic surgery and in minimal invasive surgery in general. And I could improve and widen the usage of microsurgical techniques for fusion, for correction of some deformities. I don't use any open surgery, just only for rigid deformities or for posterior cervical fixations. But the endoscopic surgery is a game-changing principle in treating many cases, because I'd like to start my my presentation now. Can you see it now? Can you see the presentation now?
Yes.
Hello? Yes? Okay. So I would like to give you this imagination how I understand the endoscopic spine surgery. You have a room and you have a treasure inside the room, but in the way you have a lot of electrical wires. These are the roots and the cord. You have to dig a hole in the ceiling of this room to reach your treasure. While you have on the side, this white line on the left side, you can see a door which you can use to get directly into the room and get your treasure. That's how I understand endoscopic surgery. Digging through the ceiling is the microscopic surgery, the posterior standard approach which we use. You have to remove the flavum, part of the lamina, part of the facet joint, and manipulate the roots, push them away to the side to reach your disc prolapse. In the endoscopic spine surgery, you just open the door, you go through the foramina, and you are directly inside the room. You will get your treasure and go away without any harm. This case is a 74 years old female patient. She got TLIF, percutaneous TLIF. In my clinic, I was the operator. I have done this fusion because of claudication pain, instability pain, and so on. The usual indication for fusion surgery. This was for about 4 years. She came to the emergency department suffering from radiculopathy, L4 radiculopathy on the right side. You can see a huge disc prolapse, L3-4 on the right side, affecting the L4 nerve root. She was refusing any type of fusion surgery. I believe she didn't got a lot of benefit from the fusion surgery. And this is a very good question. After doing about 50 cases of endoscopic spine surgery, I can tell that I regret doing a lot of fusions before, and I revised my ideology in treating many cases, because I believe you can avoid this fusion if you use endoscopic techniques. The most difficult problem in the stenosis is the foraminal stenosis in the craniocaudal diameter. You have the stenosis from anterior and posterior, from disc bulge and facet hypertrophy, but due to loss of disc height, you have a craniocaudal stenosis, and that is the difficult point to be treated through decompression and microsurgical techniques without inserting a cage to restore the disc height. But I believe this problem could be solved using the endoscopic surgery. So I have discussed all the options with the patient, and I have advised her to do an endoscopic surgery. And if it couldn't help, we can still think about doing the fusion. And she accepted it. So these are images from another patient, just to explain how we locate the site where you are going to do your skin incision. These are cornerstone lines and measurements to be able of reaching the foramina without harming the exiting nerve root and without having any difficulties. We are doing full endoscopic or fully endoscopic spine surgery without entering the disc space. So you have to do a line on the height of the disc space. So, and another line, as we have heard from Dr. Muhammad Sous and my colleague, Dr. Hatem Hamdi, crossing the cranial end of the ipsilateral pedicle and the caudal end of the contralateral pedicle. And in the lateral side, the lateral view, you just follow the orientation of the SAP, superior articular process, cutting through the posterior superior corner of the vertebral body. This is the intraoperative video of this case. You have a clean view, you have a minimal blood loss, you are directly through the foramina in the spinal canal in the lateral recess. And here comes the magic instrument. This is the disc forceps, a flexible disc forceps. This is a very useful instrument, and it is flexible in the last third of its length, and through it you can get the disc space just underneath the electrical wires, underneath the dura. You see how big the prolapse is, and it is stuck in the tube, in the work channel. You have to attack it another time just to get it completely removed. I hope you can see the video. This is the big fragment we could remove. And another fragment. And you can see that the wash is minimizing the blood loss underneath the dura. And I believe you can see now the pulsation of the dura. I hope you can see this nice video. Okay.
Hatem, you can start.
Dr.
I hope you could still see the video and see the whole presentation. Thank you very much.
Thank you, Professor Salhin.
Thank you.
Very nice case, and you save one level from a fusion. I think it's a big success. The next speaker is Dr. Alfonso Garcia from Mexico, and he will speak about the transforaminal endoscopic foraminoplasty instead of fusion surgery in foraminal stenosis cases.
Thank you to the organizing committee, Dr. Hamdi, Dr. Katab, Dr. El Hawari. It's a pleasure to be here. In recent years, there has been a continuing growth and special interest towards endoscopic spine procedures. Today, I will share some concepts on transforaminal endoscopic foraminoplasty as an option to fusion surgery in foraminal stenosis cases. My disclosure. I practice in the city of Tijuana, which is located at the most northwestern part of Mexico, bordering with the state of California. Tijuana is well known for its museums, art, and some internationally awarded musicians. Nationally recognized for its scenic roads, amazing Baja-style food, wine, and craft beer. Tijuana is considered the fastest growing health and wellness tourism destination in Mexico. People coming to seek health services look for dental care, weight loss, plastic surgery, cancer treatments, including alternative medicine, and lastly, orthopedic attention. Spine care is not yet a main reason for medical tourists to visit us. Only 1.4% of our population has private insurance, and unfortunately, endoscopic spine procedures are still not covered by public health. Endoscopic surgery has opened a new perspective and has drawn an interesting pathway for the treatment of the aging spine. Endoscopic foraminotomy was possible thanks to a number of well-orchestrated events. The major milestone in this direction was the description of the transforaminal safe working corridor, better known as Cambin's triangle. This very important step made it possible for other surgeons to continue exploring the foraminal region by further developing highly specialized instruments such as trephines and high-speed burrs for augmenting this bony arch to better adapt the visual aid of an endoscope and also provide extra room for the exiting nerve root, giving a start to a new era in the endoscopic surgery approaches by broadening in its indications and include other pathologies that couldn't be safely and effectively performed before. With that in mind, the setup for the transforaminal endoscopy is credited to Dr. Anthony Young for its Young endoscopic spine system, and later by Dr. Thomas Hoogland with the Thomas Hoogland endoscopic spine system, TSYS. Dr. Young developed a working channel scope with integrated irrigation system, and Dr. Hoogland introduced a high-tech cannulated blunt tip hand-controlled drill bit to perform percutaneous foraminotomy. The next event came with the first appearance of some strong competitors that continue to improve the design of their basic instrument set, both for differentiation from other makers and at the same time making it easier and safer to decompress the bony elements of pathology in the aging spine. We are now experiencing the golden age, where the rapid interest and usability of these systems has produced high quality evidence to support the integration of this tool set to the already immense offerings of spine surgical innovations. Depending on the instrument used, endoscopic foraminotomy can be done percutaneous with fluoroscopic guidance by direct visualization and use of high-speed endoscopic drills and in combination. For percutaneous approaches, we either have trephines as featured on the bottom left side of your screen, or the cannulated blunt tip drills to safely remove bone while preventing inadvertent damage to the dura. For direct bone removal, with the visual aid of the endoscope, there are a number of different drill tips to suit any need. Recently, the deflecting angled ones have simplified this task even more. The difficulties encountered during the learning curve and with the procedure itself have stimulated the design upgrades of the next generation instruments, such as these self-stabilizing cannula and trephines that can safely stay in place while the surgeon is able to control the decompression of the foramen. As we move forward and experience this golden age, we can now communicate that endoscopic surgery has broader indications than 10 years ago, that it offers an improved surgical view. It is a muscle-preserving technique with less bleeding, less post-op pain, reduced infection rate, and a fast recovery. It has also been confirmed that it has clear advantages in other settings like degenerative spine stenosis, spondylolisthesis, scoliosis, previous fusion, and even tumors and infection. A recent prospective study with a 2-year follow-up compared outcomes in 207 patients with spinal stenosis with or without coexistent scoliosis following tubular-based ULBD, and found significant increases in functional outcomes in all patients with only an 8% reoperation rate. This contrasts to reported reoperation rates of 25 up to 37% in patients with significant deformity undergoing open laminectomy. Unfortunately, the alternatives to an isolated decompression in this patient population are short segment and long fusions, which not only have higher rates of complications, but also have high rates of adjacent segment reoperation, exposing some patients to a lifetime of fusion extensions. When asking myself, what is the benefit of full endoscopic procedures, I came about this interesting paper, which does a very good job in proposing an index of the perceived invasiveness and complexity of spinal procedures. And in result, it identifies the benefits shown for endoscopic procedures when compared to traditional ones. Not surprisingly, endoscopic spine surgery showed an increase in the benefits shown as procedures were identified as more invasive and complex. I want to share with you at least 4 cases that fall into this category. First case is a 46-year-old female with a past history of untreated idiopathic scoliosis. She is a very active fitness instructor. At visit, she had been complaining of left leg pain with numbness and no muscle weakness for the past 6 months. She had received conservative treatment without any improvement. On physical exam, we confirmed hypoesthesia on left L4 and 5 dermatome with no changes in deep tendon reflexes and muscle strength. Pre-op images of the MRI show the following, which is a broad base herniated disc that occupies the left and right neuroforamen. The direction of the rotation deformity is as shown. CT scan through the left foramen at the problem level and same level through the right foramen. 3D reconstruction of her spine and the left L4-5 foramen. The surgical plan was to make a left transforaminal endoscopic lumbar discectomy at L4-5. The surgery is as follows. Head is to the left, feet are to the right. And we look now at the first site after immediately introducing the scope. We see disc material, the bottom of the screen. We're extracting the disc. You see also to the left side of the screen, the SAP, recognized. And we continue to remove disc material. You saw on the MRI that the disc was abundant with a very broad base. We're at the intervertebral space, the disc space. And we see a very thickened PLL. So it's very difficult for me to open the PLL, which I couldn't do. And it was also firmly adhered to the ventral dura. So we see the drill sac pulsating there. And as you will see on the next fluoro shot, I'm on the contralateral side. So surgery was a success, and patient is with no symptoms following 2 years after the surgery. Second case is a 70-year-old male with a past history of heart problems that required a pacemaker. He has had prior spine surgery to replace 2 lumbar discs and then went on to fusion. Both procedures resulted unsuccessful in lessening his symptoms. He complained of right buttock and leg pain as shown, plus numbness and mild gait disturbance. On physical exam, we confirmed dysustasia with no muscle weakness and a positive right straight leg raising test. We performed an L4 followed by an L5 transforaminal diagnostic blocks. He experienced 8 to 12 hours relief on the first one and no changes after the L5. MRI wasn't possible because of the pacemaker. I personally like to use the MPR tool to kind of navigate through the planned surgical approach pathway and sometimes a 3D reconstruction helps get better oriented towards the problem in hand. The surgical plan was to do a right L4 transforaminal endoscopic lumbar foraminotomy. I will show the next surgical procedure. So as you can see, the placement of the trephines was very difficult because of the hardware that interfered with the views. So after placing the cannula and introducing the scope, this was my initial view. A fully obstructed foramen. I started to palpate my limits and try to identify my safety zone. And initially, my thought was to drill a little bit to get a feeling of how thick was that bony wall. So I started drilling. I wasn't getting anywhere. So I decided to look for the exiting nerve root and try to identify that interface between the exiting L4 nerve root and that bony wall. So I managed to make some space and started my dissection between that soft tissue of some of that fat that surrounded the L4 exiting nerve root. And I introduced my ball probe to make more space, and then try to make enough room to fit my first Kerrison rongeur and start biting off that thin bony wall towards making my way towards the base of the pedicle. And as you will see, when I start to remove more and more of that bone and continue to decompress that foramen, some of that traversing nerve root will show on the bottom of the screen there. So now I have a safety corridor to follow while keeping a close eye on the traversing nerve root and keeping away and biting away from that exiting nerve root. So I keep on biting until I reach where the SAP comes to make part of the pedicle. And as you can start to reconstruct there the images, the fully decompressed neuroforamen appears. So I made a composition of some pictures taken during the procedure to fully show how the neuroforamen was decompressed. So the patient starts walking with no aid 3 to 4 hours after surgery and ready to go home on the next day. I will go fast on these two last cases, which also fall into the category of high complexity procedures. This surgical procedure is a right side L4-5 recurrent disc herniation, a 26-year-old female who had prior surgery. She had acute onset symptoms of right buttock pain. These are her MRI images. And that was the selected needle targeting. And these are the first images once I put the scope in. And you can immediately see the traversing nerve root, some disc material, head to the right, feet to the left. And there's the a very good picture, video picture of the traversing nerve root and the underlying herniated disc. So I'm removing the disc from underneath the traversing nerve root. I do a twisting motion to safely remove the larger fragments. And sometimes you even have to take out the scope through the cannula because the fragments are so big that they won't fit through the working channel. So you start to see more and more of that traversing nerve root as you continue the decompression. And as you follow the video, you see that I can get pretty close to that traversing nerve root without fear of damaging it, because it's always under direct visualization. So this part I like to document the lateral recess and my endpoint with a fully decompressed traversing nerve root at the base of the pedicle towards the SAP, the lateral recess right there. And a successful fully decompressed neuroforamen. Last take to document SAP, pedicle, and L5 nerve root. The last case is a bilateral L5S1 foraminal stenosis. We did a left and right transforaminal endoscopic lumbar. Oh, I'm sorry, it's misspelled. It's not a disectomy, it was a foraminotomy. I'm sorry for that mistake there. So these are the pre-op images. And you can see the left L5S1 foraminal stenosis and also the right foraminal stenosis. And on the top, we see the sequence of pictures that correspond to the decompressed left L5 exiting nerve root. And on the bottom, we see the right L5 exiting nerve root with a better view of the lateral recess. So take-home message. I would like to share some tips on targeting and safety during your procedure. Depending on the side you wish to decompress, there are other bony safety landings for your initial guide needle, such as the transfacet or at the base of the pedicle. Keep in mind that this green area is your safety zone, and it's okay to explore throughout this region. Keep away from the top of the foramen where the DRG and exiting nerve root is. First, palpate the bony landmarks inside the safety zone. Identify the top of the pedicle, SAP, and the base of the pedicle that limits with the end plate. Second, locate your disc space. And lastly, dissect towards the lateral recess and make sure to fully decompress and see the traversing nerve root. And again, always stay away and explore with caution this red zone. Just before I leave you, I would like to share that it's a good idea to let your patients take you from basic to more advanced cases. And definitely learn from every case. I'm sure we all expect to look like this runner when we jump over our first hurdle, but it might go something like this, and we should be prepared. Instrument handling is key. Build academic relationships. Teach others. Obviously, share your knowledge. And most of all, enjoy the reward of your work. Jose Carlos Villarreal from Mexico didn't expect to win gold at the 1500 meters in the 2019 Pan Am Games, and definitely he enjoyed every second of it. Since I finished my fellowship training in 2015, we have been busy training other surgeons in Mexico and abroad. Thank you very much. You can contact me here. It's been a pleasure to participate.
Thank you very much, Dr. Garcia. It was a very nice presentation. And we have some questions to Dr. Hassan. He's present. Yes.
Yes.
Question from Muhammad Baksh. I want to ask about the type of lens and recommendations to courses training on MIS spine.
For the endoscopic spine surgery, I use the lenses from the company Joymax, and there are 4 types of cameras. There are long cameras for the transforaminal approach, about 17 centimeter. They have the diameter about, the working diameter is about 3.7 millimeters. These narrow diameters allow just the passage of small and fine instruments to get through the foramina to the disc space and the epidural space. There are, for the posterior approach, interlaminar approach, there are 3 types of cameras. There's the small one, just the same diameter, 7 millimeter outside, and the working channel is 3.7 millimeter. And this allows you to land inside the spinal canal during the dealing of mediolateral disc prolapse, L5S1, for example. You just do an interlaminar approach, partial flavectomy, maybe partial laminotomy, and you can push the working channel inside the canal and rotate the root and excise the disc prolapse. The other types, the other 2 cameras are just for decompression. One allows you to use a bigger drill and bigger instruments with a diameter of 4.7, and you can use it to do crossover because it is not very thick, and you can slide over the dura to the other side. There's a bigger one. The working channel is about 6 millimeters, and it allows you to use 5 millimeter and 5 millimeter rongeurs and keratins. This type is used for severe stenosis, and this is used also for endoscopic fusion. For the courses, I believe these courses which I visited, they were not very beneficial because there are a lot of participants and you are working on cadaver, and the faculties have different experiences. Some show you doing the surgery in lateral approach, and some show you the surgery in prone position. And I got benefit from the webinars offered from the Egyptian Spine Association through the personal contact with Dr. Hatem Hamdi, my dear friend, and Dr. Assous. And I believe online nowadays you can find a lot of information, a lot of videos. But I believe to have a mentor, to have somebody to guide you in the first steps is crucial to get a successful endoscopic surgeries. And I repeat my invitation to all my colleagues which can or want to visit my department in Germany. You are very welcome. I think my personal data are available for many colleagues, and I can make it more and more available if you want. I hope I could answer the question.
Very clear. And a question from what are the peculiarities of endoscopic discectomy and general endoscopic spine surgery?
What are the
peculiarities? Why do you recommend this question?
It's a very, very important and very nice question. The most important thing, you are using an anatomical approach through the foramina for many cases. We have managed to do discectomy at the level of L5S1 transforaminal. This was performed by my colleague and my fellow, Dr. Mohammed Al-Ma'adawi, the consultant of spine surgery. Number one, you have an anatomical approach. Number two, you do very, very minimal injury to the stabilizing structures of the spine. No injury or minimal injury for the spine. You are splitting the muscles. You are not removing the ligamentum flavum. You are not injuring the facet joint. The third advantage of endoscopic spine surgery, you have minimal bleeding, and through the wash, through the irrigation system, you have a very clear vision. And in comparison to my experience in the microscopic surgery, the field is almost bloodless. We have a radio frequency system, just like a bipolar system, which works inside the fluid environment, and it is very safe for the nerve root. If you touch the nerve root with this radio frequency, you are not going to cause any type of injury, because we are operating without muscle relaxants. This is very crucial. This is our neuromonitoring without muscle relaxants. So the patient is reacting and will react immediately if you are near to the nerve root. The recovery from the anesthesia is very fast in comparison to microscopic surgery, where I need to do to insert my work channel. I must remove a lot of muscles. I have to remove the ligament flavum, partial facetectomy and partial laminotomy to get access to the spinal canal. You have a bloody field. You have to use anticoagulants inside the field and Surgiflu and such medicaments to stop the bleeding. And you have a lot of manipulations for the nerve root and for the dura. This is.
Yes, thank you very much. Dr. Hatem, can you proceed?
Yes, I hear you. Thank you, Dr. Hassan, and thank you, Dr. Alfonso. Now, I'm happy to introduce my great friend and my great mentor, who changed my many things in my mind. I use a lateral approach for the transforaminal endoscopy for 2 years, and he pushed me to do a craniocaudal approach, and actually I get a lot of benefits from him. Our dear friend Dr. Muhammad Asus from Jordan, he speak about the advanced transforaminal endoscopic approach.
Dr. Asus, I have to read what you have written in the on the chat before you start. We have enough.
Okay, I'll wait.
To suggest that endoscopic discectomy is better than microdiscectomy in terms of patient satisfaction and lower complication rate.
Yeah,
Okay.
absolutely. Yeah, meta-analysis, excellent one, came from India on over 4,000 patients only 3 months ago, and basically, included 11, randomized controlled studies, and across the board, basically. So we had better patient satisfaction with the ODI scores and the VASA scores with the endoscope compared to the microscope, and you also had a lower complication rate in and really we have passed the stage. Is a transforaminal approach, endoscopic transforaminal approach, better than the interlaminar endoscopic approach, and I'll show you why the transforaminal approach probably is better. So thank you so much, Dr. Hatem, Dr. Khattab, and Dr. Yusri for the invitation. And I've enjoyed actually listening to Dr. Salhin and to Dr. Garcia, who basically showed you cases where the transforaminal approach using the endoscope is actually very, very good and very valid option and safe option at the same time. My name is Mohammed Asus, and I come from Jordan, and I've been doing endoscopic surgery for the last 4 or 5 years. I've done around 700 cases now. And if I look back, I wish I started this before I started with the tubes in 2009. This is my disclosure. And the learning objective, really, I'll show you clinical indications and scenarios where the transforaminal approach is not only better than the interlaminar endoscopic approach, but is also safer. And in my job and your job as a spine surgeon, better often, and almost always means safer. And in doing this, I hope to convince some of you at least, to adopt transforaminal endoscopic surgery. So if you haven't started endoscopy, start endoscopy. And when you start, you really should start interlaminar endoscopy and transforaminal at the same time. If you have been doing like Dr. Hatem, my friend, doing interlaminar, surgery, you really should put your hands on the transfemoral approach. It's a little bit tricky to learn, but once you do it, it is one of the most fascinating and exciting surgeries. So this is a couple of meta-analysis very quickly. The transfemoral approach is actually better. So this is meta-analysis, came out in 2019, basically. And look at the dural tears. So even if you do interlaminar endoscopic surgery, you are in the region of 4% of the dural tears, like indeed any interlaminar surgery, whether you use microscope or the endoscope, there's a definite risk of dural tear. And the risk is also there with the transfemoral approach, but this is less than 1%. And people, feel apprehensive about using the reamers. The reamers are very, very safe. So I have, a lecture for the beginners in transfemoral surgery. This is not, the case today, but the transfemoral craniocaudal approach using the thesis approach is very safe. And if I could learn it, you can all actually learn it and be better than me. So the other meta-analysis between the transfemoral and the interlaminar endoscopy looked at the long-term outcomes of the VASI scores. And guess what? The transfemoral approach is better. And we know now because Dr. Salhiya told us there is no flavum work, there's no bony work really. And the bleeding is much less. So the idea is that the foramen is your side door to the spinal canal. This is all what the foramen, so it is the step, it's the doorstep. If you have a problem at the doorstep, like foraminal stenosis or foraminal disc, you can deal with it. If you have a problem inside the house, then basically your entry point is the foramen. It gives you brilliant access to the ventral part of the dural sac, of the dural canal, spinal canal. So what Dr. Garcia and Dr. Salhin has shown you in the last half an hour basically are indications and applications of the transfemoral approach, and this is no exception. What I've done in the last few months, I put all these together basically. So in my opinion, the interlaminar approach is good, is great, but the transfemoral approach is just greater and it is better. If you master the interlaminar approach, and once you climb these 3 steps, you can do modially and caudally migrating, ones central, paracentral, ones, etc. So if you master the interlaminar approach, you can do all types of disc herniations in the canal. But if you master the transfemoral approach, you need to climb a few more steps. So it is more difficult to learn. But once you learn both approaches, I promise you the transfemoral approach is easier than the interlaminar approach. It's just for you to take the plunge to actually do it and learn how to do it and invest some time and effort, in doing that. The transfemoral approach gives you brilliant indications over, the interlaminar approach. And I'll show you examples of these. And we've already seen the adjacent level disease with Dr. Salhin and Dr. Garcia. We've seen the recurrent disc herniation, somebody who's had a posterior surgery with the microscope or, with open surgery, God forbids, and they have a recurrent disc. It makes sense to come from the foramen. It is not a virgin area, but I promise you the adhesions are probably 10% of what you would encounter if you'd gone again from the back of that patient. So you can still do most intracanal herniation, including the migrating ones, not all of them. You're going to struggle to do a cranially migrating L5S1, but so what? Do an interlaminar approach on that one. But that's probably 10%, that's 5-10% of the cases. The other 90%, you can do easily the transforaminal approach on them. Foraminal, extraforaminal disc, I'll show an example. Recurrent disc after posterior herniation, again, the upper hand belongs to the transforaminal approach. What about disc in the upper lumbar and thoracic spine? You're going to take most of the facet at L1, L2, for example, if you go from the back. Imagine this is the adjacent level. Somebody had adjacent level L1, L2. They're already collapsing at L1, L2, and the fixation is from L2 downwards. And you want to do a posterior surgery to decompress. You have committed your patient to fusion. But if there's a lateral recess stenosis or a central disc herniation and you come from the side, you can defer. And in fact, you can actually save your patient unnecessary fusion. What about this with coexisting foraminal stenosis? Absolutely, transforaminal approach. Large central disc, somebody with logical deficit, footed drop with a large central disc, the last thing you would want to do is to actually exert significant traction on that nerve root. You don't want to do that. Again, the transforaminal approach is better. What about adjacent level? If somebody has a disc in the adjacent level or lateral recessive stenosis, transforaminal approach is definitely better than any central interlaminar approach. High-risk patient, morbidly, I'll show you examples of all these cases now. High-risk patients who can't go, morbidly obese patients, they can't go to sleep. Sedation is very easy with the transforaminal approach. It is not with the interlaminar approach, full stop. Foraminal stenosis, you've seen a fantastic case or two from Dr. Garcia. And lateral recessive stenosis, and this is a classic example, Ya Khattab. People do laminectomy, they do discectomy, and they do not actually chase the traversing nerve root into the recess. And the patient is in severe pain post-operatively, sometimes worse than a pre-op. These patients do not need discectomy, they do not need laminectomy, they need lateral recess decompression. And if you don't follow that traversing route into the lateral recess, you have to go back. And if your patient had 1 or 2 posterior surgeries, do the lateral recess from the side. Why go through the adhesions and risk, nicking that nerve root and causing a dural tear, or God forbid, a significant root injury? So this is an example. This is a famous actress in Jordan. She's 60, and she's troubled with foot, drop. She has dorsiflexion and she has EHL. And the reason is here. She has a big foraminal component and she has a high-grade caudally migrating 4-5 on the left side. I mean, which interlaminar approach will do this for you? No interlaminar approach can do that to you. Full stop. You just can't do it. You can take the caudally migrating. You're going to struggle with the foraminal component. But a transforaminal approach, take a little bit of that pedicle, can actually address both the problems. And I'll show you. So this is the video. So cranial on the left, caudal on the right. I'm going to speed a little bit with the videos. Otherwise, we're going to spend 2 hours, which is not very good because it's already late for most of you. So cranial on the left, and we know this lady. So the anatomy doesn't change. So there will be a pedicle on the right side here, and there is a facet. And you can already see the pulsation from the epidural fat. So I know the nerve root, that traversing L5 nerve root is hiding behind me here. And I know these are fragments of the disc herniation, but the main disc herniation is not here. It is hiding behind that caudal pedicle. So you clean, and then look at this view here. So the exiting nerve root is on the left, coming at 6 or 7 o'clock here. This is the posterior wall. I'm going to stop this here because this is absolutely critical. This is the posterior border of L5. This is the pedicle, and that's the facet. So the nerve root is here, and all that which didn't take my contrast is the caudal herniation, but it's part of it. Another huge fragment, I know for a fact, is hiding behind that pedicle here. And this is why you need to drill that pedicle a little bit to grease that. So you remove that disc herniation. But typically with those, there is always a bigger fragment hiding, I promise you. If you think you have finished with these cases, don't. Stay, poke, probe, and you will get a bigger piece. That has been my case with me for the last 18 years. So I have pulsation now. This is a good sign, but it's not enough. You really have to see that nerve root. It is not enough, the pulsation. People say a free pulsating nerve root is enough. Sometimes it just transmits the pulsation. So you get your drill and you take part of that caudal pedicle. I'm going to speed this up a little bit. So nothing, and this is the fragment from behind the pedicle. And that's the nerve root, pulsating and mobilized. And then you poke ventral to the nerve root, and there's nothing. And then you know for a fact that you've finished. And as I told you a minute ago, there's always another piece hiding, and that's still actually a further piece for the time, purposes. So there it is. And that's the flexible pituitary that Dr. Salhin mentioned and he likes. It's a beautiful thing. But that's a nerve root for you. So this is the traversing L5 nerve root, and I have already removed the foraminal component. You see, more pieces keeps coming. So, and that is typically the case. So that's the traversing nerve root, and that's the disc space, and that's the exiting nerve root. There you go. That's the epidural fat, and I've removed the foraminal component here. And my advice to you, if you start this, do the MRI. MRI doesn't lie, and it teaches you how to improve yourself in the next and the third and the 200th case. So this is a pre-op on the left, post-op on the right. The caudal migration has gone. Look at the foramen on the left, and look at the foramen on the right, and that foramen is patent, and the patient is very happy. She went home after 5 hours, and this was 1 year actually, and she's still very, very happy. What about a high canal compromise, adjacent level disease? This is the example I mentioned, L2 to S1 fixation. And typically, we've all done this. We've all actually proud, ourselves, with the post-op X-rays, and they look fantastic and reduce everything. But many of these patients will come back to you. And if you've practiced 18 years like myself, you will see your own complications or your own nightmares, because they come back. They do come back 5 years, 10 years down the line. An adjacent level will just basically go. So she has weakness on the right side, in the right leg, globally, all muscle groups, basically, all the myotomes. She has no upper motor neuron, and you can see this is L1, L2, huge disc compromising the whole canal here. I'm going to show you T11, T12, but this lady does not have upper motor neuron signs in her lower limbs. So I was satisfied this is not the problem. I still actually took part of it, with the endoscope, but I knew the problem was L1, L2. And if you do the upper lumbar or the lower thoracic, or the thoracic ones in general, do not re-impass the medial pedicle wall. You would do that for L3, 4, L4, L5. You will never do it for L1, L2, L2, L3, and the thoracic ones, because the thecal sac is fat and it will through the foramen. So be very careful. And this is the video. So cranial, on the right-hand side, caudal on the left. The anatomy doesn't change, but typically for the thoracic and the upper, you need full foraminotomy. You really have to remove the ventral part of the facet to get access to the canal because of the size of the foramen. Otherwise, you can't get into there. So again, drilling of the SAP. This is the flavum. Every time you drill the SAP ventrally, the flavum shows, and once you see the flavum, you know basically that the epidural fat and the neural structures are just, hiding behind that. So you take this out very slowly. This is the nerve root, and are safe. And this is the beauty of the craniocaudal approach. The only thing that you can injure is
So we lost you.
Yes. Can you hear me?
Yes, we can hear you.
Oh, okay. Okay. So, I'm sorry. So I was saying anything ventral to the nerve root will have to go, and this is a central fragment, so you really have to go ventrally to actually retrieve that. So again, your hand is radiofrequency probe, and this is the big herniation, absolutely still stuck, but you are safe again and again because I can see the neural structures. I can see the ventral part of the dura and the nerve root. And this is what you should see in the end. So the ventral side is void. There is no compression ventrally. And this is the post-op. So pre-op, again, I do MRIs for all my discectomies. So this is on the left pre-op, and post-op, you can see that the neural structures are much happier. This lady was much happier. She's 8-9 months down the line. She doesn't want fusion. Will she need fusion? Maybe, but now she doesn't need a fusion. This is the axial cut on L1, L2, and the post-op, there is definitely some space, significant space in the canal, and this is the 3 or 4 millimeter disc. What about foraminal and extraforaminal disc? I mean, which interlunar approach can do that to you? Absolutely not. Absolutely not. So foraminal, extraforaminal disc, the transforaminal approach is a brilliant indication. This is one of my teachers and my professors at university some 30 years ago, brilliant, fantastic vascular surgeon who was troubled with foot drop in L4 and L5, were basically affected, and the reason is big extraforaminal disc affecting the exiting L4 root, but the lateral recess is very tight. So this is a gentleman who had extraforaminal as well as lateral recess arm stenosis at the same level. And a transfemoral approach can do both surgeries for you if from a 6 or 7 millimeter incision. So cranial on the right, caudal on the left. And let me just show you again, because people ask about this all the time. How do you identify the exiting nerve root? So you put the scope, as every single time, Dr. Hassan, in the lateral recess, because we know this is the safest. You are far away from the exiting nerve root. So basically the caudal here, that's the lateral recess. And then you pull the cannula. So what I'm doing, I'm actually pulling the cannula out and I'm rotating 90 degrees up. And this is the exiting nerve root. That's the exiting nerve root. And that's and you pull the piece underneath that exiting root. Pull the cannula probably 3-4 millimeters. And you rotate 90 degrees so that actually the bevel will be looking actually cranially. And then the root work. And this is the lateral recess. This is the edge of the pedicle. And because I can't see that traversing nerve root, I know for a fact so this is what Dr. Garcia basically, showed you. You use your drills, you use your Kersons, but the idea is any nerve root which is compressed by stenosis or a sequestrum, it has to be free, pulsating, and mobilized. And you look at the volume of the disc that you took out in the end, that should, in theory, match the volume on the pre-op MRI. So
we lost you.
And this is how and this is towards the end of this. You lost. Okay.
I think we're back now. Oh, no.
Okay.
Oh yeah, we can hear you now.
Just give me one second, please. Give me 1 second.
Ready?
Right. Can you hear me now?
Yeah, perfect.
Yes.
Yeah, sorry. Yeah, I have a metal door, which seems that when I actually close the door because of the kids, I can't actually have a stable connection. So I asked my children to be quiet till I finish, and I opened the door. So this is the example of the extraforaminal. Again, do MRI. I pay for my own patients' MRIs because they don't have to pay for it. I'm a full-time private, but it just teaches you. So pre-op on the left, and look at that foramen. So that foramen and that recess is very patent now. So the extraforaminal disc is gone, and look at that traversing nerve root, and it's absolutely much happier than it was before the surgery. What about a large central disc herniation? Was somebody, not in this particular example, but imagine somebody with impending coda equina or somebody with a significant foot drop or progressive neurological problem. You don't want to, exert a traction on that nerve root. And this is an example, a 61-year-old gentleman with severe bilateral, lower limb pain and difficulty walking and standing. And you can see this big herniation at L4, L5. And this is the video. So cranial on the right, caudal on the left, and it is caudal. There should be a facet, there should be a pedicle, and there should be a posterior pedicle wall and the annulus. And that's the big disc herniation. Again, central herniation means you really have to reach, as you can see on the radiograph in the middle, you have to reach the central part of that, annulus, or even to the contralateral side. And that's the herniation. And again, this is really, people look people look at the disc, they look at the nerve. I look, to be honest, at the posterior vertebral wall. This is your safety net. And people ask me, I've done this, I've taken half of the disc, the patient is half, the way better, but they're not brilliant. And the only reason this will happen is because you are afraid of getting inside the spinal canal because you haven't identified the traversing nerve root. Identify the only structure that you can injure, and then the operation is easy. Anybody can do it. And this is why with the craniocaudal approach, you land in the recess, because if you land in the recess, you are far away from the exiting nerve root during the access, so you are safe. And it is the best place to identify this traversing nerve root, full stop. And this doesn't change. It doesn't change. You build your experience, start with straightforward cases, but then after 100, 200 cases, you'll be doing all these cases and teach them to people from all over the world. So this is the posterior wall. So pay attention to the posterior vertebral wall. Anything parallel to it, anything in line with it is safe. The dura and the traversing nerve root is not stuck to the posterior vertebral wall. You've got a good 4 or 5 millimeters distance. So, and you have a 2 millimeter pituitary longeus, and if you put that sideways, you can remove anything ventral to the nerve root, basically, without any risk to the nerve root or the central dura. So that's the big fragment coming out, and now you see the nerve root. This is the PLL. This is the PLL. Okay, you commonly mistake that for the nerve root. The PLL is shiny, it's horizontal. Okay, and it's very thin, and with time, this is PLL, and you just put your scissor in it if you want to. I don't usually remove it unless I absolutely have to. So this is subligamentous herniation. It's a big herniation, you can see it here, but I want to see the nerve root. And then everything here can safely, and completely be removed. And again, and again. So that's the nerve root. Nobody can get confused with that. This is the nerve root. This is the disc out. And that's remnant of the fragments here. And this is towards the end of the surgery. And you can drive your endoscope deep. So I'm inside the disc now. I'm underneath the annulus, looking into the contralateral side. And this is not the inside-outside technique. It is still actually outside technique, but for central disc herniation, when you have a big wrench in the annulus, you really have to reach inside the disc and make sure that the ventral part of the fecal sac, this is not a radicular problem anymore. This is a central problem causing severe canal stenosis. So you reach the contralateral side and the disc is out. And what about the post-op MRI? Again, so the big herniation is gone, and you can see the difference between pre-op and post-op. So 2 or 3 more examples and I'll finish. And this is a common scenario I get. So people who get laminectomy and discectomy for lateral recessive stenosis, and they have persistent symptoms. And I have some reason they are more painful post-operatively than they were. I don't know, maybe from micromotion, irritation of the nerve root. I don't know what happened. And this is the typical ED. Most leg pain, little that happened, and she had another one, and she had another go, basically, by the same surgeon, and again no improvement. And you can see why, because the lateral recess is still very tight. So this is the video. So cranial is 9 o'clock, caudal is 6 o'clock, it's 3 o'clock, sorry, yeah. Anatomy doesn't change. So, but this is lateral recess. Your enemy here is the ventral aspect of the facet. This surgery, lateral recessive stenosis, is an exercise in using the burr. So you need really to take that ventral aspect of the SAP, because it is the most compressive part of lateral recessive stenosis. Lateral recessive stenosis is disc, pedicle, posterior, body osteophyte, but more SAP and flavum. Yeah, whether you go from the back, you go from the side, the anatomy doesn't change. You are just looking at it differently. So you need to open your way. This is the straight drill. There are articulated drills, which are no use to me. I use the straight drill. There are 2 or 3 tricks, in the advanced do that. But then this, you are opening the lateral recess now, and this is part of the pedicle. just the rim of the pedicle because I need to open the space. But you know, the end point of the surgery is the identification and the visualization of a free and pulsating traversing nerve root. And if you can't achieve that, surgery is not done. You can do it from the microscope, you can do it with the endoscope, you can do it interlaminar, you can do it transforaminal, but the outcome does not change. So this is part of the adhesion. Part of the bone from the back. I think this is fragmented from the IAP from the previous surgeries. Amazing, you can reach that, you can get this out. But that membrane is not compressing it, but that nerve is not compressed by dorsal structures and by side structures. So the SAP is gone. I just need to make sure there's no ventral compression from a disc herniation. So I'm ventral to the nerve root. I know for a fact I'm safe because again and again and again, I am parallel to the posterior vertebral wall. And if you are parallel to the posterior vertebral, so disc space is here, posterior vertebral wall of L5, and this is or that of L4, and then you know for a fact that you are safe. And this is adhesions and more disc herniation, are more medially. And this is the end result. And if you want to see the nerve root, that is the nerve root here with small membrane, but it doesn't matter because I know the job is done. So that is the previous two surgeries, and this is the endoscope from the side. Pre-op on the left, you can see there's more space because we've taken part of that SAP, and you look at that nerve root, and I can probably convince you that canal in the lateral recess on the left-hand side is much better than the view on the. A similar example, again, common, very common, it's a classic mistake. Laminectomy, discectomy for lateral recess decompression, absolutely zero outcome. Again, this lady was walking 90 degrees, and this is the very first MRI. So you know for a fact that the lateral recess is closed, but she had laminectomy. Lateral recess is even worse. So this is after the open surgery, and this is the view after the, the transforaminal, and you can reach into the contralateral side. So this is the traversing nerve root, and this is if you want to reach ventrally all the way to the lateral. If you want, I just wanted to show you with this video that how far you can go centrally into the contralateral side, and that's obviously the exiting nerve root. I always check on it because I don't want to compress it and strangle it with the bevel of the working cannula. So, and again, a pre-op and post-op X-ray, recess on the left, and you can easily, and confidently say that the root is free, in this example. And this is the SAP resection as compared to the SAP here. And because this is part of the compressive. This is the last case, I think. So morbidly obese gentleman, I operated, on him with a tube. He was a huge guy, still huge, 5 years down the line, weighs 142 kilos. I used at the time the 80 millimeter tube. And if you use the 80 millimeter tube with a microscope, you know for a fact that case will not be easy. Having said that, he did very well for 5 years, and he lifted something heavy. And guess what? He had recurrent disc herniation. And the guy said, we can't put him to sleep. He's too risky. Sleep apnea. He desaturates very easily, if in any prone position, etc. So he's on his side. This is the surgery. So the patient is actually awake. So this is conscious sedation. Again, nothing in pedicle and facet. And you find your anatomy, find the posterior vertebral wall, and this is the disc herniation. And that pulsation is from the epidural fat, just dorsal to it. I'm sorry, I'm going to speed this up, otherwise, So this is the herniation. And you can go all the way in as long as, again, you are parallel to the posterior vertebral wall and ventral to the neural structures. And failing to do that will not allow you to remove any big sequestrum completely, and your patient will have persistent symptoms. And this is one of the major causes that people don't continue with endoscopy. They don't identify the nerve roots. They see a disc, they take whatever they see, and they say, we've done the surgery. Well, I'm sorry, but you haven't. And this is big discrimination, as you can see. This is one of the bigger fragments. I'm just going to show you the beauty when do this under conscious sedation. The guy on his side, and we're going to do straight leg raise, you know, and he's absolutely pain-free. You know, I've got some volume in here where he said he's pain-free, but you know, this is one of the advantages of conscious sedation on the side, and the patients go home within an hour and a half to 2 hours. I've finished my take-home message. Thank you so much for listening. And I think in the aging patients that you and I are increasingly seeing in our routine clinics, if they present with predominant symptoms on the legs because of neurogenic, you know, claudication or radicular symptoms from a disc or stenosis, I think the endoscope is becoming rapidly the standard. But for posterolateral disc, but there's a good group of patients, the ones I showed you. There's a good group of patients who had previous surgeries posteriorly, patients who had adjacent level disease, morbidly obese patients with persistent lateral recessive stenosis, etc., etc. And I think in those examples, and I get so many of these patients, I think the transforaminal approach definitely shines over the interlaminar approach. Thank you so much for having me. Appreciate it.
Thank you very much, Dr. Asus. Very nice lecture and very nice presentation. I have a question. When do you ask the patient to do the second MRI? Immediately post-operative?
To do what, sorry?
The MRI. You said they do MRI
immediately. I do it within 2-3 hours after my. So I do them the same, and you can't do that with the microscope. If you drill, you know, the facet, if you drill the lamina, if you take the flavum out, you know, you can't really differentiate what's disc, what is blood. But with the endoscope, you don't have this problem. With the transforaminal, with the transforaminal approach, we don't have this problem. So I do MRIs immediately post-op for all my discectomy patients.
Dr. Salhin, do you do the same?
I don't. I'm not allowed to do it because of the costs in my hospital. But I go around this way through connecting the colleagues in their clinics. The patients in Germany are doing the follow-up through the help of another colleague in his praxis, in his private clinic. And they send the patients to the MRI, and this takes about 8 weeks. But I'd like to say that the Dr. Asus had got the point of doing the MRI post-operatively for the microsurgical patients. It is always unsatisfactory. If I need any type of MRI for microsurgical patients, I do it after 8 weeks to just get rid of all the blood and hematoma and the collections and all these type of fluids.
All the MRIs I showed you were same day post-op.
That's amazing. That's amazing.
We have a question from Anita. She said that if you have to do the same surgery again, do you go from the same portal on the same side?
Yeah. Transforaminal approach, I do the same portal. I don't do the X-ray because I know I got it the first time. And surprisingly, there is very, very little, you know, in the way of adhesions in the transforaminal approach. There is hardly. It sometimes as if you've gone for the first time.
Same question to Dr. Sarhi.
I don't have too much that type of experience like Dr. Asus. I have just started doing this endoscopic surgery for a couple of months after the recommendation and the encouragement of Dr. Hatem Hamdi and Dr. Muhammad Asus. So I didn't do any type of revisions of my own surgeries, but we have done recurrent discs. We have operated microsurgically for about 1 year, and the lady came to us with a recurrent disc when we have done the revision through a transforaminal approach. I hope in in 1 year, I believe I will tell you in another sitting about my experience in 1 year, if I can do these revisions like the great lion, Dr. Muhammad Aswis.
I'm not. I started 4 years ago. I've done 7, 8. But these two, I mean, my recurrences, I mean, I get my recurrences from 3 months. I mean, I say a recurrence is 3 months, basically. I think any recurrence less than, probably 2 months is a return defragment, to be perfectly honest with you. But I get my recurrences from a year, 2 years, 4, 5 years with the endoscope. And I don't think again. I just do the same transfemoral approach. And patients ask for it. This is the amazing thing. And if you ask me, because I've done thousands of microtubular, I've used the 50 millimeter tube for all my decompressions, ULBDs, for years and years and years. And the most important difference between the endoscope and the microscope is the post-operative pain. Patients after the endoscope, they're not in pain, full stop. They go back to work very quickly. They really had minimal surgery.
I'd like to add a point. The patients are very happy because they have no wound pain and they have no back pain or minimal back pain in comparison to the minimal invasive microscopic surgery. These wound problems, I don't believe that we are going to have such wound problems with endoscopic surgery, and this is a very great point.
Thank you very much, both of you. Thank you. We're going to end our session by Dr. Khattab in a case-based discussion.
Thank you, Dr. Sharif. Thank you, Dr.
We didn't hear you well, Dr. Khattab, please.
Can you hear me right now?
Yes.
Thank you, Dr. Hatem. I'd like to thank Dr. Sharif and Dr. Hatem for staying with us, and I'd like to thank 120 attendees and the faculty as well, and completing this session focusing on the endoscopic and the minimally invasive spine procedures. I'd like to introduce 2 cases and show you what I did for them. First of all, I'd like to thank Novartis company for sponsoring this webinar. This is a male patient presented to me with L45, L5S1, these 2 huge discs, as you can see here in the MRI, in the sagittal cut and in the axial cut as well. And we can significantly found that there is caudally migrated fragment here in the upper right axial cut at 4-5 and central big fragment at L5S1 as well. But for the patient complaint actually, I found just mild back pain and a little bit 7/10 radicular pain, and there is no weakness at all. And I'd like to show you this video. The patient is standing, tiptoeing, and he can, as you can see, no weakness at all. He can even heel walk, so he can do leaning forward as well. So there is even no tension signs. So I decided to stay with the least invasive procedures, which is a medical treatment for such cases. Don't go for surgery because of the radiological investigations. We're treating the patients and the patient's symptoms. So I decided to be the least invasive, conservative side with medications, non-steroidal anti-inflammatory drugs, which is a safe, efficient, all the gold. Some muscle relaxants for the spasm in his back. And when the patient has radicular pain, sometimes I used to use adrenocorticotropic hormone injection to improve the neurological symptoms of the patient, and some anti-neuritis agents, as we heard from Professor Hawari presentation. And one of the medications which you can use is actually diclofenac potassium. Diclofenac potassium ampoules, you can prescribe 2 ampoules per day. It can prescribed for 2 days, and it give very rapid effect. Within 10 minutes, you can have pain relief, and it also can improve the patient articular rheumatic pain if he has, for example, some knee pain or some hip pain as well, and it decreases the inflammation by 95%. And depending on the literature, for example, this is one of the cases, the baseline was huge disc like this, and after 12 months after doing an MRI, there is complete resorption of the disc. So non-surgical treatment works in 80% of acute lumbar disc prolapse with no neurological deficit, and this spontaneous resorption can be anticipated in many cases. So treat your patient, don't treat the radiological investigations. Mesh surgery is actually aiming to decrease the collateral damage, and by small incisions you can preserve the paraspinal muscles, you can decrease the postoperative pain, negligible blood loss, low rate of infection, short postoperative stay, and early return to work, as we heard from our previous colleagues. There are different forms of minimal invasive spine procedures like endoscopic or microscopic, percutaneous fixation for fractures, for example, minimal invasive TLF for fusion and degenerative conditions, cement augmentation, which is a percutaneous management, as we heard today, for the osteoporotic vertebral fractures, which can be anticipated in the geriatric population. Of course, some difficult scenarios can be suspected in such minimal invasive procedure, especially if the patient has severe deformity, if there is high-grade spondylolisthesis and the patient complains from radicular pain and you would like to proceed endoscopically. Some anatomical factors like morbid obesity, body mass index more than 30 kilogram per square meter, abnormal difficult anatomy like fast angulation more than 35 degrees. Some of these cases will have difficulty while applying the percutaneous screws, and even you can hit the facet and injure the facet and accelerate the degenerative cascade inside the facet. And of course, poor less equipped theaters. So you need to have well-equipped theater, and you need to have proper training before doing such minimal invasive procedures. This is one of cases presented to me. It is a female patient, 66 years old, presented with severe right radicular pain for 2 months with failure of conservative management. And although the patient has no weakness in her right leg, but the pain is really intervening with her quality of life and she cannot live. She presented to me asking for cutting her leg to relieve the radicular pain. And if you can see here, this is a plain X-ray which shows severe osteoporosis and the degenerative scoliosis as well. So it is difficult to proceed for the compression and the fixation. It needs a lot of preparation to improve the purchase of the screws. And of course, his main complaint is right radicular pain for 2 months. So doing MRI, you can detect here, this is an extraforaminal huge disc protrusion. And as well, we can see here, this is the central canal stenosis at the 4-5 level, as we can see here. This is the coronal cuts we can see here, and can take the extraforaminal pathology, which causing the severe right radicular pain. So managing this patient with severe osteoporosis, old age, and degenerative scoliosis, the best for her is to do the less and improve her quality of life by relieving her pain. So I decided, by the help of one of my colleagues, Dr. Ali Salah, to do an endoscopic approach, transforaminal approach, to relieve her right leg pain. And this is the disc which we get from the extraforaminal approach. And for the central canal stenosis, I did microscopic decompression over the top technique for her. So this patient became happy, and we treated her severe radicular pain as well. So in order to avoid bad scenarios in minimally invasive procedures, properly select your patient and use a checklist to see every detail during the procedures and, of course, before doing the procedures. Train well, do cadaveric lab, do workshops. Learning curve is important to improve by online teaching, as we heard from Dr. Salhin today. Operating with a team, experienced surgeon and experienced surgeon to help you and mentor you is important. Careful selection of early cases is mandatory. Proper patient selection and OR setup is of utmost important. High quality image intensifier will help a lot, especially in difficult cases like cases with stenosis and osteoporosis as well, and cases with degenerative scoliosis. Stick to the technical tips and tricks provided by the mentors. Use standardized instrumentation and implants, and be ready always with plan B. So my take-home message for such presentation: minimal invasive spine surgery is a good option for most spinal pathologies. MIS can achieve the benefits of surgical management while avoiding some of its drawbacks. Steep learning curve till mastering the technique is the problem, but don't forget the conservative management you are dealing with patients. Thank you so much for your listening.
Thank you very much, Dr. Muhammad. I think we don't have questions now.
Yeah. Can I have a comment?
Yes, please.
Yes. Many thanks for
طلعت في الفيديو.
أنا طلعت في الفيديو.
My daughter is helping me.
I believe our dear Professor Hawari and Dr. Khattab and Dr. Sharif Al-Ghamri for this nice my advice for our colleagues is to start doing a transforaminal endoscopy, not just for a discectomy. Always you are going to do inside out. You dig your endoscopic cannula inside the disc, and you remove some disc materials, but you didn't see the epidural space or the traversing nerve root or the exiting nerve root. Actually, this is one of the very bad approach, and this is one of the bad scenarios with the transforaminal endoscopy. Another thing, I spent 2 years doing a transforaminal lateral approach. Transforaminal lateral approach, you need to find a patient with a wide foramen and low iliac crest to go directly. Just a foraminal disc or paracentral or central. You cannot do inferior migrated disc because they learn us that the foraminotomy and foraminoplasty for advanced courses. Actually, you should to learn foraminotomy and foraminoplasty from the start. Foraminoplasty and foraminotomy is the same, like when you do a posterior surgery, you will do a laminotomy and you remove a part from the ligamentum flavum to reach your disc space. You don't learn a laminotomy in the advanced cases. This is one of your first step. Okay, so the craniocaudal approach and the foraminotomy, that you widening your foramen and you see the traversing nerve root. This is one of the very successful approach. This is my advice. The next thing is the transforaminal approach. You get 2 birds with 1 bullet. You decompress the traversing nerve root and the exiting nerve root with only 1 snip, 1 centimeter in the lateral side of the patient. Okay, this is my advice. I hope all of you get some benefits from our professors, Dr. Salhin and Dr. Garcia and Professor Assous. And again, congratulations for the committee of the conference. Thank you.
Thank you so much, Dr. Hatem Hamdi, for your help and support. Actually, you are completely right, and I think the endoscopic era will come, and I think with once we can find, cheaper implants, I think it will be